Good morning, everybody. I declare open this hearing of the Community Affairs Legislation Committee into the Budget Estimates 2026-27. I begin by acknowledging the traditional custodians of the land on which we meet today and pay my respects to Elders past, present and emerging, and also extend that respect to Aboriginal and Torres Strait Islander people in the room or joining us online today. The committee has fixed Friday the 24th of July as the date for the return of answers to questions taken on notice, and the submission for questions is Friday the 12th of June. The committee proceedings today will begin with the Department of Health, Disability and Ageing in Outcome 2, Individual Health Benefits. The committee will be conducting today's hearing in person and via video conference. Under Standing Order 26, the committee must take all evidence in public session, and this includes answers to questions on notice. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. The Senate has endorsed the following test of relevance of questions at estimates hearing. Any questions going to the operation or financial positions of the department and agencies which are seeking funds and estimates are relevant questions for the purpose of estimates hearings. I remind officers that the Senate has resolved that there are no areas in connection with the expenditure of public funds where any person has a discretion to withhold details or explanations from the Parliament or its committees unless the Parliament has expressly provided otherwise. The Senate has resolved also that an officer of a department of the Commonwealth shall not be asked to give opinions on matters of policy and shall be given reasonable opportunity to refer questions asked of the officer to superior officers or to a minister. This resolution does not preclude questions asking for explanation of policies or factual questions about when and how policies were adopted. Witnesses are reminded of the Senate order specifying the process by which a claim of public interest immunity should be raised, and I incorporate the public interest immunity statement into the Hansard. I remind senators of their obligations under the Behaviour Code for Australian parliamentarians to treat witnesses with dignity, courtesy, fairness and respect. An officer called to answer a question for the first time should state their full name and the capacity in which they are appearing. I remind committee members and witnesses who are appearing via video conference and who are not speaking to keep themselves on mute. We have a live caption enabled for the duration of today's hearings. The feed will be displayed on selected video conferencing monitors at the witness bench, at the back of the room and also in the waiting room. We ask witnesses to please inform the Secretariat if at any time during the hearing you're experiencing any issues, and we'll endeavour to troubleshoot them as quickly as possible. I would now like to welcome Minister Katie Gallagher, Minister for Finance, Women, Government Services and Public Service, representing the Minister for Health, Disability and Ageing. Minister, would you care to make an opening statement?
No, thank you.
And thank you very much for stepping in this morning. We do really appreciate it. And welcome back to Mr Blair Comley, the Secretary of the Department of Health, Disability and Ageing. Would you care to make an opening statement?
Chair.
No? Okay. In which case, we shall roll straight into questions on Outcome 2, Individual Health Benefits, and I will go to Senator Ruston.
Thank you very much. I was wondering if I could have a chat about the budget decision in relation to the removal of the PHI rebate, additional subsidy or additional rebate to people over the age of 65. Mr Hawkins, is it you I'm directing my questions or Ms Street?
Far away, Senator.
Okay. So I'm just interested to understand exactly how many Australians do you believe will be impacted by this policy change?
Thank you, Senator. So Celia Street, Deputy Secretary for System Strategy Group. So we think that the figure that we've modelled is 0.4%, which is 44,000 would come off the private health insurance, and that's based on the year 2028-29.
Why are you using 28-29 figures?
Sorry, Senator, just to supplement Ms Street's advice. In the total, we think about 3.1 million people will be impacted by the rebate.
3.1 million?
3.1 million. The figure that Ms Street's just given you is those that we think that have the potential to drop off, that will kind of stop their coverage as part of PHI.
Okay. So why are you using 28-29 figures?
Yeah, thanks. We're using that year because we think that's going to be the most representative year in terms of people having that full year impact. So it comes in from the 1st of April 2027, and there'll
You're
be...
assuming it's going to come in on the 1st of April 2027?
The policy is...
Policy decision is
Is
based
the-
on that timeframe,
Yeah.
acknowledging that legislation has to pass
Yes.
Parliament.
Yeah, so we think that's going to be is more representative than, say, the previous year. So happy to, provide the figure in relation to the previous year.
Okay. So in your analysis of those 3.1 million people, how many of those people are currently based here?
Or am I just...
Just bring that figure up for you.
So I assume you mean based in Australia?
No, based here.
Based here.
Yeah.
Not based here. Based
Oh, I'm sorry.
here.
Based here. I thought you said based here too, and I was like,
Yeah, I want to talk about all the people living overseas.
Senator Pomeroy, Assistant Secretary, Portfolio Strategy Division, is that for over 65s on the base tier or overall numbers on the base tier?
Over 65.
That number currently is 3,431,874.
3 million
431,874.
431,800.
I'm sorry, that's overall 65 plus. Base tier is 2,875,193.
Okay, so we've got 2.8 million of 3.1 million are on the base tier.
Yes, Senator.
Okay. And of those 2.875 million, how many of them are pensioners?
So the model doesn't specifically identify income types. It only looks at their income. So we can't, the model itself doesn't.
Okay, so could we ask then how many of those 2.875 people are earning less than $55,000 a year?
So, Senator, we wouldn't have that information, so we can talk to you about the modelling that we've conducted, but we go firmly within the kind of base tier category, which is anything under 105,000.
So how can you possibly model the impact on the most vulnerable in our community if you don't know who they are?
Senator, we can talk to you about the modelling, we can talk to you about the broader kind of impact that we've done through this, but we've actually based it off of the thresholds that sit around PHI anyway. So we know, Mr McBride's give you the number of people that sit in under 105,000. Okay. And then we can just talk you through the process we've gone through and the kind of assessment that we've done, if that would be helpful.
Oh, yes, you will be. So according to National Seniors Australia, who we've spoken to about this, they estimate that of the people who will be impacted on this, around 55% of their members who were surveyed said that they were pensioners. Does that reconcile with your understanding? Have you bothered to at least investigate what it might be?
I think we'd have to look at what National Seniors, approach. If it's a self-sampled survey, we would, I don't know that there's anything more we can add.
Well, my question is, have you bothered to engage with National Seniors Australia on this policy?
So we're aware of the survey they did that came up with that figure. We've also been, looking at, we know those age 65 not receiving the pension, so we have a reasonable indication of what number of age pensioners will be. What we importantly don't have is then the breakdown from max rate pensioners to part rate pensioners, because obviously, I'm sure you know, part rate pensioners can have a house of unlimited value, up to almost $1 million in assets and a healthy income. So there is quite a divide between part rate pensioners and max rate pensioners, and we don't have that breakdown.
So I suppose the question is, have you done any analysis of your own on how many aged pensioners will be impacted?
So not beyond knowing how many of those aged 65 don't receive the age pension, so we know that. So that leaves you to a reasonable expected.
I'm sorry?
So we know how many people aged 65 plus don't get the age pension. And we
That's
know
it,
how many
as
people
a population-based statistic. As a population-based statistic, not.
Yep.
So are we talking about these numbers, or are we talking about the population?
So population, and we know how many people aged 65 are on the base tier. Mm-hmm. So there's a reasonable expectation that, look, the number of people on the age pension is a significant number. We can't narrow it down because we don't actually get data that supports that analysis, but it's a significant number. What we don't have, as I mentioned before, is the breakdown between part rate pensioners and max rate pensioners.
Okay. So you've got the number of people on some amount of pension.
So not as it connects to them having a PHI policy.
Okay, so in total, what's the percentage of Australians over the age of 65 that do not receive any pension?
So that's we estimate about 2.2 million.
About 40%.
What percentage?
About 40%.
So 40% of Australians over the age of 65 do not have any pension, so 60, by virtue of that, 60% of Australians over the age of 65 have some form of pension. Do we know from the general population statistics how many have part pension and how many have full pension of that 60%?
I don't have that number in front of me.
Probably a question for DSS.
Well, I'm just trying to get to the bottom, Minister, of...
Yeah, I understand, but I'm just saying you wouldn't expect health to come prepared with data on numbers of part pensioners.
Yeah. Well, okay, so reasonably 60% of the people could be impacted by this. Is that a reasonable assumption? 60% of pensioners or part pensioners could be impacted by this?
So pensioners will make decisions based on their own risk tolerance and things like that in terms of whether or not they want that private health insurance.
No, that was not my question.
So I don't believe I can say that the assumption is 60% would be.
Okay. So how many other policy changes has the government, has the Department of Health made where they have not directly considered the impact on vulnerable Australians?
So I don't think it's fair to say we haven't considered the impact. So the modelling we do looks at how people behave to price changes and other changes in private health insurance and how they will react to that. And based on that modelling, we think very few people will actually choose not to take out private health insurance because of the value proposition to them, with most people on average over 65 deriving far more in terms of private health insurance benefits than they pay in premium. So there's a strong value proposition for private health insurance for that age group. And so we think, and the impact on them of this measure will be modest. And the Minister has mentioned this, less than $1 a day in terms of less than $1 a day in terms of the impact of this measure on average on private health insurance recipients over the age of 65.
And if you remember, Senator Ruston, the money that would be generated through this is being completely offset and spent in aged care and additional $3 billion investment in aged care. I mean, I think I've had colleagues of yours saying that you can't spend unless you offset. We're trying to find ways to manage some of these big shifts in demand for services and find room within the budget.
So I think my point is it's not about whether older Australians keep their PHI or not, and I'll discuss that with you in a minute. But, I mean, does the department concede that when a person is on a pension, we want to make sure that we provide them with the consideration for the financial support from government that is appropriate. And it seems to me that we're talking about two different things. It's the impact that they experience in relation to price impact. I mean, whether they keep it or not is a matter we'll discuss in a minute. But what is the intent of this in relation to older Australians? I mean, do you actually understand the impact on the most vulnerable people in our community of this move? And what was the basis for your decision that in your impact analysis that you didn't think that older Australians were going to drop their private health insurance?
Okay. Well, can I just jump in there first and say that the government considered this and considered that the rebate and the support should be provided based on income, not on age. That is the decision we've taken. I think there's been some misreporting of this decision that has raised concerns that people no longer get a rebate. The change is on the additional rebate. Everyone will get the same rebate dependent on their income. We think that is a fair approach, and we are investing an additional $3 billion into delivering more aged care beds, which specifically targets older Australians to make sure that we've got the services that they need when they need it. And it has to be seen in conjunction with the effort we put in on cheaper medicines and on bulk billing, so that we are providing support in additional ways to those who may be on a part pension or a pension or not on a pension at all, to make sure that we are supporting people, with cost of living pressures. But this decision is based on how do we meet some of the costs that are coming at us on aged care in a way that the budget can afford. And we think the decision, and it was a government's decision, is the right one, to base the rebate for private health insurance based on income, whether you are 35 or 65.
So you made the comment that it's only $1 a day. I'm just interested to understand whether you think finding an extra $300+ would be difficult for somebody on a full pension.
So what I'd say is, the modelling that we've done is indicated that it will be $252 per year for people on base on Tier 1 and Tier 2,
Okay.
so not over 300.
Okay, so would you think that would be difficult for somebody on a pension to find over and above all the other cost of living expenses that they have?
I think that pensioners are making decisions in relation to their private health insurance and making decisions on the cost of it. Yes, it is an additional expense.
Which is why cheaper medicines, bulk billing, all the other investments are have to be seen as part of the decisions the government has made. And I don't know that you should be asking for opinions of public servants.
So what is the breakdown of the numbers across all policy levels of the, first of all, of the 301 million Australians who are impacted, and the 44,000 Australians...
3.1.
Sorry? What did I say?
301.
That's why Richard's here. What is the breakdown of the 3.1 million Australians over the age of 65 who have got private health insurance in terms of their levels, and what is the breakdown of the people that you think, and of the 44,000, what are their levels?
Dr. Nicholas Johnson, Assistant Secretary, Evidence and Research Division. So in 2028-29, there are, on base tier, 2,998,008 people over 65.
How many?
2,998,008.
In 28-29.
In 28-29, the year that's reflected in the impact analysis. On tier 1, there is 136,000.
No, sorry. I should have been more policy levels, so gold, silver, bronze. That's already in your impact analysis, yep.
Yeah, sorry. The forward estimates model doesn't consider those levels. It just looks at hospital and extras, but we might have that data.
So how on earth can you
have that.
cost it if you don't know what levels they're on?
The model considers the average premiums of the different classes of cover, and that methodology has been used by the forward estimates model for many years, and no modelling is perfectly accurate, but we're able to check, I guess, each year once the budget year is concluded to see what the actuals are, and this model is extremely accurate. It tends to be around about 1% variation the following year from what we had forecast it to be.
In terms of those age 65 plus, we do have a percentage breakdown. So 42.2% are on gold, 41.2% are on silver, 3.4% are on bronze, 1% are on basic, and 12.2% have general treatment only.
And that's based on existing data, so that won't be 28, 29.
So one would imagine it's not going to, well, if anything, you will see a drop from gold to silver as people, which is what we're already starting to see. So that breakdown, is that of people over the age of 65, or the breakdown more generally?
Over 65.
Over 65. Is that reflective of the general population in terms of how they hold their private health insurance?
No, it tends to be almost inverted. So younger people tend to have lower products, and older people tend to have higher value products.
Okay, so it would be reasonable to say from that analysis that people over the age of 65 are more likely to have gold cover.
Gold and silver.
Gold and silver, yep. Okay, thanks. An independent review of the Medicare levy subsidy, the PHI rebate, by Finity Consulting was provided to the government, and obviously to the department, in 2023, and it found that the additional PHI rebate for over 65s provides good value, and removing the age-based uplift would result in a declining value for government. Does the department believe that analysis is wrong?
So can I just say, Len, I'll get the team to talk through the differences between the methodology, but there was different methodology used between the Finity modelling and then the department's modelling. So the department, as we indicated, Dr Johnson mentioned the model that we've been using for the last 7 years, but I will refer to the team. We do acknowledge that it's different methodology, that what we've been really looking at in this measure is the impact on participation rates and the decisions that go into that. And our model gives us really good information in terms of what the likely price impact will be on participation and things like that. So what we were looking at was in terms of that impact on participation. But if I turn to the team, they'll be able to indicate the difference in the methodology used by Finity versus the department, and therefore they were answering different questions, Senator.
So, to be fair, I actually wasn't asking that question. I was asking, does the department believe that the Finity modelling is wrong?
No, Senator.
I think what Ms Street was saying was that it was asking a slightly different question, and that's what the team was about to explain, what the question they were asking and what the context is of that report, which is 3 years old.
So in broad terms, we came to a slightly different conclusion about the participation impact than Finity did, and I'm happy to explain why. But what Finity said was that because older people get more value and participate in private health insurance because of the rebate, it provides value for government. And we don't disagree with that. What we're saying is that in terms of if participation is your benchmark as to success, we can get those, or very close to those same participation outcomes without spending as much money on that rebate. And so we agree in principle in what they say, but we think that proposition still holds for what we're doing now because what we're doing will have such a minor impact on participation.
So you've done
rotate the call when you...
Yeah, so you've done a sensitivity analysis in terms of like price responsiveness of older Australians that you believe is different to the sensitivity analysis that's been used by Finity.
Marginally different, and I'll get Nick to explain what our model did. But to determine participation impact, Finity conducted a survey. What we've done is a different approach. Finity data is 3 or 4 years old. They had different assumptions about the breakdown across the tiers. So if you're correct for all of those things, we're not that far apart in terms of our expectation on the participation impact.
I would argue that you are a long way apart, that the amount of people who Finity predicted would leave the system is like 2.5 or over 2 times more than the predictions that you've made. So I'd first of all argue that there is a significant difference in the impact that you're projecting or predicting as opposed to Finity.
So Senator, I could talk about what methodology our model uses that gives us the confidence in the behavioural response that people have to the price changes. The forward estimates model, the affinity model surveyed people, and that was part of the input into their modelling outcome, whereas the department has got access to the actual data on how people do have behaved historically in response to price changes. So the model's quite sophisticated. It's a linear regression model that takes in a number of inputs and then uses statistical calculation to estimate how behaviour will change. So the inputs are, there's a demographic projection around as the age is changing and more people are moving into that 65 and over cohort. There are economic inputs around changes to CPI and other economic factors, average weekly earnings. And then there's, as I mentioned previously, there's a...
Can I just ask a question there,
sure.
Dr Johnson? Average weekly earnings are not something that is a strong component of people over the age of 65.
No, but it's part of the broader model, because this isn't a model for 65s and over. This is a model for the entirety of the rebate program.
Okay.
And so it's one of the economic inputs to the model that I was explaining.
I understand the rebate component of it, but we're not actually talking specifically about the rebate. We're talking about an additional incentive on top of the rebate to try and incentivise over 65s who, from your evidence, you've already admitted pay more into private health insurance than younger Australians, because you say that they're disproportionately got gold and silver cover, and it tends to be inverted. So they're already paying more, but we're actually talking only about over 65s in this policy measure.
So I was seeking to answer your question around what our model predicted and the difference to Finity. And so that's an economic input that feeds into how the model calculates behavioural change. And then there is a behavioural module that takes all those factors in, and then based on previous experience will forecast how people will change in their behaviour. And that change could be entering private health insurance where they didn't have it previously. It might be moving between a level, or it might be exiting private health insurance. And that's broken down across the income tiers and across demographics. And that modelling is what indicates that by 28, 29, we anticipate around 42,000 people fewer in private health insurance. So it's a different inputs and I think a rigour in the estimate than what the Finity model was able to do without access to that data.
So you've projected that it'll be 44,000 less people in private health insurance, but have you modelled the change in the levels of health insurance that they are likely to be on? So if you've got the breakdown that you've said here, 42 gold, 41 silver, 34 gold, etc., bronze. Have you modelled in that 44,000 people that currently sit on that ratio, what the ratio will be of the people that remain on private health insurance? How many of them will drop from gold to silver, etc., etc.? Is that modelled and costed in here?
The model doesn't include that degree of granularity in changing between levels. So this is the established forward estimates model for PHI rebates. It models whether people are on general only or combined or hospital only and the movements between those broader categories. That's what the model does for the purposes of forward estimates modelling.
Yeah, I get that in the broader...
So we'll need to rotate the call if you want to wrap that one up.
Okay, I was just going to say, in the broader sense, that's fine, but we're not talking about the broader sense. We're talking about the price responsiveness of older Australians, many of whom are on fixed income. So it sounds to me like what you said, the government's assumption is that older Australians will maintain the cover based on the fact that they're too frightened what happens to them if they don't have it.
I think it's, so if it might help us to look right out, I think the point he made earlier was, and he expressed it quite nicely, the value older people get from private health insurance is significant in an actuarial sense because we have community rating in Australia, and because we have community rating, the ratio of benefits tend to rise for age, and so we think that's the driving factor why there would be little substitution out of private health insurance for what is approximately an 8 percentage point change in the rebate for that cohort.
Okay, we'll come back to this. Thank you, Chair.
Thank you. Senator Steele-John.
Thanks very much, Chair. So I have some questions in regards to a question on notice that was asked to the department, and I've got the portfolio question number, if that's useful. It's DHA SQ26-001295. It was asked by my colleague, Senator Hodgins-May, regarding MECFS.
We're going to which effects, sorry, Senator Steele-John?
Sorry?
Just repeat which effects?
In regards to MECFS.
MECFS. Well, I'll correct it, sorry, yep.
Myalgic encephalomyelitis.
Yes. I'm intimately familiar with it. So.
Are we waiting for certain people to come? Ah, right, okay. No worries, no rush.
Good morning, Senator. Liz Devlin, Deputy Secretary at the Department. I might try to help you whilst my colleagues find their way here.
Okay, thank you very much, Doctor. The Department has advised that people with MECFS rely on general practice to access specialist allied health services and disability support, so this is referenced in your answer. Now, many people with MECFS require specialist services, often from multiple specialists and healthcare from multiple specialists, despite experiencing simultaneously significant loss in income due to the condition. They are often also affected so severely that they are unable to leave their homes in order to travel from the home to a specialist, or particularly in this case, a GP. And the combination of the loss of income and the inability to leave home can make the GP a hard thing to access in the first place, to then be able to get through to the specialist services through the referrals that you're given by a general practitioner. Many in the community describe this as effectively creating barriers for them to access Medicare-funded care. Now, this is a barrier for this particular community, but it is also a dynamic that exists for many people with chronic illness in our community. So my question is, has the government considered Medicare or service delivery reforms to address these barriers, and if so, what are the options under consideration?
Maybe I'll start and then throw to colleagues in terms of reforms, but the sort of situation you describe is certainly understood by the department, is very challenging. Obviously, what the government in the first instance is doing is trying to make financial barriers to accessing a GP through bulk billing reforms. There also can be access to telehealth, which is much more widely available than was in the past. I'll ask colleagues to say, I don't think we're intending to expand that. And so, of course, there are sometimes restrictions on when you must have had a physical appointment before you have a telehealth appointment. But they are the things that primarily are giving kind of access to GPs. And then beyond that, and the pathways that you're talking about, there is also a question of what will be specialist fees once you move in that direction. And the government's announced a number of intentions to look at specialist fees to reduce out-of-pocket expenses. I don't know if other colleagues want to comment, but I think that's the broad direction of the answer. But we do recognise that in cases like this, it is a pretty complex, particularly on the diagnostic pathway, often very complex.
It is, and just to pick you up on the telehealth point, which I acknowledge that is available, but again, there's a barrier in the fact that you have to have seen that GP in the last 12 months. And if you've been bedbound due to ME/CFS, as many people who experience it are, you're again stuck in this loop where you can't get access to the GP to even begin the journey of accessing then the specialist service.
Okay.
Senator Daniel McCabe, Assistant Secretary, Medicare Benefits and Digital Health. One of the other things that government has done is introduced the My Medicare program to allow patients to enrol and have a regular relationship with a practice. As part of that, that extends the time that you need to have a face-to-face appointment out to 2 years. So patients that are registered through My Medicare with their practice don't have to go into a practice physically in less than
for
2 years.
2 years.
2 years rather than 12 months.
But you still have to have seen that GP first and then you get the 2 year.
That's right.
So are there exceptions for people whose medical conditions prevent them from physically accessing a GP practice in person?
So the telehealth restrictions, exemptions are very narrow, Senator. They relate more to do with where people are impacted by natural disasters, sexually transmitted diseases and the like, but they are very limited at this point, Senator.
Yeah. And that... Sorry.
And GPs can also, and still do, perform home visits, Senator.
They do, sorry, what?
Perform home visits as well.
Yes, but there's not as many GPs that do that as access to practice more broadly. And I guess my concern is there are, on some estimates, upwards of 500,000 Australians who experience ME/CFS, and a subset of that grouping are literally unable to get out of bed, and the only way that we can, or indeed, they can, but then they are severely ill for months at a time. And I'm using that as a case study of a chronic illness because there are other conditions that require you to stay within your home. So is there any work being done on a chronic illness exemption to the requirement to see a GP before you can then see them in person, I should say, before you can then...
No, Senator, we're not doing anything specifically at the moment.
Okay. Minister, is this something that's under consideration at the kind of ministerial or political level with the government? Because it seems to be quite a gap in the system.
So I don't want to cut across the minister, but I do wonder whether this is something where the Chief Medical Officer could add something, because obviously the reason of having face-to-face consultation is not necessarily just put a barrier in the place, but because of the nature of the clinical care. If you wouldn't mind going to the CMO.
I'm happy for Professor Kidd to contribute.
Thank you. Thank you, Senator, and thank you for raising the issue, and particularly the issue for people with ME/CFS who are homebound, and as you mentioned, a significant number of those people are bedbound as well. It is important that people do receive healthcare face-to-face at least some of the time in order to pick up important medical conditions, in order to make sure that people are being appropriately assessed, and if people are unable to physically get to a general practice, then as we've heard, the option of home visits is available to some people. And once that home visit has occurred and a relationship exists between that general practitioner and that person, then it is safe and appropriate to provide telehealth services moving on. One of the other challenges is that some of these people, as you mentioned, would benefit from other specialist consultation, not just medical specialists, but particularly allied health professionals as well. You know, the multidisciplinary approach is so important. And some of these interactions are going to be most helpful if they're face-to-face as well, rather than through telehealth. I did want to mention, and I expect you know this already, but the National Health and Medical Research Council is developing new Australian guidelines for ME/CFS, for long COVID and for related conditions. And these guidelines are being developed in close consultation with people with lived experience to provide additional information to us about how best to deliver care.
Yeah, I understand that, Professor Giddens. Thank you for that. I've been keeping an eye on those guidelines and that process for a long time now. I think I agree with everything you've said around the value of in-person consults. I'm very familiar with the proposition and the need for them. What I'm sharing on behalf of the community today is that there is a cohort, there's a group of Australians for whom this is a barrier. Not an intended barrier, but they are either unable to leave their homes to begin that process, to then get potentially specialist care, to then potentially begin a recovery process. And so while it is all well and good to talk about the value of the in-person consult, that's not the proposition for them. They are unable to do that. So while it would be theoretically great, and you might be lucky enough to live in an area with a home visit GP, if you don't, you're currently stuck in a bit of a no man's land. And I think, again, this is not so much a policy question, but not so much a policy question as a political one. Surely, Minister, there's some work. I can't be the first one to have raised this gap, given the extent of chronic illness in Australia and this particular condition. So is there conversations at the ministerial level, at the cabinet level, about how we might open up a pathway for those that are homebound to access healthcare? Because at the moment, that's not an option if you can't leave your door and you don't live in an area with a GP that will come to you.
Senator Steele-John, I mean, Minister Butler and his team are in constant engagement with consumer organisations, stakeholder groups, looking at ways to make sure that healthcare is provided in a way that's accessible to everybody. But I can take that on notice. I don't really have anything further to add to what officials have provided already.
Okay. If you could take that on notice, that would be great. Moving on from, if you are lucky enough to be able to either live in an area where you have a GP come to your home, or you can either deal with the kind of post-exertion malaise impacts of chronic fatigue, or the other post-exertion kind of conditions that then develop. Say you are able to get to the GP and you are able to afford to engage in a consult. One of the other barriers that is then faced by the community is that because this is a complex condition that often co-occurs with other chronic illnesses, and at the moment the research that we have shows that it occurs within certain particular cohorts within the community at higher rates. All of this adds up, to put it simply, to a more complex conversation with your GP that then takes longer. And one of the things that I'm hearing really clearly from the community and also from general practitioners is that we could have an improvement in the quality of care for people with complex medical needs such as this if there was a increase to the Medicare rebate for consults that are of the longer type. Now, this matters to the patient cohort we're talking about here, the people in the community suffering the condition, but it also has a material impact on the general practitioner. We have a lucky situation where when we look at the demographic breakdown of those who are in general practice, we are looking at 50% or in some areas higher proportions being women. And we are seeing those folks are the ones currently that spend the longer time with the patient, despite the fact they're not compensated in terms of at an adequate rate for the longer consult. So to be quite direct, does the government have any plans to raise rebates for GP consults over 20 minutes?
Well, we've done that. The level E consultations, which are hour long, that's been done in a previous budget.
Which budget are you referring to be clear?
23, 24.
Yeah, 23, 24, there you go. I just knew it was a previous budget. I mean, we specifically looked at this, and including in relation to women, it was part of our consideration about women's health as well, that led to that. So we have done that.
So that's consults over an hour?
Well, it allows for a consult, yes. A consult of an hour.
But what about consults that are over 20 minutes?
Yes.
So, Senator, there are a couple of things that are in place today. We have GPs have access to chronic condition management plans, which pay a higher rebate because of the complexity and the time involved for patients with chronic conditions. That allows them to work with that patient, review that condition every 3 months, and that is paid, as I said, at a higher amount of money. We're also reviewing all of the GP time-tiered items through the Medicare Review Advisory Committee at the moment to have a look at how they are structured, the complexity of the items for GPs, and whether there's consideration on how longer consults are remunerated, Senator, and that advice will be given to government later this year.
Because at the moment we've got a situation where, while you may well have made that modification for categories E, if we're looking at C and D, there hasn't been change there, and that's the challenge for both the community member and the general practitioner, is that between 20 to 60 minutes there has been no change.
Penny Shakespeare, Deputy Secretary, Health Resourcing Group. There are higher rebates for Level C and Level D compared to Level B consults as well, and those are indexed on the 1st of July every year, so they have been increasing.
They're higher, but they haven't been increased. They're higher.
They get indexed and increase every year.
Yeah, indexation is different from the call that has been made quite clearly and consistently by the college for an increase to C and D consults beyond indexation.
As Mr McCabe has said, the rates for all time-tiered GP consultation items at the moment are being reviewed by the Medicare Benefit Schedule Advisory Committee, which will need to consider things like do we encourage longer consults? Does that then have a negative impact on access because we've got more people being seen for longer periods of time? GPs less able to see more patients. So these are complex things that do actually need to be considered properly.
Has the department undertaken any assessments of the barriers faced by people with ME/CFS or other chronic illnesses in obtaining specialist evidence often required for disability support applications, including barriers of financial burden for obtaining assessments and reports, and whether some of patients are effectively, which is what I'm seeing in the community, excluded from medical care because they're unable to attend the in-person appointment first?
Obviously, Senator, the access to disability support pension, or in fact pathways for job seeker or other payments, are a matter for Department of Social Services. We generally look at trying to ensure access to all medical services to the greatest extent possible without necessarily that link to those assessment processes.
Yes, but in terms of the broader Australian social safety net, there are many a program that requires you to have obtained specialist assessment before you can then access support. What I've been trying to flag with you today is that many people with this condition are stuck in a loop where, to get the additional support they need to get a specialist assessment. To be able to get that assessment, they need to be able to go to the GP. To be able to, once a year. Yep. For many people, that's not possible. So they are then stuck without the ability to go to the GP, to then get the referral to the specialist, to then get the assessment, to then get the support. So the question was, have you done any assessment as a department of what that looks like for the cohort of Australians stuck in that gap?
Look, we can take it on notice, but I don't think there's anything further we can add, Senator Steele-John. And you know, I took your earlier question on notice.
Okay. What about the financial gap here? Because again, income loss is a significant experience for this group of people. They are then in a position where, say, you're able to do your once a year trip to the GP, get the referral to the specialist, but then you cannot afford the gap between the specialist and the rebate, effectively preventing you from getting the assessment and then getting access to the support. Have you done any analysis of what that looks like in terms of a barrier for this community or others with...
There's a lot of analysis going on around specialist fees, and we've been clear about that.
Yeah, but specifically for chronically ill people. Well,
I mean, the issue you raised definitely affects that cohort of patients, but it has a much broader, you know, impact. And so, yes, I mean, I think the issues you raise will be picked up and worked through with the work that Minister Butler has already outlined.
So, Senator, we are, as the Minister has indicated, working through a number of reforms for specialist fees and especially dealing with the out-of-pocket costs. Our government has asked us to consult widely with not only doctor groups but also consumer groups. So as part of that process, we will be understanding some of the issues that you're bringing forward.
Thank you. Appreciate it, Ms McCabe. I think I'll probably reach my end of the block.
Thank you very much, Senator Steele-John. Senator Colbeck, did you have anything?
Senator Ruston's.
Timing's everything, isn't it?
Timing is everything.
We will go to Senator Ruston then.
Thank you. So if we could just continue on where we were. So just for some... Oh, sorry, I'll wait. Okay, so just to be clear, I just want to confirm on the record, you have said that older Australians are already paying more for their private health insurance because they are more likely to hold higher levels of cover. Is that correct?
Senator, I think you said that. I think we...
Oh, so, well, could you please tell me what you think?
At the moment, because they have a higher rebate, that wouldn't necessarily be the case. But on average, older Australians have higher levels of coverage.
So if they've got higher levels of coverage, would that not naturally mean that they pay more for their private health cover?
Not net of rebate, not necessarily.
Sorry?
Once you take the rebate off, because we have that inflated rebate for over 65s at the moment, that would not necessarily be the case at the moment.
Okay, so have you done any analysis to suggest that an increase in rebate of the rebate of 4% or potentially 7% if you're over 70 is actually greater than the difference between the collective higher levels of cover of older Australians? Is that what you're suggesting?
No, Senator, I'm just saying...
Well, older Australians over 65 to 70 get approximately 4% increase in the amount of rebate that they get compared with Australians under 65, and it's about 7% or so if you're over 70. You're telling me, from what I've just gathered from your comment, that 4% or 7% is greater than the additional amount of money that older Australians pay because of the skew in where they hold their private health in comparison to younger Australians. Is that what you're telling me?
I didn't say that, Senator. I said it wouldn't necessarily be the case that what you said is true because of the action of the rebate. So obviously you have people on all covers across all age groups. Older people have a higher level of cover in gold and silver plus, and absolutely accept that. But the rebate current rebate does dilute some of that.
Dilute some of it. You just said it diluted more than some of it. Does it dilute some of it, or is it actually greater than the amount? You told me that there is a skew.
Yes.
disproportionate skew on the number of older Australians who hold gold and silver cover in comparison to younger Australians who have lower levels of cover. You said that to me.
So I think if we put aside the rebate...
No, just tell me about how they hold their cover.
Allow the official to answer.
If we put aside the rebate for a moment, older people's premiums before the rebate, on average, would be higher by virtue of the fact that they hold higher level products.
Right, okay. So that's where we started. So my question is to you, well, first of all, what is the magnitude of that?
How would you measure magnitude? Senator?
Well, so on average, you've got here, 42% people have gold, 41% silver of people over the age of 65. What are those percentages for people under the age of 65?
I don't think we have it as percentages.
No, we've got the actual... I mean, if it's helpful, Senator, we can give you kind of average premium numbers of what it would be for under 65, over 65 and 70, if that would be helpful, of what the average payment would be, and that way you can compare a like-for-like comparison.
All I'm trying to establish is older Australians are more likely to hold gold cover.
Correct.
Yes.
Gold cover is way, way more expensive than bronze or basic cover.
Correct.
Multiples. And older Australians require this because of the things that are included in gold cover.
Correct.
Include things like joint replacements and cataract operations, things that aren't disproportionately likely to be things that older Australians are likely to need. Is that correct?
Yeah.
So,
sorry,
I'm not...
Sorry, it is complicated a little bit by maternity.
Yes.
Because a lot of gold
And mental,
I understand
is bundled by...
mental health.
Yeah, and mental
health.
Yeah, understand that. But, the two big ticket items for older Australians are obviously joint replacements and cataract that sits within gold. So I'm just trying to understand is there a significant proportion of older Australians that hold gold in comparison to younger Australians?
Yes, Senator.
Okay, so I'm just trying to get to the point that it actually, whilst the additional rebate is an additional incentive for older Australians to continue to hold private health insurance, it would go no way to being more than the additional amount that they are paying to hold their cover in higher levels of cover.
Senator, I'm not sure if this might help, but when it comes to over 70 plus, those on the base tier, the average premium after the rebate for gold is $2,610. Now, that is in comparison then to the average benefit paid by insurers to the over 70s, which is $5,099.
It's a very useful statistic.
Thank you, Senator.
Very useful statistic. Okay, I think we've established where we need to go, so thank you. That was very useful. So can I just also confirm that no analysis has been done on the impact of downgrades?
So, Senator, the model, as I mentioned earlier, looks at not the gold, silver, bronze levels, but looks at the insurance type as far as hospital or extras or no insurance. And that's partly because there isn't a consistent applying of what that means to be gold and silver across the insurers, and there are differences in those premiums. And so for the purpose of the modelling, it's very difficult in order to factor in that when we're doing our estimates variation. So the answer is no, the model captures estimated premiums based on the actual claims data we receive from Services Australia. So we receive that, but the model does not then seek to estimate whether people, to what degree they will move between the levels of cover. Instead, it will look to see whether people's behaviour will change by taking up private health insurance, moving to combined cover, or vice versa.
Okay, so you've just said that you have done no analysis of downgrades.
The model that is used, we do analyse product holdings, and we do it based on APRA data, so outside the model that Dr. Johnson was speaking to. And as I mentioned earlier on, there is a concentration particularly for over 65s in gold and silver, and that is held historically. There has been a drift from gold to silver, to silver plus in particular. But below silver, we go from 41% to 3% for bronze and 1% for basic, because the value proposition that we mentioned before, and Mr. Hawkins just put numbers against, is so strong for senior Australians that dropping below silver would dilute that value proposition. So at the moment they pay far less in premiums than they get in benefits, but to take advantage of those benefits they need a type of coverage, and that's generally in the gold, silver or silver plus categories. And some of the silver plus categories are now offering things that used to only be available in gold, so it's a logical choice for seniors to downgrade to a silver plus cover so they don't have to pay the price premium of gold that is inflated a little bit at the moment due to the pressures of maternity and psych.
So can you just explain to me so your explanation of why they have more value is, maybe in your own words, so I'm not there. So explain to me why you think older Australians think there is more value in private health insurance than younger Australians.
Because for younger Australians, they pay more in premiums than they derive in benefits. That is flipped once you're over 65 on average, where you derive far more in benefits paid out from insurers than you pay in premiums.
Senator, it's a fundamental feature of the system. Because we have community rating, we're
going to get to that.
We do not allow insurers to risk rate, with the exception of the lifetime premium. So
we'll get to that.
That's fundamental.
So the data point, Senator, from what I mentioned about the benefit that an over 70 would derive from the system, under 65, the average benefit paid is $826. So that's $826 compared to an over 70-year-old that is $5,099.
Yes.
So you can see the benefit derived significantly the older that you are.
So you're talking about value and benefit on the basis of dollars.
Correct.
Have you factored any value into this in terms of the emotional value to older Australians?
So what I'd say is, as Dr. Johnson has indicated, we do have that behavioural element in the model. You won't necessarily go to that specific value, but I'll pass to Dr. Johnson.
Yeah, so we're not able to model the other benefits that health insurance might provide the community around assurances and feeling assured that they can receive the healthcare they require. The model can really just look at how people on aggregate behave in response to changes, and what the model suggests is these changes elicit a very minor behavioural response, which based on historical data, so how people have changed previously to change in these parameters. And that, I think what Mr McBride is suggesting indicates that while we can't understand exactly why each person makes that decision, clearly their behaviour is that they seek to, in the main, retain their private health cover, and they are deriving a significant financial benefit from it. But those are the numbers that we have available for the purpose of modelling, so I couldn't comment further on the motivations or why people are retaining it from the modelling.
But I mean, I would have thought that behavioural analysis on something as important as this would have been an important element of your analysis as to how people are likely to respond. Because,
but Senator, it requires the model is only as beneficial as the data that can be fed into it. So we don't have a data input that talks about people's feelings towards the cover. We only have data inputs that talk about people's propensity to take up or to leave private health insurance.
Yeah.
But Senator, perhaps, there's no one piece of analysis that leads you to the overall conclusion. The model that's being talked about there is the historical model that calibrates for factors that could drive behaviour and changes, and that's what the historical issue. The data that the other officers are talking about looks at essentially what the financial benefits are of different tiers. So we have done analysis of different tiers against the benefits they are. Now that is essentially, you could think about that, and obviously for different individuals, the actual payout they're going to get changes. So that's really what we would talk about as the expected payout if they had access to their data. And then you were quite right, there's a number of range of other reasons that people will hold these, and including habits and persistence, etc. And we take that into account. But it's not all agglomerated into kind of one magic model. They're all aspects of the problem that we bring to bear in thinking about the policy question of whether there's likely to be behavioural change.
So do you concede that emotional value is part of behavioural response?
Sorry, Sally, can you repeat
So
the question?
do you concede that emotional value is part of a behaviour, it would be part of the behavioural response of older Australians to this policy measure? Is that conceded by your model?
The model... Sorry, Secretary.
The point we're trying to make is the model being talked about doesn't try to capture that. It's the historical from the numbers of what people actually do. Do we agree that people's perceptions and emotions affect their behavioural response to a broad range of policies? Yes. In the same way, across other areas of health, we know that people respond to high-profile individual events more than they do to kind of aggregate dispersed risks. So they are all the things that we'd be taking into account when we're considering a policy like this.
Okay, so I'll go back and get your exact words, but you have basically just said that you don't take into account the emotional value when you...
No, I did not say that's exactly...
All right, well, I'll dig it up.
That is exactly what I
I'm
did
happy
not
to
say.
move on. I'm happy to move on, but I will dig it up.
Don't verbal.
I think it's a very important point, Senator Ruston. The idea that one quantitative model of any particular type is the definitive answer to a policy question is not how we would approach virtually anything within this portfolio.
Okay, so can I ask another question then? If older Australians drop out of private health care, it will shift the cost of that care to the public system. Is that a fair?
So I would say that people on private health insurance still use the public system. So, for example, going to the emergency department. So it is a mixed model in terms of the use of public and private right now. In terms of whether or not that shift will happen to public, yes, but we also assume that people that make a decision to come out of private health insurance or to downgrade are potentially those people that are less likely to be using their private health insurance at the moment. So there's a number of factors that come into play there, Senator.
And it's also the case that some people will self-fund, notwithstanding the fact that they don't have...
I'm sorry.
Some people will self-fund into private care, notwithstanding the fact that they don't have private health insurance for low-value care items. Not value care, low price points. So day procedures and things like that, they may still pay for themselves, notwithstanding the fact that they don't have private health insurance.
So, Mr McWright, are you contending that a pensioner would be able to afford to privately fund themselves into...
Witnesses. I mean, that
I'm
is
asking
not,
a question,
that is not the
Minister.
evidence you just heard. What you heard was there is a range of reasons, including you currently using the public system or choosing to privately fund arrangements. There are a range of responses. That's what the evidence you just heard, not what you just put to the committee.
I was actually asking for clarification, Minister.
So for some pensioners, they may drop their private health insurance, which is, say, $2,500, $3,000 a year, but they may still fund minor procedures in private hospitals at a price point lower than that. That may be their choice.
So have you modelled that likely response, the response that people will drop out and fund themselves?
You've heard what the health department has modelled. We've been through that this morning.
Well, could you clarify for me? Maybe I didn't hear that. Have you modelled the likelihood of people who drop out actually self-funding? So, have you analysed the cost of the shift of this change on the public health system?
So we've looked at, so Ms Street mentioned before that in 28-29, 44,000 fewer people had private health insurance than otherwise would have had it. over that time, the number of people on private health insurance will still grow, and the number of people on private health insurance who are over 65 will continue to grow. So it's not a reduction in the numbers of private health insurance, it's a reduction in the growth of the numbers of private health insurance. Notwithstanding that, the growth will be lower than it would have otherwise been if those whole 44,000 people went to public hospitals, and we don't think they would, then that would represent less than a 1% increase in public hospitals. The reason why we don't think they would is that some people will self-fund, and some people would have gone through the public system anyway if they went through accident and emergency, and some people would have chosen public provision of care anyway.
Okay.
And we'll rotate once if you want to wrap up a question.
So the simple question is, have you modelled the impact to the public health system of this policy change?
Well, he's just answered that.
No, he hasn't,
yes,
Minister.
Yes, he has.
Yes. Okay, well,
that's
could
the
you
evidence
answer
that if everybody, so private health insurance membership continues to grow over time. It grows slightly less, in the order of about 44,000, and if every one of those 44,000 became unwell and went to a public hospital, all of them in 1 year, and there was no other factors, then there would be a very modest increase in public hospital activity. Now, that is obviously extremely unlikely to occur, wouldn't occur. So that's the evidence that you've been given today.
Yeah. So my question then, to follow on from what you've just said, Minister, is could you provide me with what that actual impact is? I mean, you're saying it's only going to be modest, but I mean, I think it's only going to be modest.
Less than 1%. If every one of those
less than 1% of what is less than 1%?
Of public hospital activity overall.
Okay. So
but just
where is that? Is that? Take
it on notice, Senator, but I think I just want to emphasise that's if every single one of them would have used private rather than public, would all go to the hospital in 1 year, and none of them would self-insure at that point in time.
Or would have gone to public anyway.
Yeah. So we will take on notice what we can provide to provide you greater evidence than that, but you would have to heavily discount even that high level number.
And in this budget, if we get back to the budget, it has an extra almost $20 billion, actually higher, I think, in investment in public hospitals to support increased activity in public hospitals. It's got the Medicare urgent care clinics funded in perpetuity. It's got billions of dollars of new investment in new medicines that are cheaper than they've been for a decade. We are coming at how we meet the needs in the health system from every different angle, and including all of the money that would be generated from this change, this modest change to private health rebate, which essentially aligns it on income, not age, with everything we've heard about usage and benefits, etc., is going into building more aged care beds specifically for the generation that this age group that this affects, because we need to meet the costs that are coming at us in relation to aged care, and we have to do it in a way that the budget can afford.
Okay.
Senator, it's helpful. Mr McBride mentioned that we anticipate the number of insured people over 65 will grow. I can give you the numbers of what we have modelled for this year up to into 28, 29, if that's helpful.
Look, I mean, it's a useful piece of data, but quite frankly, I'm just trying to understand the impact of this particular policy measure in isolation. I mean, the Affinity report says that there is a cost transfer associated with a measure to take away this particular additional rebate. There is a cost transfer from one place to another, and I'm just really interested to understand if you have modelled that cost transfer. But, to be fair, what this sounds like is that we...
And Senator Russell, we are going to rotate the call.
I'm happy to shut up after I've said this. It sounds like you're holding older Australians hostage. They desperately need their cover because, by your evidence, they are more likely to draw on their health cover, and they are emotionally hold far greater value of their health cover because they're scared of their need for access to the health system. So you're banking on them being too scared to drop it. So
that's not.
Senator Ruston,
that is
that's
not
a fair
what you've heard this
characterisation.
morning, and completely reject your remarks just then. That is not what you've heard.
Well, when a pension is
So we are going to
well-
rotate the call now to Senator Steele, John, and we'll come back to you.
Thanks, Chair. So if we look at the 2026-27 budget, one of the things that has been done here is a $126 million allocation for Medicare-funded 3-year-old health assessments and an expansion of the Comprehensive Health Assessment Program as part of the Thriving Kids program. So my first question is, will the 3-year health assessment be used to determine eligibility for the Thriving Kids program?
So, Senator, the answer is no, but my more general procedural point, I'm in the hands of the chair here, is I think if we're going to the question of eligibility into the disability system, then that would be estimates on Friday.
Yes, well, that's a very interesting point, Secretary, because we're not quite sure where Thriving Kids sits. But my questions are predominantly about the 3-year health assessment program.
I'm happy to take questions on the 3-year health assessment,
yeah.
but I think if we get to the question, is it being used as an eligibility funnel into Thriving Kids or any other program of disability, the answer is no.
That's great. You've given that answer. That's fabulous. Okay, thank you. Who will be able to deliver these health assessments?
So, Senator, these health assessments will be performed by GPs, but the GPs can be supported by their practice nurses as part of that health assessment.
Okay. And how will the details of the 3-year-old health assessment then be developed?
So we've had, which my colleague can talk to a bit more on, a expert group come together to have a look at the literature for what we need to do for a 3-year-old health check, and that has been developed.
Louise Riley, Assistant Secretary, MBS Policy and Reviews Branch. Thanks, Senator. We had established an implementation liaison group to work up the requirements for the 3-year-old health check. That included someone from the AMA, someone from RACGP. I'd have to check who else. I have a feeling it was ACRM, practice nurses, but I can provide that on notice if you wish.
If you could provide on notice, that would be great. So that was a group that you have got together.
Yes.
Is it so that group is now to undertake that work, or that work has been complete?
It's largely been completed, Senator. So they've developed up, an item descriptor, what the requirements of the item are. It's important to note that the 3-year-old health check will use existing time-tiered health assessment items. So there already exists in the MBS a set of health assessment items that go from a short health assessment to a long one. And so 3-year-olds will become another eligible group of patients who can access those items.
Right, and that's for we're talking here about the 3-year-old health assessment.
Yes.
They've been doing work on that.
Yes.
That piece. So have they also been doing work on the comprehensive health assessment program?
So the CHAP tool, Senator?
Yeah, that was flagged in the budget on page 126.
So, Senator, that's been largely led by colleagues in Primary Health Care Division.
Okay, have we got folks from Primary Health Care Division that can come and talk to us about that?
Senator, that comprehensive health assessment is actually sitting with our disability colleagues who are not here until Friday.
Ah, okay, so the disability colleagues, right.
Yeah, so we moved that, as Mr Connolly talked about, as part of our broader Thriving Kids work, which is sitting in the disability team.
So it sits with the team but still within the department, but
Yes.
the team within the department, and they will appear on, they're scheduled to appear on Friday?
That's correct.
Okay, so staying then with the 3-year-old health assessment, which you can answer questions about
Yes.
now. Okay, thank you. These are the kind of confusions that we get into when these programs are devolved and shifted. So you've spoke to us about how the details of the 3-year-old health assessment will be developed. You've said there's been a team of people brought together representing different organisations. Was there an organisation involved in that consultation that was there from a disability health perspective?
So, Senator, there wasn't specifically, recognising that for the 3-year-old health check, it's available to every 3-year-old in Australia.
Yeah.
So, Senator, it's probably just important to note that the recommendation to establish the 3-year-old health check came out of the Minister's Expert Advisory Committee on Thriving Kids, which included disability advocates and advisors as well.
Yeah. So that was a recommendation that came out of that committee.
Yes.
But that sits here in this division of the health department, even though it came out of the Thriving Kids recommendation?
That's correct.
Okay. But there wasn't a even though it was a Thriving Kids recommendation, there wasn't a specific disability health stakeholder involved on that consultation group.
No, but Senator, there was the GP, like I can remember from memory, the GPs that did it were like the special interest childhood people, for example, from the RACGP.
In fact, I think, Senator, and Ms Wiley might correct me, but the GP that was involved in the development of the 3-year-old health check was involved in the Expert Advisory Committee with the disability advocates, the early childhood advocates and experts as well.
So they were involved in that broader work.
So there's cross-pollinisation from the Expert Advisory Committee.
But there wasn't, just to be clear though, that there wasn't disabled people's representative organisations or disability-specific health experts involved in that consultation for the 3-year assessment?
No, we did have a paediatrician from, again, Senator, I'd have to check, I think she was from Monash Hospital, who has a special interest in children. She participated on the ILG. And, sorry, the team's just sent me through, so I can tell you we had representatives from the AMA, the RACGP, Australian College of Rural and Remote Medicine, Practice Nurses Association, the National Aboriginal and Torres Strait Islander health workers, and the paediatrician I was just referring to.
Okay. Now, the Royal College of General Practitioners were calling for annual developmental checks in the run-up to the budget across the first 2,000 days of a child's life. Was there consideration by the government of a similar approach to this so that the child's progress can be tracked across that period of time rather than just basically having a snapshot at a singular point in time?
So, Senator, I think all the work that we've done in this space was focused at children from 0 right through to 8. In the context of primary care, I guess our discussions have been focused around leveraging their existing time-tiered items, using every opportunity when they're seeing a child to work through any developmental concerns. Government is also investing in a national children's health record as well, that GPs and other professionals will be able to use to update and record progress notes. But the 3-year-old health check was a specific recommendation to make sure that we had a safety net for all children by the time they turn 3, if they weren't seeing health professionals or child maternal services earlier.
I understand that. The problem though is you're getting a snapshot rather than the kind of more comprehensive picture that was recommended by the experts.
So, Senator, as part of the work that we're doing on the Children's Health Record, we are working with the College of GPs, disability groups, states and territories to have a look at all of the key milestones for children from 0 right through to 8, and we'll be making sure that we have mechanisms to capture all of those key developmental milestones. But government's made a specific decision to fund the 3-year-old health check, as I said, as a really important safety net for all children.
But that certainly doesn't prevent the child having consultations with the GP on a more regular basis. They would be funded through Medicare under normal time-tiered items.
No, I very much understand that. When Minister Butler initially announced Thriving Kids, and I'm mentioning it because we're talking about a recommendation of the working group around Thriving Kids, he said that the government would look at new Medicare items for allied health, including occupational therapy, speech pathology, psychology, psychosocial therapy, as part of the broader Thriving Kids program. We haven't seen any of these Medicare items yet. Are they on their way?
So, Senator, the government looked at a range of options for how we could best use the Medicare system and allied health professionals, but government has focused on working with states and territories to establish services for children as part of the Thriving Kids program, and that's where most of the effort and investment is going to be focused.
No, I understand that. I'm just referring back to the Minister's press club address, where there was a number of other areas.
We canvassed a whole range of options through the expert advisory committee, Senator. Including
and you canvassed them, and then this is the result. The result is this 3 year.
Government has made decisions.
So no speech pathology, no other Medicare items.
So those services are available in Medicare today and will be available to children that need them. But also, Senator, and it's probably better discussed on Friday with my disability colleagues, a lot of the focus will be developing and commissioning services through states and territories to support all of those types of supports.
So hang on, I'm a bit confused. So the Minister was untruthful at the press club about...
No, Senator, he wasn't untruthful. At the press club, which now I'm just trying to remember the exact date, was probably August last year, the Minister put out what he thought at the time was his hypothesis as to what the system would evolve. There was subsequently both the Overclade Committee but also the negotiation with the states and territories. In the negotiations with the states and territories, there was a consideration of the value of these allied health services and what the relative priority of those at this point was compared with what would be commissioned through what is known as the Thriving Kids program. So at the moment, the government is still considering whether it would have such items in the future, but the clear feedback, for example, from states and territories was that the priority was to set up the Thriving Kids program, which is commissioned. That itself may involve some of these allied health activities, but it also may involve other support such as parenting groups, group activities, etc. But perhaps we could, so the Minister was putting out his ideas at the time. There was an engagement with states and territories, there's the Overclade Committee, and at this stage the 3-year-old health check is the thing the government is proceeding with.
Yeah, but again, the Thriving Kids is for kids up to like 8 or 9, and we still have this quite significant gap. What are people over the age of 8 or 9 meant to do in terms of speech pathology, for example?
So, Senator, if I can go to that, you'll recall that we recently added severe speech and language disorders to a group of Medicare items that enable a GP to refer a child with severe speech and language disorders to a speech pathologist, and they can receive up to 8 assessment services and up to 20 treatment services as well.
It is wild. I think this is why there is such high levels of confusion and distrust in the community in relation to what the government is doing in this space, because, to be quite frank, when the Health Minister, who is also the Disability Minister, who is also the NDIA Minister, steps up at the National Press Club and talks about what the program will deliver, there is an assumption that they're talking about what the government will then deliver, not that he's riffing on his broader vibes of what should be included.
If you read the speech...
Oh, I read it.
Yeah,
and,
sure.
And watched
and
it.
as I recall it...
Many
times.
times.
Minister Butler also outlined the need to consult further and work with the states and territories. We have been very clear about that. Now, you just asked what's happening about, speech therapy for a cohort, and you got the answer of what the government has done already. So you can't just brush over that because it was an inconvenient answer.
I'm familiar with that program.
What have you done? Well,
I'm familiar with that program, though, and I believe it's about 20 sessions per year. Is that correct?
So, Senator, it's 8 assessment sessions, up to 8, and up to 20 per lifetime, recognising
across the lifetime.
Recognising, Senator, that those people can continue to access speech therapy through a chronic condition management plan, which renews every year.
20 across somebody's lifetime, you know?
And in addition, if you listen to the evidence, can access further. Well, no, but you're just because it's not a convenient answer to you. You're ignoring the evidence.
I'm trying to give folks the benefit of the doubt, but okay. It is an area of policy I'm very familiar with. 20 sessions across a lifetime is nowhere near enough. The additions that you can then access through the chronic disease management plan also leaves a significant portion of those who require speech pathology without access to the intensity of support that is needed either through life or at particular stages of the development of speech and communication capability, particularly those who are neurodivergent or autistic. Everybody that knows anything about this area of policy kind of knows that, so I didn't really pick us up on it because we should have better things to do. But you all know that's not sufficient, and I think I'll just leave that there.
Well, okay. Thank you, Senator Steele. John? Did you have anything else you want to add? No. We'll go to Senator Pocock.
Thank you, Chair. I've got some questions about bulk billing and then just a couple of PBS issues. I was looking at the bulk billing rate of GP services in the ACT for the most recent quarter. So we're up to 54.1%.
54.1.
Yeah, up about 1% from the previous quarter, which...
Was it 1.2 or around 1%? Yeah, it was a modest increase.
Yeah, much smaller than other states, but at least it's
heading
1%.
in the right direction. Yep.
But the most alarming thing looking at the data is that the average bill for each service has gone up by $13.96 in the ACT in just one quarter. And so my team actually went back and looked over the history of the quarterly statistics that the department provides, and that seems to be the largest increase ever, the largest quarterly increase ever to the average bill for each service. And the average gap for patients has gone up $5.80. Again, one of the biggest increases on record for a single quarter. So what's going on here? Why are we seeing this huge jump in costs here in the ACT?
Senator, I can give you some hypotheses about what's happening there. So we have had some practices in the ACT switch across to the bulk billing incentive program. They, based on modelling that we undertook in the development of the bulk billing incentives reforms and the bulk billing incentive program, were probably the ones that were closer to, had lower charges and were more likely to benefit financially switching across to full bulk billing. So the average out-of-pocket cost may be affected by the fact that we've had practices that were charging lower out-of-pocket costs to some patients, moving across to fully bulk billing, so they're no longer appearing in those statistics. I think that probably the main reason, though, is decisions of practices about what they charge and, increases that they have decided to make, and potentially recognising that we are in a high inflation environment at the moment. So the government knows that we have particular issues around bulk billing in the ACT and is making particular investments to provide bulk billing options for people in the ACT. And I might ask my colleagues to talk a little bit about how those grant processes are going.
I've got some questions in a bit to get a bit more of an update on them, if that's all right. And so, Ms. Shakespeare, do you think that that's what's happening across the country? Because if you look at the stats, there's also been big increases in the gap fees for people who aren't bulk billed over the last quarter. And so you think it's the lower gap fee charging practices becoming bulk billed, and so you have this jump on average?
I think that's probably contributing to it. Things have been in place for a fairly small period of time, so want to be careful about being very definitive about what's going on there. We have started developing measures, though, looking at the average out-of-pocket cost across the entire population to ensure that the bulk billing reforms are having the intended impact, and we have seen, when you take the entire population into account, a small reduction in the overall out-of-pocket payments. But for those that are not being bulk billed, the out-of-pocket cost is increasing.
So for the rest of the country, the bulk billing rate is generally above 70%. New South Wales, it's 85%. But here in the ACT, we're just over 50%. So an increase in gaps hits a relatively large population. Do you think that these gap fees are going to continue to rise, or do you think we've sort of adjusted for the change in bulk billing, fully bulk billing clinics, and we'll see that stabilise now? What does the department expect?
I'm not sure that we can give you an expectation. What we are working on is trying to provide options for bulk billed services across the country, particularly in the ACT, where we know that there is less choice.
And so we're still on track to have the 3 bulk billing clinics open on 30th of June?
Senator Mark Rodham, First Assistant Secretary, Primary Care Division. Yes, I'm really pleased to tell you 3 clinics will open this month. Macquarie General Practice is establishing a clinic in Gungahlin. Next Practice Deakin is establishing a clinic in South Tuggeranong, and Oka Health will have a clinic in Molonglo by November 2026, but in the interim was opening an interim site in Woden until that clinic is ready in Molonglo.
And how many GPs will be at those clinics?
The target for those is 30, around 10 per clinic. I would
FTE or head count?
I believe that's FT, but I can provide that on notice.
Yeah. And thank you.
And we've got the
that's good to know.
Medicare urgent care clinic that's opened as well,
Indeed, yeah.
seeing a lot of people.
And could I get an update on the number of clinics participating in the PIP for Bean, Canberra and Fenner? I've got the 1 Jan 2026 figures, but do you have something more recent?
Yeah, as of Joe DeRocha, Assistant Secretary, My Medicare and Bulk Billing Clinics. As of the 27th of May, it is 20 clinics.
20, and how's that broken down across the 3 electorates?
Oh, I don't have that detail.
Yeah. I'm sure we can take it on
notice.
Yeah,
I can ask our colleagues at Services Australia and get back to you on notice.
And how do you expect the 3 clinics to affect our bulk billing rate? It's clearly such an outlier nationally.
Well, I think it puts, it's an important intervention in the market, Senator, to provide those bulk billing options and encourage other clinics to move to bulk billing as well, which we are seeing in the ACT.
And so those 3 clinics those doctors will have no existing lists, and it'll be totally new, or will they essentially just transition?
I don't know definitive about that, Senator. The idea is to recruit new GPs to the ACT, but I'd need to provide that sort of detail on notice.
And how are we doing that? I hear all the time that our being a MMM1 makes it hard to recruit new doctors here. Despite that, I've been told many times that changing the MM1 won't have an impact, but that's not what I hear from clinics. So how are we doing that?
The successful tenderers for the 3 clinics are organisations that have substantial networks into the general practice community. I would anticipate they are using them to recruit general practitioners as well, but we continue to look at ways to attract GPs.
And they will be additional?
It's additionality is what we're
to the ACT?
What we're providing the financial support for. And when I spoke to a couple of those providers, and indeed the way the Medicare urgent care clinic in Woden is operating, they are looking at a mix of attracting new and also providing sessional opportunities for GPs that might not be wanting to work, take on a full-time caseload, of which has always been an issue here in the ACT of having a reasonable workforce just not necessarily working in general practice, and they think there's a level of kind of attractiveness about that. When I spoke to the operators, they did not seem overly concerned about not being able to fill that additionality, but we do have to watch how it rolls out. And the other thing is, like, we will watch what happens here. This budget also has a similar response. I think it's the Central Coast and the Hunter region, who's facing they face kind of the same issues that we're seeing here in the ACT. So where we're seeing the bulk billing rate not respond, we are kind of trying to essentially intervene into the market, is what we're doing.
Thank you, Minister. It's a welcome investment. Just finally on the PIP, do you know how many of those practices have closed their books?
No, sorry, Senator, we don't have that.
Could you get that on notice?
We can try. I'm not sure that that's collected.
Okay. Because the thing I've heard from a bunch of Canberrans is basically impossible to get into these fully bulk billed clinics because doctors have basically just said we're not taking on new patients.
Yeah, what we collect through Services Australia is the number of clinics that have registered for the bulk billing practice incentive programs and those who might unregister.
Sure.
We don't know the reason that they might decide to not continue with their registration.
Thank
Certainly
you.
some of the newly established clinics, Senator, so you would not expect them to have their books closed.
Sure. Great. That's good to know. And then just finally on these two PBS issues, the first is about Zoladex. And as I understand it, AstraZeneca has made the decision not to supply Zoladex 3.6 milligrams, which I understand is for the treatment of breast cancer. But they have decided to continue to supply the dosage that is used for prostate cancer. And that just seems ridiculous to me. This is obviously a decision of AstraZeneca, and I've heard from a Canberran who's living with stage 4 breast cancer, and I believe the department has met with this person, and I really thank you for your engagement. Clearly very disappointing decision by AstraZeneca. Do you know how many patients are relying on Zoladex 3.6 milligrams?
Senator, I'll ask my colleagues if they know how many patients received scripts for those. That might be something we need to take on notice. But let me reassure you that we are looking for other GnRH agonists. So Zoladex is one type that's currently available on the PBS, but there are other companies that have TGA registered GnRH agonists, and we are working with other companies to try and find a replacement for the Australian PBS market.
Thank you, Mr. Shakespeare. And if you can take the first part of that on notice then.
I've got that now, Senator, if you would like.
Okay.
So Rebecca Richardson, Technology Assessment and Access Division. So in 2025, there was just over 94,000 scripts dispensed for the 3.6 milligram presentation. It's a monthly script, so that translates to about 7,800 patients.
Wow. Okay, thank you. And
Duncan McIntyre, First Assistant Secretary, Technology Assessment and Access Division. Just to note that Zoladex 3.6 milligram is prescribed for a number of different types of condition. So the full number that Ms Richardson gave you would not all be breast cancer presentations.
And so what reason did AstraZeneca give the department to discontinue one where part of the use case is breast cancer, but to continue the bigger dose where it's, as I understand it, mostly prostate cancer? That seems a strange decision.
I think that's really, it's a commercial decision, and the commercial reasons is probably not something that we're able to share publicly.
Okay.
It's a question for the company.
And so, as I understand it, the department sought to retain the listing, but AstraZeneca wasn't willing to negotiate the retention on the PBS. Is that correct?
We did seek advice from the Pharmaceutical Benefits Advisory Committee, and they recommended that we do seek to retain.
Yes, Senator, we've been in discussions with AstraZeneca and a range of other companies about the retention, but the company has advised that they are removing that item from a number of markets, including Australia, and that's been a commercial decision. For further information about the reasons that have driven that, you'd have to talk to the company, but it's not just Australia that's been affected by this withdrawal.
And from your letter to this Canberran, I understand that AstraZeneca has announced that it will provide free access for eligible patients following its discontinuation on the 1st of November. However, when this Canberran rang AstraZeneca, they told her that they were only considering a patient access program. That language is very different to what they told you and what they've told this Canberran. Should we be concerned that AstraZeneca is leaving people without access right now? Have they given the department some assurances?
Senator, yes, the company's given us similar assurances that they intend to provide access and that they intend to provide access for 6 months beyond the delisting date, and that they will then review that at 6-monthly intervals. At this stage, that's been the statement by the company, and that's they might have said something slightly less than that to this particular patient.
Okay, thank you.
We have also raised the issues that were raised by your constituent with AstraZeneca, and we'll meet with them in a couple of weeks to follow up on that already. Yeah.
Thank you. I really appreciate your work on this. Really disappointing from a company like AstraZeneca.
Yeah, and Senator, just to mention, we do have a bit of time to work through these issues with AstraZeneca because the delist doesn't take effect until the 1st of November 2026.
Thank you. And just can I also ask about the two drugs that we were discussing last time, adalimumab and infliximab, for patients under 18 with Crohn's disease, the new biologics treatments as I understand it. I saw the decision by PBAC to allow young people to access these new medicines if they are at high risk of complicated disease, which is great news, and I really thank and commend the department for your work on this. Could you walk us through what the next steps are? Do sponsors have to put in applications? Do listings need to be changed? What actually happens now to give that effect?
Thank you, Senator, for your question. Yes, there are quite a number of steps that we have to take. PBAC has considered issues associated with these medications at many of their meetings over the past year and continues to work through what is quite a complex issue that relates to a number of drugs that are interrelated. We have to work with each of those sponsors, and that does add to the complications associated with implementing these recommendations, because we need to make sure that in making any changes, those changes are acceptable to each of those sponsors. We have to make changes to the way in which restrictions are worded, and we have to consult on that and ensure that that is propagated to various systems. Where decisions have a financial impact, we have to ensure that those are approved for the use of public money, and depending on their size, there are various kinds of processes within government necessary to ensure that those that the finances to fund changes are available. So we are working through that set of issues, and indeed it's been a very strong focus of PBAC and of the department in our support of PBAC over several years, and I can assure you that we're doing everything we can to get through that work as quickly as possible.
And so what sort of... Thank you. What sort of time frame for families out there who are desperate to access these treatments? What sort of, if you can distill that into, this is what you can probably expect?
I can do, this is what you can probably expect, but it is difficult to give total confidence about an end date. These processes usually take 3 to 6 months, and we are working with the hope that we can do that, and that's based on from the time from the decision. And you would have seen over the past year there have been a series of decisions that that deal with different sub-elements of the issue. So that's commonly the sort of time frame that we are able to achieve. We can usually achieve 3 to 6 months. There's an interaction between different drugs which is adding to the complication, but we're still working towards that time frame.
What date was the decision you're referring to?
Sorry, there's been the date of the PBAC meeting.
Yes.
So there have been a series of PBAC meetings from November last year through the March meeting, the May meeting, and each of those meetings has made decisions, and then we are working to implement those decisions.
Okay. Thank you. Thanks, Chair.
Thank you, Senator Pocock. Senator Nandaraja.
Thanks, Chair. Just have some questions regarding bulk billing reforms. Yeah. What has been the impact of the government's historic investment in bulk billing at the end of last year? If you could just give us an overview, that would be wonderful.
Yes, Senator. So we've had a significant increase in the bulk billing rate. In the first quarter of this calendar year, we've seen a 4.6% increase in bulk billing. We now have 3,638 practices in Australia that are offering bulk billed services to patients.
Mm-hmm.
That was at the end of March. I think it's actually gone up now to 3,800.
Yeah, it's actually gone up to 3,812 as of the 27th of May.
Right, okay.
Well ahead of expectations.
Really, right.
In fact, in our advice to government, we estimated that we'd get 3,600 practices enrolled in the bulk billing practice in the first 2 years. We've achieved that in the first 5 months.
It's incredible. And how do you, what has been the switch from, say, mixed billing to bulk billing?
So as of the 27th of May, 1,451 practices have made the switch from mixed billing to bulk billing.
Right, okay. And you said a 4.6% increase. So what does it come from to now? Is it
Senator Mary Warner,
yeah.
Assistant Secretary, Medical Benefits and Digital Health Division. If we compare the 2024-25 March quarter to this quarter on a national basis, we are looking at 77.3% for 2024-25 March quarter, compared to 81.9% for the 2025-26 quarter.
Okay. And can you give us an indication of the sort of the spread of bulk billing clinics around the country, state by state, for example? And then also break it down by age group if you have that data.
Certainly, Senator. I'll start with the state-by-state breakdown. So in Western Australia, the bulk billing rate is 74%, which is a 4.6% increase.
Mm-hmm.
In the Northern Territory, it's 89.8%, which is a 13.7% increase in the previous comparable quarter. In Queensland, it's 79.5%, which is a 4% increase.
Mm-hmm.
In New South Wales, it's 85.6%, which is a 4% increase. In the ACT, it's 54.1%, which is a 1.4% increase. In South Australia, it's 80.4%, which is a 5.9% increase. In Victoria, it's 83.7%, which is a 5.5% increase. And in Tasmania, it's 78%, which is a 5.7% increase.
Okay, and what about age groups? Do you have any data for age groups?
I can talk about age groups. So if we look at the March quarter last year compared to the March quarter this year, the significant gains have been made in the 16 to 64 age group. So their bulk billing rate went from 68.5% to 76.2%. The 16 and under age group went from 89.8% to 90.8%. And over 65s went from 87.2% to 88.5%.
Okay. And what about concessional versus non-concessional patients?
Yes.
Yeah, so that change was this for the last quarter just gone was 92.7%, which was up from 90. 91.9 for concession card holders. And for non-concession card holders, it's at 72.5% nationally for the March quarter, compared to 64% in the same quarter last year.
Have you got any qualitative data from patients, for example? Any feedback? Have you done an evaluation?
So we are due to commence work on an evaluation, Senator, but we haven't started that work yet.
Sure. Just with regards to the state-by-state data, there's been a huge jump in the Northern Territory. Can you speculate as to what's going on there? I mean, it's fantastic to see bulk billing rates of 89%.
Senator, we have a lot of areas, well, I think most of the NT, if not all, except for Darwin, is considered rural regional, and we have scaled benefits for rural and regional areas. So that means that the payments are higher. We have heard from rural colleagues, whether that's providers or other service delivery people, that the bulk billing rate in rural, regional, remote areas has gone up a lot.
And just to follow on from Senator Pocock's questioning around thin markets, I can see, I mean, ACT is just one area which has had chronically depressed bulk billing rates for a long time. But there are other areas as well where the government is now intervening. Could you perhaps update the committee on what kind of interventions are happening in that space?
Yes, Senator, there's been an investment in the Newcastle Hunter region in the most recent budget for up to 6 bulk billing clinics, very much modelled on the successful policy that we've seen here in the ACT to boost bulk billing in that area, which is lower than we would have expected.
Yeah, okay. And sorry, when are they due to open?
By mid-2027.
Right, okay, so there'll be a commissioning process of some sort.
There will.
That's right, yes. The local primary health network will undertake that commissioning process, Senator.
Okay, yeah, all right, this is good. 2 minutes. Might join Professor Kidd. Professor Kidd, bulk billing is the backbone of Medicare and general practice is the backbone of the health system. Can you comment on any feedback you've had from the colleagues in either primary care or in public hospitals? I mean, this is designed also to take pressure off hospitals and better manage patients with chronic diseases who are the bulk of who bear the burden of the health system.
Yes, thank you, Senator. Feedback from colleagues from across the country. Many general practices right across the country have made an assessment of the financial model, and they've made the decision about whether to join the Commonwealth's bulk billing practice incentive program. You've heard the figures about the very large number which have decided to do so, and also about the incentives which support this program, particularly in rural and remote regions across Australia, improving access for people in those areas where access can often be a real challenge. The RACGP, the Royal Australian College of General Practitioners, has developed specific tools and education resources for doctors to look at the business impacts of these changes and to decide what they do now and what they may do moving into the future.
I've received some anecdotal feedback just on my travels from community members, particularly in the regions, where there's been some pressure on some doctors to not bulk bill. This is in, again, areas where there are few clinics, and it's a little bit like cartel behaviour, if you know what I mean. Have you encountered any of this sort of behaviour in small regional communities, for example?
The answer is no, but that doesn't mean that it's not happening. The decisions, as we know, are individual decisions, so individual doctors deciding whether they're willing to adopt this incentive, and then of course every doctor in a practice is required to come to a consensus if the practice is going to sign up to the program.
And from the department, last question, just have you had any feedback from doctors in regional communities who do wish to bulk bill but are being pressured by others to not do so?
Senator, I haven't. I've spoken to quite a lot of rural medical representative groups who are very happy with the policy and enthusiastically participating in it, but I haven't had any feedback about people who are being pressured not to participate. That isn't to say, as Professor Kidd said, it's not happening. I don't think any of my colleagues would have had that.
Not aware of it, Senator.
Okay. On notice, would you be able to provide a list of those bulk billing clinics broken down by model as well, the modified Monash model? Yeah?
Yes.
Yes, we can.
And states. That would be great. Thank you.
Okay, and now we'll suspend for morning tea and we will return with outcome 2 again at 11:15. Welcome back, everybody. We will recommence with outcome to individual health benefits, and we'll go to Senator Ruston.
Thank you very much. Before the break, Minister, you made mention of the savings that are going to be generated to the government by the private health insurance rebate measure being reinvested back into aged care. So I'm just interested to understand, is this savings measure going back into general revenue, or has it been hypothecated to aged care?
Well, we've been clear, I think, in the announcement that the amount that is raised will be an equivalent amount will be spent in aged care. So in that sense, the investment in aged care is being offset by this modest change to the private health insurance rebate.
So it's not hypothecated though?
Well, I mean, the way the budget works is, you know, and the decision we've taken here is that where we've needed to spend an additional or make additional investments in aged care, we're doing so, and we're offsetting that in the normal way that we do in a whole range of other areas through this modest increase in private health insurance.
In Budget Paper 1, it states and provides the estimates of savings from this measure past the forwards out for 10 years, and states in there that $11 billion will be saved through to 2036-37. Will all of this money be reinvested in aged care, and is there a guarantee that this particular money will all be reinvested in aged care?
The commitment we've made is through the forward estimates, but I have no doubt that future, finance ministers will be providing, whether it be me or someone else, will be providing additional investment into aged care over the medium term. I have no doubt about that at all.
Okay. So, can I just clarify, would a full-age pensioner, where their only income was the pension, be eligible for the $250 tax cut that you announced in the last budget?
So that's a working Australian tax offset. So it's relating to income coming through labour income. So it would depend on the arrangements. Like if that pensioner was working,
I just said who was only income came from pension.
Yes, so my question was, it was a bit mumbly. Sorry.
Okay, sorry. Will a full pensioner where their only income is the pension be eligible for the $250 tax benefit that you announced in the budget?
Well, it's a working Australian tax offset. So it's through, that is provided for people who are earning an income through wages.
So how have you characterised this tax cut? Is it significant for those who receive it?
I'm sorry, I can't hear.
Sorry, I said how would you characterise this tax cut, the working age tax offset? Is it significant for those who are going to be receiving it?
Well, that is not a matter really for the Health Committee, for a start. It's a matter for Treasury, which I'm happy if you want to attend in the next 2 days, I will be there. But that working Australian tax offset should be seen in conjunction with the 3 other tax cuts and the $1,000 instant tax deduction that is included in this budget. We think they are modest and affordable support to provide Australians, over 13 million Australians, who will benefit from those. But this really is a discussion for Treasury estimates, not health.
Although I would point out that you are the Minister for Finance and have got access and oversight.
Not the Treasurer, and here representing the Minister for Health. But, happy to have this discussion tomorrow morning.
Sure. We have had so many calls and contacts, and I know the media have, and I'm sure all of our electorate officers and yours as well have had a lot of comments from pensioners who've rung in, and I just read you a quote from pensioner Linda, who called the ABC radio recently, and she stated, "My income is $29,000 as a pensioner, and I struggle like mad to pay that private health to keep me out of the emergency departments." Minister, how do you respond to Linda?
Well, what I would say there is that we are providing additional investments into aged care, and we've had to find a way that we can manage that in an affordable and responsible way. Indeed, I've had several of your colleagues say that there should be no additional spending in any budget without it being fully offset. Here is an example where we are doing that. So we're building the aged care system we need. We're investing over 24.4 billion into the public hospitals to support the increased activity there. Medicines haven't been as cheap as they are now since 2004. Medicare urgent care clinics are operating in 137 different locations. Most live with, I think it's a very high number of people who live now within a few minutes of, or half an hour of an urgent care 20-minute drive. 4 out of 5 Australians will live within a 20-minute drive from a local Medicare urgent care clinic. We've got our bulk billing practices operating now, almost 3,800 of them. I mean, this is what I would say. We're trying to deal with the increased areas of pressure in health, in aged care, and we're doing it in a way that is responsible and affordable, and that there is still a private health insurance rebate. It's based on income now, not age. That is the change, that everyone who earns an income of, say, below $105,000, whether you are 35 or 65, will receive the same private health insurance rebate.
I'll just point out it's always been means tested, Minister. But Linda also went on to say in that interview about the government, they just want us to pay our taxes and shut the expletive up and die. That's what older Australians are feeling at the moment. I'm not sure that they're going to have any comfort from what you've just said, Minister. What do you say to somebody who thinks that you actually are putting policy in place and just waiting for them to die?
Well, that is just not true. Absolutely not true. And I go back to my earlier answer. What we are doing here is making medicines more affordable, more healthcare options at much greater bulk billing rates, a public hospital system that can deal with the increase in activity that we've been seeing, an aged care system that is preparing for, the demand, absorbing and dealing with the demand we've already got. We are building a system to support older Australians, but we have to do it in a way that is responsible and affordable. We've made this modest change, but we are investing all of that into aged care.
So you don't accept how older Australians are feeling?
Well, you've put a proposition to me, Senator Ruston, and I'm saying I do not agree, and that is not the view of the government. So I'm answering your question, and I'm taking you through, again, all of the areas where we are providing additional investment to make sure that we are caring for older Australians when they need access to hospital care or aged care services. And we're doing it in a way that you and your colleagues have called for repeatedly.
It wasn't a proposition from me, Minister. It was feedback from pensioners.
Well, your party has repeatedly said that any new spending should be offset. This is an example where we have found an offset to support extra investment in aged care, and now you're saying that that's not acceptable either.
By using older Australians who you've just acknowledged will not receive the $250 that other Australians are going to receive as part of your budget package, they're also going to have to find on average another $250. These are full pensioners who are saying to us that they are being forced into making a difficult decision if they even keep their private health insurance as to whether they'll keep their private health insurance, whether they will actually choose to forego a meal or whether they'll turn the heating on this winter. So is your message to pensioners that actually they've got plenty of money to live on and they can afford all of these things? Because that's certainly not what they're telling us.
Well, you're trying to put words into my mouth. That's not what I'm saying. I'm saying that we are focused on investing into the services and systems that older Australians rely upon. That is coming at us and that requires billions and billions of dollars of investment. That's what we're doing.
Okay. Chair, I'm happy to cede the call for a couple of minutes.
Thank you, Senator Ruston.
I'm sorry, for as long as you choose to make me cede it.
Senator Steele, John.
After a couple of minutes, things will go well. All right, okay, so I've got some questions about the PBS safety net. Just let the right people take a mo to come to the... Fabulous. Okay, so there's been an issue brought to my attention regarding the PBS safety net that I would like to ask some questions about today. My understanding is that unlike the Medicare safety net, a person's contributions towards the PBS safety net aren't tracked by the government. And so in practice, what this means, as far as I've been informed, is that the person and their pharmacist need to track those contributions themselves and then apply to have the safety net applied to them once they've hit that threshold. Is it correct to say that this is basically the way it works? You don't track that data in that situation? And if this is correct, do you have any further detail about how this process works?
Senator, the broad characterisation you've just provided is accurate. The Australian government provides a fee to pharmacists as part of their dispensing fee to compensate them for the effort that is required to ensure that safety net expenditure is tracked. Then the pharmacy tracks that often on behalf of the patient, or the patient can do it, and then submits a claim for the safety net to Services Australia when they reach the threshold.
Okay, so the government provides a subsidy to pharmacists generally, is that correct, through the pharmacy agreement?
Yes, that's right, through the pharmacy agreement, and it's one of the components of the remuneration that pharmacists receive when they dispense medicines.
Right. And so you feel that they are financially compensated for doing the work, if you like. What does the work look like on the pharmacist end? What are they required to do?
Senator, when a patient comes to the pharmacist with their script, they log that script in a system that they'll have in the pharmacy, and those can vary slightly between pharmacies. And then they basically keep account of that money, and then when it adds up to the amount which equals the payment, they submit paperwork that allows them to make a claim. That process can be followed by a patient instead if they wish. So if a patient has a regular pharmacist, then many pharmacists provide that service for patients. Otherwise, it is something that patients can also do, is track their expenditure, keep evidence that they have had scripts filled, and when they get to the appropriate volume, they can submit claims.
Okay, so if the person doesn't have a regular pharmacist, and I would say the vast majority of people don't have a regular pharmacist these days, it's on the patient to track that expenditure.
Senator, while you're probably accurate in saying the vast majority of general patients don't have a regular pharmacist, the safety net is there to help those who have a large number of scripts. Patients who have a large number of scripts more commonly have a regular pharmacist. But in those cases where they don't, then the patient can track the script themselves. So they don't require to have a regular pharmacist to do it, but many will.
And how does the patient go about tracking that themselves?
So they keep evidence of the expenditure that they have made, and then they submit that evidence when it means that they have hit the safety net.
Right, and they do that via the MyGov portal? I'm just trying to get an understanding of the mechanics of what people are required to do here.
Yes, Senator. So the actual mechanics are an interaction with Services Australia. So I've probably gone about as far as I can in outlining that, and you could ask further questions of the precise mechanics of Services Australia, but that's a general characterisation of the way in which people submit paperwork for Services Australia.
So they submit it. How many people claim the PBS safety net every year?
Just give me 1 second, Senator. Senator, it might take me just a moment longer to find the number, but I have a dollar value of the claim, if that would be helpful.
Dollar value first would be great.
So between the 1st of July 2022 and the 31st of March 2026, there was $665.5 million in patient savings across 88.2 million prescriptions. I don't have the number to hand as to the number of patients that represents, but we can either get that for you later today or on notice if we're unable to.
Later today would be great. We're going to be here for a while, so that'd be fab. And if not, on notice. Do you have an estimate for how many people how many people may be eligible or are eligible for the PBS safety net in a year but don't claim it?
Senator, I'd have to take that on notice.
Okay. Because my concern from speaking to constituents in West Australia and across the country about this dynamic is that there may be people eligible for the safety net, for the saving, particularly important in this really tough cost of living dynamic that we're in right now. But they don't claim it because they either don't know that they can or they don't know, especially folks that are managing multiple co-occurring conditions but without a regular contact with a pharmacist. They don't know they've hit the safety net in the first place and are then spending money they don't need to spend on medications. Has the government considered making the PBS safety net automatic to ensure that people are able to access the benefits they're entitled to?
Senator, yes, the circumstances you've outlined are something that has been a concern to government in the system, and there has been some consideration as to how to best improve systems to ensure that patients can get the services that they require in the circumstances where they are entitled to them.
Okay, so you have considered it. What form has that consideration taken?
Senator, there's been discussions within government. There's been a briefing between the department and ministers on those issues.
Okay, can we have a timeline for that? When that briefing occurred?
Senator, I'd have to provide that on notice.
Okay. And so there's been a briefing for the minister. What was the other? Was there another thing that you've done other than brief the minister?
Well, it's one of many issues related to the PBS that is under continual discussion within government. We're constantly evaluating how the PBS operates and looking for ways to ensure that it continues to meet its objectives. And this is one of those issues. So there's been work done inside the department to understand this issue as one of many issues. There's been discussion with the minister and his staff, and there's been discussion with other departments and organs of government about a range of policy issues, and this is one of those that has been part of those discussions.
And has the government made a commitment to wanting to implement an automatic PBS safety net at this point?
Senator, at this stage there's been no commitment publicly made by government about this issue.
Okay. What would need to, I guess, what I'd like to know for these folks that have come to me and very understandably, they look at the Medicare safety net, they look at the PBS safety net, and wonder why one is different than the other. What would be needed to enable an automatic PBS safety net for people who are eligible? Is it just an IT systems change, or would there need to be legislative change?
Senator, yes, we have done some consideration of those issues, and so while in the absence of a decision about a particular policy, it's not possible to hypothetically explain all of the sorts of things that would be needed, but it's very likely there would need to be legislative change, there would need to be IT changes. Services Australia would need to change some of the work that they do to support their systems and to support people who use those systems. There'd need to be changes to pharmacy software and systems. There'd need to be discussion with affected groups to ensure that those changes worked in the way that they were intended. So there's a sort of fairly broad range of things that would need to be done to implement such a system.
And am I right in understanding that you, as in the department, have undertaken a scope of some of those challenges and barriers, and that's what you put together in a brief for government when you talk about having briefed the...
I think that there is actually a good summary of the work we've done in the incoming government brief that this portfolio prepared last year. So at page 49, we included in that brief options to address issues with the operation of the PBS safety net, including options to implement a digital PBS safety net, are being developed. Potential solutions would automatically capture eligible prescriptions and update patient safety net status via a MyGov digital service. So those are the sorts of things we've looked at.
Okay. So what's the timeline from here? So you've done the work, you've briefed the Minister, and you'll come back to me on notice on when that occurred. But what is the timeline from here in terms of progressing this?
That's a matter for government.
Okay. Minister, what's the timeline here?
Well, no doubt, it was really a matter for the Minister for Health to manage, but it would require a decision of government, so it would have to go through our normal processes.
Yes, it would. And I think it seems to be one of those relatively easier fixes that could deliver cost of living relief to people right now. So I'm very keen to understand when that briefing was delivered to the Minister. Minister, if you could take on notice any other steps the Health Minister is taking to advance this particular reform, that would be appreciated.
He has it under review, I would say, based on the evidence today.
Excellent. Thank you for that. My last question is, given where we are now with a non-automatic PBS safety net system in place, what is the government doing to make people aware of their entitlements and how to claim the PBS safety net? Because I've been quite shocked at the fact that for many people to hear this information, they will be surprised that they could take these steps or to access this entitlement. So what are we doing to make them aware of what is currently in place?
Services Australia publish material about applying for the safety net benefits.
Yes, they do. Yep.
And that's all on Services Australia websites and material.
But within the health department, what are we doing?
We work with Services Australia to make sure that the health programs that they partner with us to deliver are being delivered effectively.
Okie doke. Okay, that does me, Chair. Thank you.
Thank you very much. We'll go to Senator Ruston.
Thank you very much. Can I just ask a few questions about urgent care clinics?
Sorry, the only question, Chair, is that urgent care clinics are outcome one, which was meant to be later, but we do have Mark Rodham here, who's the First Assistant Secretary, so I think we'll have a crack.
I'm happy to leave it till later if that... If you want to do a roll all at once, I'm here all day.
Yeah, but if we can lighten your load by doing it quicker,
Okay,
we'll do
fantastic.
that. So we'll try and see
Thank
how we go.
Your accommodation is duly noted. I'm just interested, Is there any evidence that the urgent care clinics, as they're operating in the ACT, are taking pressure off emergency departments?
As they're operating in the ACT?
Yeah, well, the ACT one. Specifically, I'm talking about the urgent care clinics in the ACT.
So the combination of the nurse-led clinics and the Medicare, the Warrior and Medicare urgent care clinic, which is GP-led, across all of them?
Yeah. So I'm just asking, in terms of the evaluation, have you received or do you have any evidence that the urgent care clinics in the ACT are taking pressure off emergency departments specifically?
So, Senator, we have, there are 5 walk-in centres, as they're called, under the ACT's naming system, and 1 regular urgent care clinic in Woden, if you like, in the ACT. In terms of the 5 walk-in centres, I believe the ACT has done its own evaluation of those, but we now have the data under a data sharing agreement with the ACT to look at that issue more closely, and that'll feature more prominently in the final evaluation of the urgent care clinics, the 3rd and final due at the end of this year, than they have in the first 2.
So you don't, as we're sitting here today, have the necessary evidence to say?
In terms of the Commonwealth's evaluation, as I say, we have the information now to be able to include that in our evaluation process, and that's what we're doing in the 3rd and final evaluation.
Yep. So just to be clear, as we're sitting here today, you can't provide me or the Australian public or the people of the ACT with any evidence to say whether the urgent care clinics in the ACT or the walk-in centres are taking pressure off the emergency departments in the ACT.
Well, what I can do is take that on notice,
Yeah,
Senator.
and I can certainly say as a Canberran, from what I see, the walk-in centres are very busy. I was actually the Minister for Health when the walk-in centres were established. There's been quite a lot of work done around impact on emergency department presentations in the ACT, because we do have, a small jurisdiction with 2 very busy emergency departments, one in a tertiary hospital that gets referrals from New South Wales as well. Part of it is around making sure we are taking pressure off emergency departments, particularly with those low category 4 and 5 presentations. But the other thing is also making sure in a jurisdiction that has, shortages in relation to accessing GPs and out-of-hours care, that people have choice and accessibility to out-of-hours care for non-urgent conditions. And you can actually go to the website and have a look at the waits for each of those clinics. But certainly when my family and I've used them, when my friends have used them, they are very busy and they are providing a very highly valued healthcare offering here in the ACT, which has, as we've just heard with Senator Pocock's questions, some rather unique features that are not seen elsewhere in the country.
So, going back to my question, the Minister just made the comment that we're making sure we're taking the pressure off emergency departments, but as yet you do not have the evidence to back that up. You're expecting to have that at the end of the year. Is that what you said?
We certainly have evidence across the Medicare Urgent Care Clinic program that pressure is being taken off.
In the ACT?
Just across the program. In terms
no, sorry, I'm just talking about the ACT.
In terms of the ACT, what I can do, Senator, is provide on notice the early insights from the data that we have, as well as any information the ACT government may have put together, any evaluations they have, and provide that to you.
Now, I understand there was a request from the AC Health Directorate for the UCCs in the ACT to have a different approach of evaluation. Is that correct, and was it granted?
I wouldn't categorise it in that way, Senator. We are incorporating evaluation of those clinics into the final evaluation, as I said.
Okay, so you're saying that they haven't requested a evaluation approach that differs in any way to the evaluation approach that's been undertaken outside of the ACT?
The thing about these clinics, Senator, is they've been around, I think, since 2013, so they're a well-established part of the ACT health ecosystem. So we do need to consider that in any evaluation, and so that could be considered.
And they're a slightly different model in that they're nurse-led. So they don't have GPs on site. Some of them have had nurse practitioners in the past or advanced practice nurses, but they are nurse-led and have you know, more limitations on their scope of practice, as you would expect.
Yeah, that wasn't actually my question. My question was, has the ACT Directorate requested that a different approach of evaluation be undertaken? And I can read from the report, says that considering the unique arrangements in the ACT, it's difficult to report against these measures of success, the standard measures of success, given UCCs are an integrated part of the ACT's long-standing walk-in clinic facilities. It's difficult to differentiate between patients of UCCs and patients of the nurse-led ACT walk-in clinics. The ACT have concerns around how the evaluation commissioned by the Department of Health and Aged Care will measure the impact of UCC program in the ACT given this unique arrangement. So in their request, they sought on the basis, that was the basis of why they sought it, they asked, my understanding is they sought for a different evaluation approach for that reason. Did you grant them a different evaluation approach? Will you be evaluating the ACT urgent care clinics or walk-in clinics differently in any way than how you're evaluating the clinics outside of the ACT?
I wouldn't say we'll be doing it. The independent evaluator, Senator, I wouldn't say we'd be doing that differently. There are, as I said, it's a different ecosystem in the ACT around the walk-in clinics and their, the fact that they've been in the system for quite a period of time now. But we can certainly provide on notice any details of any correspondence with the ACT on that issue.
So maybe just to be really clear, it's a different approach to evaluation. So if you could provide me with that, because, you know, quite frankly, this looks like the ACT is being treated differently. So
the ACT
just to
won't be treated differently. It has a different model in implementation, but we will consider that as part of the evaluation. I'm very intrigued by your interest in the walk-in centres in the ACT, Senator Ruston.
care about all patients in all places around Australia.
Right, okay.
It's my job.
It wouldn't be doing some work on behalf of anyone else.
No, Senator Pocock's here to do his own work.
Right. Okay, just intriguing, and also talking to, you know, the walk-in centres here are very popular. I'd be very surprised if you went out and asked anyone in Canberra about whether they are doing a good job, whether you would get a negative response to that, Senator Ruston.
I had calls to walk into one and said, I'm going to excellent, absolutely.
Senator, I'm advised the clinics will all be part of the same evaluation, as I said, but there will be consideration given to the distinctive nature of the nurse-led model.
So there will be a slightly different approach taken. Because the Minister is very invested, her pet project here in the ACT.
Well,
so
excuse me, the walk-in centres have been a very important addition to healthcare provision in the ACT. Now, if you have a problem with that, come out and say it, or whoever else is wanting these questions asked, come out and say it, and then we can have a discussion about that. But you will find on all of the assessments that have been done, they provide a valued offering, that the standard of care is extremely high, and they have passed every assessment that has been asked of them in the years that they've operated.
They clearly haven't passed every assessment because they haven't been assessed yet.
They have, sorry, Senator Ruston, your asides, they have been through thorough evaluation in the history of their operation here in the ACT. So just to be clear, we brought them into the urgent care network because they provided a service that was unique and didn't exist in other jurisdictions, and we have supplemented that with a new Woden Medicare urgent care clinic, which is GP-led and has had huge take-up as well.
Thank you. So I'm assuming that the ACT Health Directorate is now providing evaluation data on the UCCs?
We have a data sharing agreement with the ACT, as we do with the other jurisdictions.
So you have a data sharing arrangement, and the data is being provided?
Yes,
the data is being provided. Okay. So is the ACT Health Directorate now reporting the percentages of patients whose conditions would be more appropriately managed by an ED or their GP and subsequently referred?
I don't have the detail of the data we're getting with me, Senator. I need to take that on notice.
Okay. Is it possible to table the evaluation data on the Medicare UCC program as it's integrated into the ACT, into both the UCC and the walk-in clinics that's received from the ACT?
We can provide details,
so
Senator.
far?
Part of the challenge is it's something like a fortnightly data exchange from system to system, so we can explain that on notice.
So I'm sorry, I wasn't quite clear what you're going to
I guess
provide.
what I'm saying is there's no report at the moment at a point in time. There's a data flow between ourselves and the ACT. What I can do is provide detail of the data items we have, etc.
So when will that data be in a format that would provide a meaningful analysis?
Well, as I said, it's incorporated into the evaluation process. The third and final evaluation is due at the end of this year to government.
So we're probably not likely to see anything till the end of the year, or you'll be able to
Well,
provide
that's
that
our formal evaluation schedule,
Yeah.
Senator.
But will you be able to provide any preliminary information in relation to
We'll
that
see what
data?
we can provide on notice, Senator.
Thank you.
In this, like your ACT, I don't think I've ever heard you ask a question about the ACT health system before, Senator Ruston.
I'm
intrigued.
I'm the Shadow Minister for Health for
I know,
Australia.
but you've never, in the whole time I've worked here, I don't think I've ever had an ACT question. I'm just intrigued.
Well, you should be delighted that I'm taking an interest in where you live and the health services that are being provided or not provided to the people in the ACT.
That we created and invested, yes, that are delivering for the people of the ACT. Yeah, very interesting. Anyway, noted. Look forward to more.
Senator Ruston, if you're going on to another topic, you're just coming up on the 15.
Sure.
Is that all right?
I will accommodate.
Excellent. We'll go to Senator Pocock.
Chair. And as a Canberran, I can confirm that the Medicare urgent care clinics are very busy. In fact, I just actually got text a photo from the Woden Urgent Care Clinic last week, and there's a sign out the front that reads, "Urgent care is not taking patients. We're currently at full capacity and unable to accept any more patients today." So clearly very busy. But on that note, what is the capacity of the Woden Urgent Care Clinic?
That would depend, I think, on the workforce at any particular time of the day, Senator. There wouldn't be a hard and fast rule about that.
Well, what's the workforce range from?
I'd need to give you on notice, Senator.
I think it's a doctor and a nurse.
Yes, at least, but sometimes more than one.
But yes,
depending
they
on time of the
surge.
day.
But I did see some data. We'll see what we can provide you.
Thank you. Maybe I'll notice if you could give the sort of breakdown of generally who is working there during the day at what times. That'd be helpful. I was keen to ask some questions about ultrasound in the ACT. I've asked about this before, and am having more and more Canberrans raise concerns about ultrasounds. I was looking at some of the data in May 2022. The bulk billing rate for ultrasounds in the ACT was 44.9%, which seems low, but it's now fallen to 28.9%. That is a huge drop, almost halved. But the most alarming thing is the gap fee. The gap fee has increased by about $45 in that same time frame. It's currently sitting at $125 per service. And as a Canberran, I feel pretty aggrieved looking at the data for the rest of the country, where the bulk billing rate is 65% and the gap is $47. So you can go to Goulburn and get an ultrasound and pay $47. And here in the ACT, you're paying $125. What's going on here? Clearly there is a market failure. What can the department do? Can the ACCC do something? How do we explain this?
I think the explanation, Senator, is that the charging practices for Medicare rebated services, which are private health services, are decisions made by the provider of the services. So you have different decisions being made in Canberra compared to Goulburn about what patients will be charged. Now, having said that, the Minister, the government is very concerned about increases in the out-of-pocket costs for specialist services, which include specialists that provide diagnostic imaging, other types of services, so it's not just sort of surgeons and things like that. And we have started work on developing options to consider how specialist costs might be addressed, because there is general increases in out-of-pocket costs for specialist services, reductions in bulk billing rates, and while we've seen a good turnaround in bulk billing rates for primary care services, GP services, patients who need specialist services also are going to need, I think, some assistance. So we're looking at different options. The department has already been consulting on potential changes to Medicare referral arrangements to make it easier for patients to move around between different specialists based on cost, if that's what's going to matter to the patient. But we're also looking at other options in consultation with consumers, with providers of specialist services, about how we might ensure that we do not have unaffordable services going forward under Medicare. So, Ms.
Shakespeare, it's your understanding that these are big providers, these are not small businesses providing these services, looking at what's available in the ACT. So a provider is charging someone who turns up for a scan in Goulburn or Queanbeyan $47, but when it's in Canberra it's $125. Same company, same machine, and they're charging Canberrans more just because they can? Is that the understanding?
That appears to be the case.
And can the ACCC do something? Like, clearly this is a very concentrated market. I assume barriers to entry are huge in terms of the costs of these of the equipment. It's not like a small business can just pop up and provide competition. What can be done? Could the department speak to the ACCC about it, or is it out of their remit?
So, I mean, we're certainly looking at options to ensure that people get appropriate informed financial consent before having services provided.
That's a very
and one of the
different thing
options is looking at, what are the ACCC's powers there. I can't tell you exactly what the ACCC can do at the moment. If you've got inexplicable variation in fees that would have the same cost base across different geographic regions, that's going to have to be something that we'd refer to them.
And why hasn't the department looked at that already?
So we're looking at a range of different options to manage the affordability of specialist fees. And it's not just referring people to the ACCC.
Okay. So, Senator, we're going to be consulting over the next 6 months, as Ms Shakespeare indicated, on informed financial consent, improved transparency. But we're also going to start a discussion on excessive fees and if those excessive fees should be regulated as well and how they might be regulated. Okay. But that is still ahead of us. We're doing the policy work at the moment and we will then be consulting broadly on that.
I accept the sort of informed financial consent for big surgeries when you've got anaesthetists and all the rest involved, but for something as simple as a scan, like, it seems like the cost is pretty obvious. It's just that we're getting absolutely fleeced in the ACT because they can, and so it seems like to me just a total market failure. So I'd urge you to sort of look at ACCC or what could actually be done, because clearly the same company charging $80-90 more just because they're in the ACT doesn't make sense. But I appreciate that there is work underway. And
Senator, Mary Warner, Diagnostic Imaging and Pathology Branch. We recently undertook 2 reviews of women's imaging, including ultrasound and mammography, breast imaging, which will looked at the Medicare fees, not the out-of-pockets, but looked at the fees and the services that are provided under the hundreds of items that are on the Medicare schedule for a wide range of ultrasound services.
And what can you tell me about what's happening in the ACT?
Well, that's due to report. It's going to report. It's reported to government, and it's a government decision of what they want to do.
Whether or not they publish it.
Yep.
Okay. Well, we'll wait for that. Can I just finally go back to the biologics treatments for Crohn's, and I wanted to go back to the timeline. We were talking about 3 to 6 months from decisions. but then you said that PBAC essentially makes a decision at every meeting. So what does that actually mean? Is it from the original decision in March or after the reconsideration in May? When do families think, well, okay, 3 to 6 months from now we should be able to access this?
Thank you, Senator. There's been consideration at quite a number of the PBAC's meetings, starting with the December meeting last year. Those things, there's a range of different parts to the decision and they're not necessarily delivered as a package. So there's changes to restrictions, there's things that have to be negotiated with the companies that are responsible for the different medicines, and we will do that work and get it available on the PBS as and when we can. So we're not going to save it all up, and it's not resetting a clock every time there's further decisions being made. So the decisions that were made by PBAC in December last year are the most progressed, and then the other ones are coming soon after. I believe that we're targeting July, August for the first of those things to be worked through, and so if everything goes well, then that's coming very soon.
And so it'll be different types of biologics available based on 3 to 6 months after those decisions. Is that what you're saying?
So, Senator, we don't have a process that means we stop the clock and wait 3 to 6 months and then release it. That's how long it tends to take to work through all of those issues. If an issue is simple enough, we'll do it sooner. If an issue is complex, it can take towards the upper end of that period of time. So some of these are quite complex because they relate to changing restrictions associated with a range of medications, and there aren't clinical studies associated with many of the issues that have been considered. So a lot of this relates to the way we treat paediatric patients, and there's things like making sure dosage is correct based on age or weight. There's issues associated with emerging evidence and the decisions that are being made by other international regulators. There's advice from clinicians about how this fits into practice in Australia. And I know it's very frustrating for patients, and we're very mindful to try and ensure that we act as fast as possible, but it's critical that we don't degrade care or cause harm in introducing these new elements, and that's part of why we need to be very thorough about going through all of the work that we do in order to make sure that when we make changes to the PBS, they're always a good thing for the patients that then have an opportunity to get the new care.
Sure, thank you. But it's still a little bit unclear what, you've got this sort of rolling, working on things. Have you reached out to the sponsors of these medicines to start to negotiate, or?
Yes, so Senator, I think, my colleague's reluctant to put a hard and fast time on it because things can still unravel, depending on how the negotiations go. But this is proceeding well. We're working to get this listed as fast as we possibly can, and at this stage we expect that this will be on the PBS in the next couple of months.
Great, thank you. And so how does that listing work? Is that 1 July or?
So when all the work is done, if there are changes to the PBS, they're announced, and if there are changes to availability on the PBS, they're usually made available on the first of the month, in the earliest month that it's possible to make them available. And that's often accompanied by information it's always accompanied by information on the PBS website. Often the Minister will release information about changes that are made to the PBS as well. If there are changes to restrictions, which is likely in this case, so the restriction is the information that's provided to doctors to help them when doing their prescribing and making sure they're prescribing in the right circumstances. So if there are changes to those, then those go out on bulletins that target the practitioners that need to take advantage of that information. So there's a range of different ways that we'll publish information about this to ensure that those who are affected by it are aware of the changes when they're made.
Okay. And so I'm just trying to read between the lines there. So we're working towards a potential 1 July listing, or?
Senator, as Ms Shakespeare clarified, we will do it as soon as we possibly can, and we're still working on the things that need to be put in place to allow that, and so we can expect that to happen over the next few months.
And obviously there's a lot of interest from parents in this. How will they be kept in the loop? That many will be making decisions about treatment and sort of really hanging out for this decision. What do you say to them?
So we include information about new listings on our departmental websites. The Minister usually puts out a media release around the times of new listings. We have the medicine status website people can check in on. So there are a range of ways people can get the information, but we usually have the Minister make announcements about new listings. I'd say that's probably the thing that gets most attention.
Okay. Well, thank you very much. I appreciate your work on this and look forward to seeing that decision. Cheers.
Thank you very much. Can I just ask a few questions on some of the budget line items? So in budget paper 2, page 110, there is a couple of measures in there in relation to, I'll just get it up here. In relation to the Medicare, extended Medicare safety net benefit. It says the government will achieve savings of $75.6 million over 4 years to ensure government funding for healthcare continues to be appropriately targeted to areas of most need. Okay. Can you please provide the details of the MBS items impacted by the decision to impact the decision to cap the EMSN for the items included in this measure?
Senator, we have a small number of items that the government intends to cap. We haven't announced them yet. The government will be announcing them later this year. And the primary reason is that we have some integrity concerns with a small number of providers charging extreme, excessive fees that are contributing to safety net payments. And so we want to work through that carefully so that we don't signal to those providers to take advantage of that gap in the safety net until later in the year when we cap those items.
Okay. So on page 111, it says $3.1 million over 4 years in savings through applying the lower rebate to the MBS listings for sleep disorders in children and adolescents. So how many patients are impacted by this change?
Senator Nigel Murray, Assistant Secretary, Medical Benefits Division. I'm not sure I have that specific number on how many are affected by this change, but what that item is doing is allowing at-home sleep studies for children and adolescents rather than them having to go through laboratory testing, which is obviously very difficult, particularly if you're in a regional or remote area. The exact number I might have to take on notice, though.
Okay. So will there be any additional out-of-pocket costs for the patients as a result of this change?
Well, what this should do is actually make it better and easier and hopefully cheaper for people to get these services rather than have to go through the more expensive laboratory testing, overnight laboratory testing. Instead, families can do these sleep tests at home with their children, and that would save them the need to actually travel, for example, into major city areas for those laboratory tests.
Okay, so it actually, whilst it's a saving to government, you believe it will be a savings to the patients as well?
It should be as well. It's extending access to these services and allowing them to get them at home.
Okay, you said it should be.
It would be, yes.
It would be. Okay, thank you. So on page 110, it also says that there'll be, let's say, $43.4 million over 4 years for capping the extended Medicare safety net benefit for a small number of Medicare benefit schedules at 80% of the fee. I know you haven't announced the measures that were contained in that. Is there a reason, Minister, why you didn't announce the measures that were contained in that savings measure?
Sorry, can you...
Sorry,
I was trying to
Senator,
find
I think
it
I
on
did
the
answer that, Senator.
Oh, okay, sure.
110, I was trying to page...
I think actually Mr McBride actually gave
Sure.
a previous answer,
Yeah.
which is a small number of providers undertaking behaviour that we're concerned about. We don't want to signal to that before we finalise which ones to identify to avoid a surge of inappropriate claims.
So we will announce that later in the year, Senator, but so that both providers and consumers are aware of those caps. But it is a very small number of items where there are a small number of providers effectively abusing the safety net.
Okay. So do you know how many patients are likely to be impacted by this?
I don't have the patient number, but it'd be less than 30 items. Of the
30
MBS. There's
items, but how
6,000
many...
items on the MBS list.
Yeah, but how many people will be affected by those items?
I'd have to take that on notice, Senator.
Okay, and I'd be interested, is there likely to be any additional out-of-pocket costs to the individual?
These changes traditionally, Senator, sent as a signal to the providers to stop charging outrageous fees, and
part of which goes to the patient.
Which goes to the patient. When we've done this previously, we get providers working back within band. So normally, and obviously we can't predict all behaviour of providers, they will reduce their out-of-pocket fees to match the cap and the safety net.
So when do you think you're likely to be in a position to be able to provide that information as to which items will be included in this?
Look, I think this change happens at the beginning of next calendar year, so we would be wanting to give a reasonable notice, but it's probably in the latter part of this year. I just don't have an exact time at this stage, Senator.
So how do you balance the consultation that's needed to understand the impact of a change if you're not telling everyone because you're worried about the impact of actually people knowing?
I think my point earlier is that this is a small number of providers that are charging well outside of what we consider to be a reasonable cap, or the cap that has been announced in this budget measure. And so the majority of providers won't be impacted by this change, Senator.
No, but you're not saying what the measures are that are going to be impacted by it.
We will, in due course.
Yeah, no, I get that, but how are you supposed to consult to understand if you're not providing the information until closer to the date? I mean,
I'm not sure that we will be consulting, Senator. We'll be announcing the caps to deal with the integrity issues that we've identified with these items. And as I indicated, there will be a small number of providers that are charging very large fees that will be impacted, but the majority of the professions that use these items will be working within the existing cap.
So my question
with
is,
the new cap, sorry.
Will this have any impact on the cost, out-of-pocket cost for patients? I'm not worried so much about the providers under this.
So I think we've agreed to take that on notice, but as I said before, Senator, when we've made these changes in previous budget updates, we tend to see providers adjust their billing to work within the MBS caps, noting that they know that the patient would then bear the costs that they're currently charging. But obviously individual providers will make billing judgments.
Will they be receiving any less from the government?
So at the moment, having these items uncapped means that the government is paying those providers 80% of their gap fee in addition to the rebate.
So you're saying they're not capped?
At the moment. So they're uncapped, and what we're doing is putting a cap on them to stop effectively providers using a loophole in the safety net to charge very large fees.
So how many items are uncapped for the purposes of the EMSN?
Again, I have to take that on notice, Senator. It varies. It's not all, as I said, there's 6,000 items on the EMSN.
It varies?
It varies across in terms of the items that are covered. There's 6,000 items on the MBS.
Yeah, I just asked how many had caps.
There are EMSN fee caps on a relatively large number of those items, but not on all items. Fee caps have generally been applied where there has been evidence of inappropriate claiming behaviour. What can unfortunately happen with the safety net is providers may take advantage of the fact that the government is paying this extra 80% by actually increasing their fee.
No, I understand
and we're trying to
that.
stop that practice with these changes.
I'm just really interested. I'm curious now that I thought I was just asking a simple question. I'm now curious that we have got MBS items that are not capped for the purposes of the EMSN. Is that what you're telling me?
Yes, and that's been that has been in place since the introduction of the extended Medicare safety net in the early 2000s, and progressively over time, as we've observed claiming behaviour and in some circumstances egregious billing, then government has introduced caps.
Okay. So you waited till you saw the behaviour that concerned you before you put a cap on, instead of making a decision around that, because I mean the cap, it only applies for the purposes of the rebate for the EMSN. It doesn't, or well, at the purposes of the rebate and then the EMSN, it doesn't actually cap the fee of the provider. It's just, it caps it for the purposes of your assessment about what additional funding will be provided to the patient or the claimant once they reach the EMSN. Is that correct?
Threshold. Yes, that's threshold.
Yes. Yeah. Okay. And so I just, out of curiosity, not for the purposes of this, we're fascinated to know what items remain uncapped.
Yeah, so we can give you that information on notice. We've done a lot of work in the last 2 years on the safety net, Senator.
Yeah, sure. Thank you. Okay. Once again on page 10 of the budget paper, there's a measure that says.
I assume you mean 110.
Yeah, what did I say?
You said 10, and I just see Penny
You'd like
madly
to read
scrolling.
the index. Sorry, I'm mumbling. It's been a long few days. Okay, yeah, 671 million over 4 years by reducing fraud and non-compliance in the MBS and the PBS. So I was just interested if you could provide a little bit in the way of additional details on the expanded capacity and compliance measures that you are considering to be using in order to achieve this saving.
Sure, thanks. Matt Williams, First Assistant Secretary, Benefits Integrity Division. So this measure, I guess, can be seen in the light of the previous 3 budget measures in response to the Phillip Review recommendations to modernise and update our the Medicare Integrity Framework and the systems and tools behind it. Some of the key elements of the recommendations associated assess that the integrity approach that the government took focused too heavily on post-payment compliance measures, and those measures really were reliant on data of payments that had already happened and pursuing practitioners and those that were operating outside of regulations. The Phillip Review also identified that there were governance gaps between Services Australia, ourselves and others that operate and govern this system. It also identified that there could be greater benefits in avoiding non-compliance and fraud if some of those measures and efforts were upfront, so providing support to providers to ensure that they understood their obligations and how the MBS and PBS worked, and also educate and provide advice when there were questions, as well as upfront control, so ability for us to intervene on high risk and high value items before payments are made, so that assessments are made. So this budget measure takes forward additional reforms and modernisation of Medicare integrity that has been happening for some time. The first element really is the ongoing reform and innovation capability. So the previous 2 measures the government implemented set up a task force to respond to Phillip Review recommendations and work with Services Australia to implement and update and modernise. This measure provides ongoing support for that capability going forward. It does also provide support for upfront controls, so high risk and high cost items that we've analysed over time have been particularly of particular concern. Allows an opportunity for us to analyse and and sort of do assessments of those payments prior to payments being made. It also, and most importantly, provides support to practitioners. A lot of practitioners haven't had visibility of their own billing in the system very easily, and so this provides a measure for us to support practitioners and patients to see what is actually happening in billing under both their names, and so would allow practitioners to better understand whether or not they are not compliant, or whether or not there are some institutional or corporate arrangements that have meant that they're non-compliant. For instance, sometimes practitioners' provider numbers will be utilised when a locum is in town rather than the locum's provider numbers, and so there is a non-compliance issue there. So having better visibility allows practitioners to better govern their own actions. It also provides ability for patients to see their own billing under their names as well. There is some visibility at the moment. This would make that more easily accessible, and so to enable people to tip off or provide information to ourselves or others when there are concerns around those billing experiences as well. A number of other things as well in terms of PBS and MBS. So MBS is relatively, I know it's a complex system, but in terms of the data that's available to us and our ability to analyse the data, it's fairly simple in comparison to the PBS, which has a number of ways the data is transmitted and scripts are made. So a significant investment will be made in modernising and maturing our PBS compliance capabilities, and our ability to analyse data across a number of data sets.
Is that likely to be an ICT change?
So there will be ICT changes, but there'll also be additional capability within the department to do what we call a pharmacy committee of review, which is similar to the PSR in nature, in that it reviews PBS payments and behaviours of pharmacists, and allows us to, at a greater level and greater number, work through those cases of concern.
So I'm assuming the figure that we're talking about, the 674 million, is a net figure. There would be costs associated with you undertaking these changes, and you're imagining it will reap a net reward of 674 million.
The investment is 146.8 million to uplift those systems, both within ourselves and Services Australia, and so the net return would be 674.1 million.
Sure. So, is there an intention to use, like AI or algorithms or the like to detect non-compliance and fraud detection?
So, Senator, as part of the Phillip review and our modernisation effort, we have really invested in moving away simply from relying on tip-offs from the public, which is predominantly how a lot of the information was passed to us for investigation and for issues of concern. We have invested in increased analytic capabilities and our ability to understand and compare data sets. And as technology evolves, we have started to rely on things like machine learning and advanced analytics to compare data sets, demographics of particular population groups, and the billing behaviours of practitioners in those population areas, whether Home Affairs data, for instance, about whether practitioners are in the country, out of the country. Those sorts of the new technologies have allowed us to do greater analysis of areas and issues of concern. AI is, it depends on your definition of AI, but there's no intention that there'll be the use of AI to make any compliance determinations. AI and advanced analytics would only be used and are only used currently to support our identification of issues of concern, which are then individually investigated by the department.
So do you have an estimation of what you think the level of fraud is in both the MBS and the PBS, and what you believe the level and value of fraud is in terms of fraud versus non-compliance? Because you throw fraud and non-compliance into the same bucket, because obviously that's funds that should have been inappropriately received, but one is a much more serious mechanism by which to access those funds than the other. So have you got fraud and non-compliance separated? And I'm just interested, do you have a number that you believe that the Australian taxpayer is being defrauded by MBS and PBS and the number of non-compliance?
Sure, Senator. So, Senator, there have been a number of estimations over time about non-compliance envelope, and that 2016 Boston Consulting estimated it was 1 to 4%. McKinsey in 2016 that it was 6%. Boston Consulting in 2018 that it was 3 to 5. ANAO did an assessment of around 2 to 5% in 2019, and the Phillip Review, which you're familiar with, estimated around 4 to 7% non-compliance. And that non-compliance is inadvertent on occasion, deliberate rarely, and fraud is the most egregious. There is also below what we consider criminal fraud, inappropriate practice, which the PSR deals with. So there is a spectrum of non-compliance that might or might not reach the threshold of fraud.
Yeah. I suppose the question is, is there a line that's drawn through that which would be considered illegal behaviour, and that is just, behaviour that's occurring simply because the legislation allows it to happen, but you haven't closed a loophole, or just people have been undertaking wrong practices for a really long time and nobody's actually brought it to their attention. So there must be a threshold at which you think somebody is intentionally defrauding the Commonwealth as opposed to accidentally. So do you have a number that the department uses, and if so, what is the quantum of that when it comes to the MBS and the PBS? Do you have a dollar value?
Senator, we don't have a dollar value of an estimation of fraud that meets that threshold. That threshold is determined by the CDPP.
What about the total?
Well, the courts would make that determination whether it's been met. So then we may suspect fraud. We may then we'd need to do additional investigations, and that threshold is determined by.
Okay, wind it back then. So, all right, let's not separate it because it's becoming too complicated. Do you have a figure that the department works to, which is obviously the basis of why you think 674 million is a reasonable savings? What do you think the magnitude of non-compliance is in the PBS and the MBS?
So, Senator, the Minister, the Phillip Review indicated that there was an estimated 4 to 7% of non-compliance. Oh, the dollars amount? Sorry, 1.5 to 3 billion.
1.5
that was in the public domain.
Yeah, and that's the MBS?
MBS and PBS and
together.
CDBS, yeah.
Okay, so if it's 1.5 to 3 billion, is that per annum?
Yes, Senator, I think that is
per
correct.
annum. And your measures are seeking to do about $160 million per annum.
Senator, that's on top of the 3 additional measures over the last few years since the Phillip Review, which also had a savings target or estimate attached to those.
So how are they going?
Well, Senator, I can run through what we've done in terms of the measures.
Well, I'm just interested, you must have a number that you think is being claimed non-compliantly now, because otherwise you couldn't have come back to the 674 million. So I'm just interested, because if it is 674 million, which is 160 million or thereabouts per year, I'm just interested in what is the quantum, so I can understand the percentage of what you think you're achieving by this measure. Not the other measures, because obviously you would have assumed that you'd have reduced it by the other measures. But if you don't have that figures.
The costings for those particular savings numbers were built off the interventions themselves rather than a percentage of overall estimates of non-compliance under the benefits programs. So, we would take a particular systems change which would deliver these different outcomes that would save this amount of money. So that's how those costings were reached, Senator.
Modelling would be done by sort of particular issue and risk area. I think the previous colleagues were talking about the EMSN risks as well, so if there was an analysis done of what that integrity exposure might be, that would be done by area. And so in our modelling, we did the assessments by the measures that were developed.
So in this measure, are you particularly targeting anything like a are you targeting doctors for making false MBS claims? Are you targeting pharmacists for maladministration of drugs that shouldn't be charged concessionally but are being charged concessionally? I mean, do we actually, is there any information around the measure about who you're really targeting and for what?
So, Senator, the most significant uplift in capability is our PBS capability and additionality in terms of what we're able to see and areas and evidence of concern that we can investigate further in the PBS. So we could reasonably assume that in the PBS there would be additional targeting.
So can I just ask you what that actually means? I mean, like, targeting the PBS is sort of quite a big statement. So could you maybe explain, like, in terms, like, as somebody listening to this would understand, because I'm not sure anybody listening to this would understand what you're actually doing?
Yes, Senator. So there's... Yep.
Mr. Williams, but I'll give you an example because they occasionally come across my desk. So we might have evidence of a pharmacy where they are allegedly dispensing a number of scripts, but those scripts in a particular area are significantly above what our data matching will say were actually wholesale supplies to that pharmacy, and therefore you can form a view that there's at least worth investigating whether they're actually not dispensing those things but claiming for scripts that either don't exist or are phantom in some other way. And so that's
phantom scripts.
That's an example, and often what you find in the cases that come across my desk is they're very high value items. So they're often injectables or other things where there might be multiple $1,000s each, and so suddenly you can have a pharmacist where it looks like you have $1 or $2 million more being claimed than you can explain by the sort of people likely to be in the catchment with those pharmaceutical needs, or the wholesale suppliers to that pharmacy is an example. So the data matching can throw up those sorts of examples, which allows us then investigate and make sure there's other corroborating evidence.
So how was the $640 million figure arrived at? I mean, obviously it was higher than that, and you've taken the costs of the administration. How did you reach the 600? What was the rationale behind that number?
So each of the measures would have savings model associated with it.
So when you're saying, like, the Secretary just gave us an example of a particular action, that would have a particular amount against the action that the Secretary just described. So each one of those would have, you've gone through line by line. This is the action we're going to take. This is what we think the quantum of the saving is, and you just added them all up. That's as simple as that.
To a degree, Senator. So some of them, particularly the ones associated with behaviour change, so providing additional information to practitioners of their billing and whether or not an item was billed to them or somebody else, or whether or not they understood new items that are being developed. We have a sophisticated behaviour change methodology that's associated with that, so there would be methodology associated with that. There would be, in terms of an uplift in our ability to not only see PBS non-compliance to be investigated further, but also to process that non-compliance through the additional pharmaceutical committee of inquiry capability we're establishing as well. And so each of those items would have associated modelling. I don't have that with me.
No, I wasn't asking. I was just asking what the rationale behind it. You don't need to know the actual specific amounts, although they'd be handy. So, for example, I gave you the example a minute ago of pharmacists who were providing concessional rates when they shouldn't be. I mean, is that something that's on your target hit list?
So, Senator, we maintain a view that all non-compliance will be targeted at any time, and so this particular budget package doesn't have a specific focus on that, but our compliance strategy does identify areas of specific focus for each year. So you'll see that the Department of Health and Services Australia work together to identify the areas of greatest risk and exposure to the Commonwealth, and we do assessments and analysis of that, and we provide to the public and to practitioners a clear insight into our areas of particular focus, and those will vary each year, whether or not it's a new government measure or whether there's a particular exposure, particular risk.
Do you have?
So that's available to the public and all practitioners every year. Annually, we'll update that.
So, what are those for this year?
For this year, online.
You can point me to where I can find it if it's easier.
It's published.
It's
Yeah,
published
just point me to where you can find it.
I'll just find it now.
So, Senator, we treat all tip-offs around non-compliance. We receive, people tell us about things that they think are non-compliant across a range of areas. All of those will be treated. We do not sort of accept any areas of non-compliance.
No, just that if you're targeting
areas of focus, and we put them in our compliance strategy, which is published.
So telehealth?
Sorry?
Telehealth?
Yep.
Care and management plans? Claiming MBS services while overseas? Inappropriate claiming of high cost...
Do you want to just tell me where it is? I can dig it out.
Sorry, Senator.
You just tell me what the link is and I can...
Sure. I'll get that to you in a second. It is, Senator, health.gov.au/resources, publications, Health Provider Compliance Strategy 2025 to 30.
Health Provider Compliance Strategy. Okay.
And then under that there's a link to each of our annual priorities. Senator.
Thank you. That's great.
There's
Thank
also
you.
explanation as to why those have been selected and the evidence we have.
Perfect. Thank you. Can I just ask a couple of questions about the intravitreal eye injections, the bouncing around of the MBS classification? Hi. Originally, could I ask you, were there concerns around the additional out-of-pocket cost for patients identified when the reclassification was first proposed for adoption and it was actually moved and adopted before
Yes, Senator.
the decision was reversed?
Yes, Senator. What happened with the IVI eye injections was the change, as you're aware, made to the classification to allow them to move them to out of hospital. Government then consulted broadly on that change, and there were concerns expressed that this could increase the out-of-pocket costs for some patients.
Okay, so when the decision was made, the fact that there was likely to be out-of-pocket cost increases for Australians wasn't identified. It was identified subsequent to the decision when the consultation occurred.
I think this change was based on a recommendation from the MBS Review Task Force, which probably would have considered, the appropriate clinical setting for these services, the impact on moving between 85%, 75% benefits, out-of-pocket costs. The consultation undertaken by the government, though, afterwards identified that there were significant concerns around out-of-pocket costs, so the government made decisions to address those.
Yep. So is it of the view of the department that the appropriate clinical setting is not for these?
So the MBS task force was very clear that the majority of those eye injections could occur outside of hospitals, which is why...
the appropriate clinical setting in most cases?
In most cases. There are some exceptions
of course.
for people with comorbidities where that would be better to be done in hospital.
But the majority of them, the appropriate clinical setting was for them to occur outside of a hospital.
Yes.
But subsequently the government's made a decision to return them to classification for a hospital setting. Does that mean that they are currently being undertaken in not the most appropriate clinical setting?
So the majority of those eye injections still occur outside of hospital settings, but the reversal of the Type C arrangement allows patients to have those injections done in hospital settings so they can claim their private health insurance.
Yeah. So yeah, sort of strikes me as it was just too hard to resolve the clinical setting argument for those people that were going to suffer out of
I think it goes to a broader conversation that we've talked about earlier today, Senator, around the work that government wants to do on specialist fee out-of-pocket costs. So that work is still ahead of us. But government was very aware of the concerns that were raised through the consultation about the out-of-pocket costs for patients and reverse that decision while we do consultation more broadly around out-of-pocket costs for specialists.
So can I assume the $15 million save that stem from the Minister's decision to reverse the decision around the move from level C to level B?
Type C to type B. That was primarily due to the reduced MBS rebate that the government pays in
for
hospitals. We only pay 75% of the fee. Out of hospital, we pay 85% of the fee. So that's where the save comes from.
So basically, the cost shift went from the government got a $15 million save, and the actual major cost shift moved from the private health insurer back to the private health insurer.
Well, that's correct, Senator, yes.
Okay. Can I just ask around GP practice and bulk billing incentive? Just wondering, can the department confirm that participation in the bulk billing incentive program is voluntary?
Yes, it is, Senator.
Okay. Can you confirm, based on your own figures, that over 30% of GP practices in Australia would be financially worse off if they shifted to a full bulk billing model?
I'd have to have a look at the data. I think when we've modelled this, there were practices that were charging higher out-of-pocket costs that wouldn't be financially better off. That was a smaller percentage. Majority of practices would be financially better off, but I'd have to just check that in the policy impact assessment.
In the modelling, Senator, there were 6,600 PIP practices that were modelled, and of that, 4,800 were considered over the lifetime likely to sign up because it would be better off for them to sign up.
So the 30% number is probably not too far off the mark on the figures that you've just provided, 6,500 versus 4,800.
There is no requirement to sign up, and so...
Yes, no, I understand. Yes, the office officials have just said it's voluntary. So is the department aware of media reports of local MPs, Labor MPs I might say, writing to local GP clinics querying them about why they aren't bulk billing? Are you aware of that?
I'm not sure that's a matter for the department.
No, I'm asking if they were aware of it. I didn't ask them to pass any judgment on it.
Well, I didn't say a judgment on it. I mean,
I think we've heard
aware
about
of media reports.
Senator.
Yeah, most people read media reports.
But mostly for the media.
So I'm just interested to understand, has the department provided this information to local MPs, or have they received it from the minister? I imagine, given you've said that you don't know much about it, that this direction has not come from you.
Bulk billing clinics that are rolled in the program are publicly available, Senator, so I can imagine that those that aren't enrolled can be derived from that.
Yeah, but on the basis of querying practices as to why they are not bulk billing, and I mean, we've actually seen letters that have been sent. I've got one here from the member from Bendigo, Ms Chester's, expressing her disappointment that the particular clinic wasn't bulk billing. So is that something she's done off her own back?
Well, I don't think it's very surprising that local members would be getting the message out across their community and to local businesses about the changes the government has put in place or advocating for increasing bulk billing in their communities. I don't think that is surprising. I think most people would expect their local member to be active in that debate because it's one of the biggest issues that's raised with MPs and, you know, certainly me here in the ACT, it's one of the biggest issues I get is access to general practice at an affordable and accessible rate. So, you know,
So
MPs doing their job and engaging with local businesses, I think that's...
Well, we've just received information from Ms Duroka, and obviously it's been in the public domain that over 30% of GP practice would be financially worse off if they switched to bulk billing. So I'm interested to understand, Minister, you know, Labor MPs are, you know, basically bullying, and I mean, the letter I've read from Ms Chester
What did you
into
say?
bulk
Labor
billing
MPs are what?
Are basically, from the letter I've got here from Ms Chester's, you know, trying to bully their
Well, no,
local...
I don't.
Could I finish?
Think,
Could I finish? You can then respond as much as you like.
I don't think that is a fair assertion to make.
Well, could I finish, and then you can more than welcome to have your say, as I no doubt you will.
Just think about the characterisation.
Yeah. Well, I mean, I would say putting pressure on a practice by sort of, you know, expressing great disappointment that they're not bulk billing when the department's own figures suggest that 30% of practices would be worse off if they went to a full bulk billing model. I'm just interested why they would be doing this when the department itself has acknowledged that 30% of clinics would be worse off for doing it. So you've got your MPs out there, you know, expressing these, making these comments, sort of trying to bully, as I say, their local GPs.
I don't think that is
fair characterisation.
Yeah, a fair
So you think the
characterisation.
behaviour is appropriate?
I think MPs engaging with local businesses and talking about what the government is doing to support their work and engaging in a conversation with them is the MPs doing their job. I don't characterise it as you have in those terms that you are, you know, politically convenient for you. I think it is standard engagement with businesses, and there's nothing to stop those businesses, and I'm sure they did, where it didn't make sense for them or didn't work for their practice in having that conversation.
So have you written to your local GP clinics and asked them?
No, I haven't.
Okay. So,
but that's, you know, that's an individual choice I've made, but I have been very closely watching the clinics that have been. I visited a number and I have thanked them and appreciated the fact that they are. We only have 20 here in the ACT. We've got new clinics coming on board. Again, bulk billing is a big issue, Senator Ruston. MPs writing and actively engaging on this is a good thing. And for those businesses to respond if it doesn't work for them. I mean, we're quite different here in the ACT in terms of, well, only having 20 practices that do bulk bill. We want to see that change. I would welcome to get to a level that Bendigo would have, to be honest.
And Senator Ruston, we will give Senator Brown a spin if you want to, before the lunch break.
Yeah, the only question I was just going to ask is, are you aware, Minister, of how many of your MPs in your party have written to their local GP clinics expressing their disappointment in the clinic for not being fully bulk billed and requesting that they do so?
Well, I think all of the MPs that are in our caucus, and remember this is a policy that you supported as well in the last election. You copied ours.
I supported the choice, Minister. Yep. I didn't support them being bullied into doing it.
Well, I don't accept that at all. That is your kind of politically weighted language there and characterisation. I would say every single Labor MP and Senator has been out talking with general practice about the investments we are making and our attempt to increase bulk billing rates across the country, because it is one of the major issues facing households. And they do that in whatever way they choose to, whether it by letter, whether it be the way I've done it here locally, and many other ways that they have engaged. I think that's entirely appropriate, and I think their constituents expect them to.
Yeah. So are you in a position to be able to answer my simple question?
No, I'm not going to go and survey 94 MPs about the way that they are engaging. What I am saying, all of them have engaged on bulk billing in their electorate.
You should be worried about how they're engaging.
All of them have been engaging, Senator Ruston, and I would think that is an MP doing their job properly on an issue that most constituents care deeply about.
So you don't care about how they engage?
Well, don't verbal me.
On that.
Like, we've got along, you know, for 3 hours and 51 minutes. It's travelled along pretty smoothly, but you have been trying to elicit a response. Don't verbal me.
And we will rotate the call and go to Senator Brown.
Thank you, Chair. I have some questions about the PBS safety net threshold. I think I've only got 9 minutes, so we'll try to get the information I need. So the government's lowered the PBS safety net threshold. Can you quickly explain to me how the threshold works?
Thank you, Senator. So the PBS safety net is designed to help patients that have very high medication needs to ensure that they can afford their medicines. It's designed to help the most vulnerable member of our communities, those who are who require many medications. And so the way it operates is that every time a patient gets a prescription filled, the cost of that medication is added to a tally. And then when that tally reaches the threshold, after that, the payments that they need to make drop. There's 2 safety net thresholds. One applies to general patients who generally pay up to $25 per script. They'll pay less than $25 for many medications because many medications cost less than $25 altogether. So that amount will get added to the total, and then when they reach the safety net, then they get issued with a card, and when they show that card to their pharmacy, they drop back to the rate for concession card holders, which is $7.70 rather than $25. For concession card holders, there's also a safety net which works similarly. What happens with that safety net is every time they pay their $7.70, it adds up, and when they get to the limit, they get issued with a card, and at that point it's free for them to receive additional medications.
Right. So can you just quickly tell me what the... Well, first of all, with the general group of people, that I'm assuming includes families, like children under whatever age.
That's correct, Senator.
That adds to that threshold amount.
That's right. So it's for the whole family. Sorry, Senator, I didn't explain that earlier. But yes, it applies to the whole family unit. So if different members of the family all have medications, then those can all contribute to that total.
Right. And so it's all medications.
All medications that are on the PBS, yes, Senator.
And can you tell me the amounts that you need to reach, the dollar amounts?
Senator, for the concession card holders, it's $277.20 this year.
Oh, that's pretty good.
And for general patients, it's $1,700.
Sorry, 1,000.
$1,748.20.
Oh, right, okay. And given that, the government's also reduced the price of medicines as well, but you mentioned that.
So what that means in practice, Senator, is that patients save on each prescription at the pharmacy counter which means they don't have to spend as much before they're saving on their medicines.
So since those reductions started, because it's been done a couple of times, reduced down a couple of times, are you able to tell me how much those price reductions have actually saved Australians?
Yes, Senator. So the lower safety net threshold has saved patients $665.5 million between the 1st of July 2022 and the 31st of March 2026. And that's accounted for over 88.2 million prescriptions during that period.
That's really good news. One of the issues that came up a couple of years ago was around the introduction of 60-day prescriptions. How's that going?
Senator, the policy for 60-day prescriptions has gone really well. So it's made very substantial savings for patients. It means now that many patients that have stable medications are able to get a 60-day prescription. Often their doctor will offer it to them, but also patients, we encourage patients to ask their doctor whether a 60-day prescription is suitable. And then what that means is that they only need to go into the pharmacy half as often. It also means that they'll pay less at the pharmacy because usually most of the fees associated with the prescription are per script rather than for the amount of time. And so usually they'll make very substantial savings on their medicines.
So if a drug is available on a 60-day script, does the prescribing GP have to give you a 60-day script? You don't have to ask, do you?
You don't have to ask, no. They are encouraged to offer that. Of course, it's not mandatory that they do that because there are circumstances in which it might not be best care. So if the GP is of the view that the script might need to be reviewed in a period, or for some other clinical reason, there's a good reason for the patient to come back on a 30-day basis, then they may not be willing to offer that. But in general, for many medicines, patients are on a stable script, and it simply makes sense for them to only need to get that script issued half as often. It saves patients a lot of money. It reduces the pharmacists are remunerated for that in a similar way, regardless of whether it's a 30 or a 60-day script.
So how many medicines are covered by the 60-day script?
Senator, just give us a moment to find that figure. I'm sorry, I might need to take that on notice, Senator. I don't have that figure immediately to hand.
That's okay.
But it's been a very substantial portion of all of the medicines on the PBS, particularly those for chronic conditions where patients are having to get script month after month, year after year. They can make some very, very substantial savings.
Those extra fees to their GPs. Can I just before, because I'm getting the wind up here, but there was a lot of discussion around particularly about the impact on pharmacies when this announcement was made. Have you been monitoring the impact on pharmacies?
Yes, Senator, we have been monitoring the impact on pharmacies, and there was a lot of concern at the introduction that it might have a negative impact on pharmacies, but in fact we found, if anything, the reverse. There have been more applications for new pharmacies to open during the period since the 60-day prescription came in than there were before that period. So we're seeing a continued demand for pharmacy services and indeed a continued willingness by pharmacists to consider opening a new business. Senator, I think my colleague can help with your previous question too.
Yeah, sorry, just to circle back, there's 300 out of nearly 950 medicines on the PBS that are covered by the 60-day dispensing.
Okay, that's good. That's good. Just so, do you have anything more to add around the monitoring of the impact on pharmacies? Because there was a lot of commentary at the time and some concern about pharmacies going out of business. I know my local pharmacy, who's just had a huge upgrade, so things are going well in his pharmacy. So, was there any other impacts that you've been seeing out of the implementation of the 60-day scripts?
So, Senator, we continue to monitor the health of the pharmacy sector very closely. Community pharmacy is an absolute foundation of the provision of medicines to Australian patients, and it's very important, given the model we have in Australia, that pharmacies can continue to be viable businesses. And it would appear that the policy mix that the Australian government provides continues to provide a very valuable, a very viable business opportunity for pharmacists, and it continues to underpin community pharmacy.
And saving the consumer a lot of money.
The community pharmacy agreement included significant additional investments in pharmacies, so they are doing quite well out of that.
Thank you. Thanks, Chair.
Thank you very much. We will now suspend for lunch and return at 2:05. I'll ask everybody to clear the room swiftly because the committee does have a private meeting. Welcome back, everybody. We will continue on with outcome 2, individual health benefits, and we will go straight to questions, and we will go to Senator Roberts.
Thank you, Chair. Thank you again for appearing today. It was announced, I want to talk about the private health rebate being cut. It was announced in the recent budget that the rebate for premiums paid by seniors towards private health insurance would be ceased. Why? Is this a socialist agenda, Minister?
No, Senator, it's not. We did go through this quite lengthily this morning, and I don't plan to add too much to what the Minister had to say in response to questions from Senator Ruston, other than to reiterate that under the proposed changes, all Australians will now receive the same private healthcare support based on their income, not on their age. And what we've set out is that we will be investing over $3 billion in delivering more aged care beds and more packages and better care for older Australians through this budget as a consequence of this decision.
I'd like to get on to some specifics after this next question. Why does the government wish to punish seniors who mostly have chosen to opt out of the public health system and pay premiums to receive private health treatment and make them pay, and now the government wants to make them pay even more than they currently pay?
Well, I reject that assertion in your question, Senator. We are investing a record amount of funding into improving the healthcare system, particularly for older Australians and aged care in particular. And that's why we've made this decision. Of course, as you will stand up in the Senate many times over the next couple of months and decry the spending from our government, we know that it's important to offset decisions that we have to make. And that is why we have said that this decision will benefit older Australians through the aged care system.
How can you deny that older Australians on private health cover will not be paying more?
Well, we've gone through this morning at length. If you've got a decision about the impact or the policy decision, then I'll direct that to the officials. But I can say to you that we are making record investments in healthcare and aged care during this budget.
The older Australians will be paying more, and I'll get to the point of that in a minute. And this is during a cost of living crisis. How many seniors currently will be effectively forced to pay more for private health cover or enter the public system? Do you have any modelling?
Yes. Senator Ross Hawkins, First and Secretary for the Australia Division. As we discussed this morning, 3.1 million people will be affected by the change in the rebate. We also put on record, Senator, and we talked about at length this morning, that our modelling would suggest that potentially about 44,000 might drop out of having cover and then therefore no longer engage with the PHI system.
Thank you, Mr Hawkins. That's what I was after. What will be the effect on the extra load being placed on the public health system? Hospitals are already short of beds now.
As I said, Senator, our modelling would indicate that it's less than 1% impact on the public health system. And as we again went through quite a lot of detail this morning, that would be spread across, not everyone would need to use the system at any one time. Also, that we might find that people would decide to opt out of PHI, but then self-fund any care that they would need.
We're already critically short of beds in many hospitals due to mass immigration. We've had a post-COVID injections, cancer detection has increased dramatically. Cancer deaths have decreased, and that's because of treatment. But the beds have decreased. The beds available have decreased. This is going to add more strain to the public health system.
So, Senator Celia Street, Deputy Secretary, System Strategy Group. So in relation to the public hospital system, also invested an additional $24.4 billion into the public health system, bringing it up to $220 billion over the 5 years. So yes, there might be some additional. We've said it's less than 1%, and that we think is, on the higher end in terms of that estimation, because we do think people were potentially to self-select or into private, or they may be people that were less likely to use the services anyway. So there's a number of factors that contribute to that number. So we think that this investment and this measure is going to have minimal impact on that element.
Thank you, Ms Street. What will be the total value of the extra premiums raised by those who choose to stay in the private health system?
So, Senator, the average that we've calculated is about $250 impact on those that will have their rebate reduced. So everyone will still have access to the rebate, but it's the size of the rebate that's reducing. And our average calculation is about $250.
How much is the government planning on saving by refusing to rebate premiums for older Australians? Or cutting them back?
Senator, by cutting the rebate, we're looking at $3 billion.
Has the government modelled the extra costs of the public system by absorbing older Australians who are more likely to require major healthcare in their elder years?
No, Senator, we haven't got that specific level of modelling, but as I said, what we have kind of looked at and modelled is what we think the impact would be, and that's under 1%.
So what about the chronic shortage of beds, doctors, nurses, specialists and allied health professionals in public hospitals?
Senator, that's veering a little bit into kind of outcome one public hospitals, but I've got Caitlin O'Brien from our public hospital team who want to talk about the investment that the government's putting in through the NHRA agreement that we've put in place. But did you want to cover that, Caitlin?
Thank you. Caitlin O'Brien, Assistant Secretary, Portfolio Strategies Division. So as Ms Street was saying, there has been an additional $219.6 billion over 5 years invested into the state and territory-run public hospital system. Your questions in relation to workforce capacity and beds are best directed to state and territory governments who, under the National Health Reform Agreement agreed on the 30th of January, are very clearly listed as the stewards of their system.
Haven't you assessed that before making the changes?
So as we indicated, we think it's less than 1% additional, and we think that's at the higher end in terms of that estimation. So in terms of that fiscal impact, that will depend on the services that people need, because we do understand that most it will depend on the service that they're seeking that treatment for.
And Senator, again, the officials made this point, but we're investing almost $25 billion into the hospital system over the next 5 years.
And as I believe, reportedly, Minister Claire O'Neill said that the budget is deliberately hitting older people. It's a tax grab because you're paying for so much waste in the government.
I don't think that's what Minister O'Neill would have said, but
it's a fact.
I think you might be verballing her.
It's a fact that the budget, I'm just going on reports, it's a fact that the budget is also hitting young people. And so what I'm getting at is that there's a cover for the massive waste within your government spending, and now you can ask older people to share in that.
No, Senator, what we're doing is we are making record investments in once-in-a-generation reforms in aged care, in healthcare, and that includes $25 billion, almost $25 billion into public hospitals, funding the states and territories to do the very important work that they do in making sure that the public hospital system is free.
It's a fact, Minister, that older people will be paying more.
Well, Senator, we've changed the rebate so that now it's means tested, so it's based on income now. So we can take you through how that might impact certain cohorts, but we have changed the rebate so that now it is means tested on income.
Thank you, Chair.
Just point of clarification, Minister. You just said that you've changed the rebate so it's means tested on income. Are you suggesting that it's currently not means tested on income?
No, I'm saying that is not what I said, Senator.
Well, you just did say that.
Well, Senator, I'm not going to go back over the evidence that Senator Gallagher gave to you this morning. What I'm saying to Senator Roberts is that there is a means test for the rebate that is based on income.
Now.
I think what the
how
Minister
semantic is do you want to get?
No, you just said that it is now going to be means tested. It has always been means tested.
Well, I think, as the Secretary said, it's solely.
Solely means tested. In fact, hasn't always been means tested.
Okay, it was means tested prior to this change.
It was, but it was not means tested on introduction in 2000.
It's been means tested up until now. Sorry.
Senator Roberts, are
finished.
you're finished? Yep. Okay. Senator Ruston.
I didn't need to even ask to interject, did I?
No, you really didn't.
Well, look at me. I'm going to waste all that energy. Actually, while we're still on private health insurance, I think it was perhaps you, Mr Hawkins, earlier, gave me a figure in relation to the average premiums paid under each for under 65s, 65 to 70s and over 70s. Have you got that data readily available?
Yeah, Senator. And so if we go for the average premium after rebate, you happy if I give you gold through those, or how would you like me to stratify it?
Well, maybe you can do them both.
Pardon?
Maybe you could do them both.
Because we can do basic, bronze, silver, gold for each of those age cohorts.
Okay.
And then kind of what we would see as the average benefit. So if you go for your under 65 years,
Yep.
and I go basic, bronze, silver, gold, it's 933 for basic.
933.
Yeah, 1,204 for bronze.
1,204.
1,638 for silver.
1,368 for silver.
And 2,919 for gold.
990 for gold.
And just for clarity, that is under the current rebate settings. The average premiums after that kind of rebate is taken off.
For which group?
Under 65s.
Under 65s.
On the basis
And that was for the
base tier. Mr. Hawkins said basic, but he meant base tier.
So base tier, yep, okay. Base tier, yep, base, okay.
And if we keep going, you happy for me to keep going down the base tier?
Yep.
Yeah, so then 65 to 60. Sorry, Senator,
This is probably the only tier
So
we've got.
age 65 to 69.
Yeah.
For the base, on basic, it's 883.
883.
On bronze, it's 1,140.
Yep.
Silver, 1,551.
Yep.
Gold, 2,765.
Okay, yep.
Okay, if we go to aged 70 plus.
Yep.
It's 834 for basic.
834.
1,076 for bronze.
1,076.
1,464 for silver. 464 for silver.
Yep.
And 2,610 for gold.
2,610 for gold. Thank you very much. That's very useful.
And then, Senator, I don't know if it's of help, but the average benefit paid for under 65 is $826.
826.
Just under 65 is 826. The average for 65 to 69, the average benefit paid by insurers is $2,969.
Mm-hmm.
And then for 70 years plus, the average benefit paid by insurers is $5,099.
$5,099. Just earlier in answering to Senator Roberts' questions around the 1%, do you have that in terms of what it means in dollars and people and beds?
No, Senator, we've got it in kind of real numbers, and we think, as we said, it's under 1% of that, kind of does that 44,000.
But what does that mean when you say 1%? What does that mean, like, in dollars?
So when we've taken the average activity across public hospitals and applied that number to it, is less than 1% of activity.
Yeah, but what is that in dollars?
Oh, I'd have to take that on notice, Senator.
Okay. Okay. So, in relation to the numbers that you've just given me for the over 65s, for the base tier for under 65s and over 65s, I might just do some calculations and come back to you on that one. So earlier you made a comment, and I'm just seeking clarification on this, that you believe that of the 44,000 people that you believed are likely to drop their private health insurance as a result of this change, that you believed it would be healthier older Australians who would drop their PHI rather than...
Sorry, I think I said may be the people. So in terms of, there's lots of factors that may mean that people make those decisions, and one may be that they're less likely to use it. So they might not be someone that's receiving that $5,099 benefit at this time.
So I think what Ms Street was referring to, and this is kind of well known in insurance, is that what's known as adverse selection, as I'm sure you know, those who have a better understanding of their risks will make choices about insurance. So one of the factors you would expect in any insurance market is those that self-assess their own risks as lower are less likely to insure. That's really what Ms Street was saying.
Sorry, explain that to me again.
Sorry. In any insurance market where there is more known about the circumstances of the risk to the individual than the insurer, those that assess themselves of having lower risk of requiring to claim are less likely to take out insurance. So that was one of the factors that Ms Street was putting forward, if you know you're a relatively less likely to use the system, or that's your view, that is going to factor into your likelihood of taking out insurance.
Okay. So ipso facto, the suggestion would then be that people who are sicker are more likely to stay on the PHI.
That's right. It's that everything else being equal, you think those who think they have a higher likelihood of claiming, and we would see that not just for elderly, but if you're, for example, thinking about a younger person thinking about, am I going to use maternity services, or is there a risk of mental health claims, etc., you're more likely to take out a gold cover than if you don't know that. So that's another form of what...
Yeah, I think if we're talking about mental health and maternity, they're a completely different construct than what we're talking about here, but nonetheless. So did you model in any way, shape or form the likelihood of the people who dropped out being low drawers on the system as opposed to people who would draw more on the system, and the impact of that in terms of health and wellbeing and the like? Is that modelled in your model?
So, Senator, as per my evidence earlier today, the model factors in behaviour of individuals based on historic changes to a range of inputs, economic factors, changes in premium amounts, and then will, based on those inputs, through a statistical model, would anticipate how many people are expected to be in different levels of private health insurance. So that is what it takes into consideration, not people's feeling towards whether they will value it or not, or as the Secretary has said, if they feel they will use the system more. The model doesn't have those inputs. So the 44,000 was based on the inputs that I described earlier.
Okay. You also, I think, said that you thought that people might reduce their cover from gold to silver plus, even though you haven't modelled the impact on the financial impact on that potential change. So I'm just keen, I know anecdotally we talked about it, but what are the main differences that older Australians draw, what are the services under gold that older Australians draw on?
Briefing papers, the top 5 conditions that people seek treatment for in private hospitals.
I can give you those, Senator. We've done some analysis just in terms of what are the kind of ADRGs that are used. Chemotherapy.
What are the ADRGs?
The diagnosis reference groups. So if you like a kind of the grouping. So we're a little bit careful about what's included and unpacked underneath of those. But chemotherapy and pharmacotherapy is kind of one. Lens interventions.
What?
Lens interventions. Eyes. Hemodialysis. Bone diseases and colonoscopies are the most utilised services.
Okay, so not replacements?
No, that's generically.
Yeah, so just saying to Mr Hawkins to be helpful, I think your question was, and I don't want to put words in your mouth, but which are the services that you have to have gold to be covered for, whereas those are the 5 that are generically used by higher age groups?
No, I want to know.
So,
I think, yes. Thank you, Secretary.
And I don't think I have that in front of me.
I think I have to take that on notice, Senator, to specifically go back to kind of what's utilised under gold.
Main one's hips, isn't it?
Okay, so you made the statement earlier that you believed that people would drop from gold to silver plus because they would still probably be able to access the services they wanted, but you don't know what those services are.
No. So I guess one of the things, and we've acknowledged this before, is there's a price pressure on gold. And the price pressure is to a large extent being driven by the costs of mental health and maternity. So what some insurers have been offering older Australians is a silver product plus product that covers all their key needs but doesn't cover psychomaternity, so they can offer a...
Yeah, no, we get psychomaternity, but do you need to have gold covered to be able to get hips and knees replaced?
So there are some silver plus products that offer that. So I don't have a count, Senator, but they are out there.
So you shouldn't...
Insurers have been actively writing to senior Australians to promote some of these Silver Cross products.
So what would be the main thing that an older Australian would use their gold cover to access? Is it joint replacements?
So, Senator, that's why I think we've agreed to have to take on notice to make sure we're giving you accurate advice.
Would it be one of the higher claiming?
I would assume so.
Sorry?
I would assume so.
You'd assume so.
Now, to what extent that's covered under Silver Cross products or silver products?
Okay, because it was just, and so obviously, a joint replacement is quite an expensive procedure. So, do you have? Give me a ballpark range of what a hip replacement is likely to cost.
We don't have those with us today, Senator.
Are we talking thousands or tens of thousands of dollars?
Net of private health insurance?
No. Just what would be the cost to an individual if they didn't have their health insurance and they chose to pay for it themselves?
We're just looking at some cameos, but it is highly variable, which is part of the reasons the government's
Give me
a specialist.
A big range.
Well, it is a very big range.
It is because of the nature of whether the out-of-pocket, the product someone's on, kind of.
No. They're not on a product.
It can vary by state. It can vary by doctor. It can vary by whether there's an out-of-pocket fee or not.
I know that.
So it can go everything from here to here.
Could I get a hip replacement for $25?
Well, Senator, we'd have to check to see whether or not there is any offering any kind of no-gap product. I wouldn't want to provide you evidence to say no until we've done our check.
Are you serious?
Senator, what I've said is there's some no-gap products that exist.
No. This is somebody who has no health insurance. If I walked in to somebody's surgery and said, I want a hip, an orthopaedic surgeon said I wanted a hip replacement, how much would it cost me?
Yep.
What's the lowest you think it'd cost?
Well, that's what we'll take on notice, and we'll just check on medical cost finder, and that'll give us an average. But someone will be doing that in the back now for me.
Okay. All right. Well,
we can give you an average cost. Get someone to get that cost for me.
Okay, that's fine. If you want a bit more time, because it just seems to me that you made a comment earlier. I think it might have been Mr. McBride made the comment earlier that he believed that there would be a number of people who may well choose to drop their cover because of the increased cost and actually self-fund. So if you're going to make comments like that and you don't actually know how much the procedures are going to cost, it's interesting. Do you know how much they're likely to be paid? And so
that's two separate things. I said some people may downgrade their cover from gold to silver or silver plus, and that might be a quite
No,
logical...
you said you thought they might self-fund.
No, sorry, two separate things, Senator. I said they may downgrade from gold to silver or silver plus, but some people who drop out of private health insurance for minor procedures may self-fund. So we had, with our MBD colleagues before, a discussion about IVI injections in hospital, a relatively low-cost procedure. Someone who dropped out of private health insurance may still take that procedure in hospital and pay for it. So those lower-cost ones, I'm not suggesting that someone on an age pension would suddenly self-fund, necessarily self-fund a hip operation in a private hospital. But a significant portion of private hospital separations are self-funded.
Yep. So is there any way that you can provide us with the granular detail about how you actually achieved all the assumptions? Because I've read the impact analysis and it doesn't actually provide any of the kind of detail that we're talking about now. I'd like to understand what the assumptions were and how you actually costed each of those assumptions and how you actually modelled the value proposition of each of those, because it seems to me that there is not a lot of information behind why you've reached the conclusions you have, that it's 1% or 1% your threshold mark, the 44,000. Your assumptions contradict much of what has been put in the Finity report. So are we able to actually get, because I think you mentioned in the impact assessment that it was done under a particular model, and it refers to the model, but when I go onto the APH website, I can't find that model.
So, Senator, we're happy to take that on notice in terms of the provision. I understand that we also have a freedom of information request from you that goes to some of this as well. So, we will try and pull that information together in terms of, you know, the discussion in terms of what's in the model and the modelling and the elements that go behind that impact analysis.
So you couldn't provide me with your analysis, your actual modelling analysis, so that we can have a look at it?
Senator, so we're happy to take this on notice. I just want to really reiterate this issue about what we think is both modelling and analysis, which are not necessarily the same thing.
We'll provide them both.
Well,
let the official answer the question, Senator
so
Ruston.
the formal model we've used, using back-looking historical data and changed in incentives, gives us an input into the change in behaviour. The sort of analysis that Mr Hawkins is talking about refers to the actual incentives you would look from a bottom-up micro basis as to what people get out of a product versus what they pay for a product, which gives you an insight into what they're likely to do, which also gives you greater confidence in whether the underlying modelling is correct. The issue of what happens to the 44,000 displaced, as we've earlier given evidence, there's a number of categories. Some may have already been accessing public hospitals for services, so not displaced into the public system, because there are quite a lot of patients who are privately insured that still undertake public procedures because they look at out-of-pocket expenses and decide not to do that. Another proportion will choose to self-insure and pay for the procedure themselves, and others may be displaced into the public system. So they are the categories that we're happy to provide you with some information on, but it's not all linked up into one grand, unified, quantitative model, because that's not the way you do this sort of analysis. But we're happy to take on notice what we can provide additional information above and beyond the detailed impact analysis that's been published with the measure.
I mean, I think you'll probably see from the questions that have been asked that the frustration is that there's a whole heap of assumptions and information that's been provided today, but you don't have the evidence to back up why you said it. Now, obviously, as you're saying, you do, you're just not providing it. So it's quite frustrating. We've been talking about this for a while, and there is very scant data that is sitting behind how you've retrieved the assumptions that you have provided, and you clearly haven't consulted, because when you read the impact assessment document, it actually says that you haven't. What do they say? It was. They described it as. That it was adequate, but it hadn't been consulted.
So we consulted on the budget.
Yeah, here it is. It says here, the Office of Impact Analysis assessment is that the quality of the analysis in the IA is adequate to be considered good practice as per the guide. The independent assessment would have benefited from further consultation.
So the affinity process, we didn't consult on this actual budget measure and its likely announcement, but we did the affinity process that looked at lots of options around what could be done to change the rebate settings, and this was one of those options consulted on and talked through as part of that process. So although this measure, as it was announced in budget, wasn't specifically consulted on, some measures very, very similar to this had been discussed with the sector through that affinity process.
But the Office of Impact Assessment have been critical of your consultation.
Because they said we hadn't consulted on this actual budget measure, which is true. We didn't consult on this measure as it was being developed for the budget process, but we'd consulted on something very, very similar 3 years ago through the affinity study.
Okay. So back to the figures that you gave me earlier about what the average is paid. I'm interested to understand what the average insurance payment is for people under the age of 65 in terms of what is the average amount that they pay for insurance. You gave me the figures of what the average amount they pay in each category is, but what is the average amount they pay in total?
So that was the total. That was net of any rebate they're entitled to. So that is their out-of-pocket for their insurance premium.
Okay, so well, perhaps then what is the percentage of each of these categories that hold those. So you've got we're talking about the base tier. You've got basic, bronze, silver and gold for each of the categories. But what is the percentage of people in each of those categories?
I think I have total numbers, but not actually percentages.
Well,
I
think Mr McBride previously provided the percentages for the over 65.
Yeah, we had the 42,
41-ish for gold and silver. And then
so I'm just be really interested. Yeah, because I mean, it'd be interesting to understand, if you were able to provide this advice. So we've got the numbers of what the average payment for each of them are. It'd be interesting to know what the average, what the percentage of people in the under 65s, the 65 to 70s, and the over 70s. What percentage of those tiers are held by each of those people? And then the numbers of people that hold.
We have that, but I didn't bring it today.
No, I wasn't. So if it was possible for you to be able to provide that, so we can just get an understanding, because it appears to me from the discussions that we've been having that older Australians, many of whom are pensions, are already paying substantially more for private health insurance than younger Australians, simply because of the nature of the way they hold their private health insurance. And it could well go to some of the things that you were just saying, Secretary, about younger people think they're invincible and not going to need their private health insurance, and it's not until they start getting a little bit older that they start realising that actually maybe this is an important thing. That might be the rationale, but I'd really like to understand, because it does appear to me that older Australians are already paying substantially more into the private health insurance pool than younger Australians. Okay. I'm happy to...
I think Senator Nandaraja just has a couple of questions, and then we will move on to the next outcome.
Oh, I haven't finished this outcome.
Oh, okay. In which case, keep going.
Oh, okay. Right, okay, Did you have any on this one, did you? Not this outcome. Just quickly, on primary care, again,
It's a broad topic.
Hi, Mr McCabe. Just in relation to the budget measure about 6 government-funded clinics in the Hunter region, the Minister is quoted as saying, and I'll read it, this is from a 20th of May 2026 Newcastle Herald article, and it quotes the Minister as saying, there is simply a cultural issue in general practice in this region, and we're determined to change that culture. So I just wondered, in deciding to put these government-funded clinics into the Hunter region, what was the rationale behind this so-called cultural issue with the GPs in the region?
I'll just direct you to
Senator,
my colleagues.
Sorry, Mr Rodham.
Really relates to the lower bulk billing rate in the region, 67.1% in the Newcastle and Lake Macquarie regions, compared with the national average of 81.9%. So really the department's advice was based on the data that the bulk billing rate in that region is lower than we would like, and this intervention is required.
But I'm just sort of interested to understand the use of the word cultural. So I don't know, Minister, whether you wanted to add anything to it. What does the Minister mean by the word cultural? I mean, I understand that that there are regions that have got lower bulk billing rates than other regions, but how does that become cultural?
Well, I think that the Minister's framing of the issue goes to the rates of bulk billing, which has just been explained to you.
So you think the rates of bulk billing are cultural?
Well, that's exactly the reason for the intervention, Senator.
Okay, so you made a comment, Mr. Rodham, was it the, or maybe it's you, Mr. McCabe, the bulk billing rate in the region? What
That is, for Newcastle and Lake Macquarie Centre, it's 67.1%.
67.1%. And when are those figures from?
That's for an average of the first 3 months, across the first 3 months of 2026. And as I said, compared with the national average of 81.9%.
Okay, because I mean, obviously we're working on different tables, but according to the table that I have here, the Hunter New England Central Coast region has got a 77.89% non-referred attendance bulk billing rate.
That region, Senator, sounds like it's the primary health network region,
Yes,
which would be much broader than the targeted investment here.
Okay, so the 67.1% bulk billing rate in the specific area, so is that an SAS area or what?
It's the Newcastle and Lake Macquarie regions. I can't remember which SA level they are, Senator.
Oh, okay.
Yeah.
Is that the lowest in the country?
Well, the ACT is definitely lower than that, Senator, as we've heard earlier today. So,
so in terms of the listing of at that regional level,
it's certainly much lower. Sorry.
Yeah, I was going to say, is there a list of the bulk billing rates at that more granular?
We can provide that on notice. It's certainly a rate that is much lower than you would expect, given the socioeconomic status, etc., of the region.
Okay, so it's not the lowest. Are there other areas that are lower, not just the ACT?
I'd need to take that on notice. I don't have the full list of data at that regional level with me.
When the decision was made for this particular region to receive 6 government-funded GP clinics, which are, for the record, are not urgent care clinics, they are government-funded and operated clinics.
Well, Senator, the government funding goes towards them. I don't think it's quite correct to characterise them as completely government-funded. There's assistance from government.
So explain to me the difference between these clinics and the UCC.
Well, an urgent care clinic is to take pressure off emergency departments.
No, in terms of the operation.
In terms of the operation. So in this example, or in this this policy, essentially it's to fund things like capital costs, fit out, staff, attraction, not wages and salaries, whereas urgent care clinics fund, there's operational grants, the funding for wages and salaries, etc. So it's a more comprehensive funding arrangement for the urgent care clinics.
Okay. So what was the process that was gone through in order to identify this region for why these particularly specially government-funded clinics were going to be located in this region? What was the process you went through?
Looking at the persistently lower than expected bulk billing in that region over time, noting that while I think there's been an improvement since the bulk billing reforms from November last year have been introduced, that hasn't been to the extent that that we would like, and so this specific intervention, which we've seen unfold in the ACT, as I said earlier, with clinics to open very soon, is something that's been replicated here with up to 6 clinics in this region.
I suppose I'm just keen to understand, this isn't the area in Australia with the lowest bulk billing rate. It is a low bulk billing rate relative to the average, but it's not the lowest. So I'm just understanding what process did the department go through? I mean, did the department recommend to the minister that these are the 6 clinics that should be first opened, or did the government indicate to the department they wanted the clinics in these areas and then ask you to build out the policy from there?
Well, that goes to the nature of advice given to government, but we have, as I said, we've been concerned over a period of time about the bulk billing rate in this region, and we're very pleased, as I said, with how a very similar initiative is unfolding in the ACT, and that's a model that has been largely replicated in Hunter and broader regions where this is being rolled out.
I'm just keen to understand, I mean, you're obviously taking on notice the other areas they've got lower bulk billing rates. So in terms of, what other sources of funding do these particular clinics have? Can they charge... they obviously can't charge patients a copay.
That's right.
So they rely on the Medicare billing rate?
That's correct.
And the additional payments that are being provided?
Yes, the
So
workforce retention and capital fit-outs, as I said before, yes.
Okay. So I'm just really keen for transparency about how this came about, why these 6 were chosen. You were saying it goes to the nature of advice to government, but I don't know, Secretary, what is your requirement as the Secretary of the Department in charge of the expenditure of this money? What is your obligation to make sure that the government is not just pork barrelling into an electorate? What is the robust process that you put around what you do in a situation like this to demonstrate that there is a valid and justifiable decision-making process that sits behind the decision to expend this money in this specific region?
Well, the first thing we start with is what the government objectives are in terms of the public policy, and those government objectives are to try and move the bulk billing rate to 90% across the country. And so we would look at whether... we would also, first of all, look at what interventions are currently in place. Now, obviously, across the country, there's a very wide variation in bulk billing rates. Western Sydney is the peak at sort of 98-99%. Canberra's the lowest. These regions, the regions in Hunter, this one in particular, is quite low. The comment Mr. Rodham made was particularly with respect to the socioeconomic status of the area, which can predict bulk billing rates. So our obligation is, when we're thinking about proposals, do we think this is meeting government objectives and is reasonable value for money? Essentially, the thing we're probably comparing against here is, do we have some of these targeted interventions, or do we, for example, try and move the bulk billing incentive across the country, or the incentive for practices? And the view, starting with the ACT, was it's going to be more cost effective to start with some localised areas where we think the bulk billing rate is stubbornly low. So if we can convince ourselves that it is making a contribution to those overall government objectives and it's a cost effective way of doing it, then that would form a view of whether we would recommend a particular site be chosen.
So did you recommend these sites to the government?
I'd have to... certainly these are the areas that jumped out at us, but I'll have to go back on the process of exactly what the toing and froing. Certainly we have no discomfort that these are areas that are stubbornly low compared with other comparators in their bulk billing rates.
Yeah. So would it be possible, obviously I can FOI it, but would it be possible to be provided with the process that was gone through to establish why these 6 particular clinics were the ones that the government chose, so that we can understand the process that has been... So
I think just Mr. Rodham might want to comment. I think there's 2 issues here. One is the region in which you do it, and then the second is the selection of the clinics. So the initial stage was this decision about which region is targeted because of the issue of the bulk billing rates. The process by which you choose the particular clinics...
Well, that'll be a Primary Health Network's commissioning process, and that's why the policy is that it's up to 6 clinics. So you're talking about a much broader geographic region in terms of size than the ACT. So there are 3 in the ACT. You've got up to 6 for this region. So the distance to be covered was really a factor there as well. But it may be that when the Primary Health Network undertakes the commissioning exercise, it might be 5 rather than 6 or 4. We'll see.
It's the process around the region that I'm most interested in, so if you're able to provide me with that about who made the decision and what was the process that was associated with it, because it just seems rather strange that we've just got 6 clinics that have all gone into one area that is not necessarily the...
Senator Ruston, the Minister had said previously that if there were particular markets in the country, like Canberra, then that we just weren't seeing that increase that we've seen in other markets, then we would look at taking action, and that's why the government's made a decision like this. Those 6 clinics the locations haven't been selected yet. We can give you more information on the process.
I'm not particularly worried about. I'm more interested in the selection of the region, because I mean I accept, Minister, that there is clearly from the statistics that that there is an issue in the Hunter region, but there is almost certainly issues in other regions that haven't had this intervention. So I just would like to understand why this was the only region, apart from obviously the discussion we're having about the ACT, why this was the only region outside of the ACT that we were even discussing, why the other regions weren't considered. So I'm not for a minute suggesting that the Hunter does not have low bulk billing rates. I'm not doing that at all. So, okay, well, I look forward to receiving that further information. Can I just ask some questions around mental health? What time are we supposed to finish this?
Sorry, can I just check, are we in outcome 2 or outcome 1?
2. It's 2's mental health, isn't it?
So if you're asking about, for example, better access, yes, then that's outcome 2.
So I'll try and move through these because obviously we've got a lot to get through. So just keen to understand if there have been any changes to the minimum time restrictions for reviewing mental health plan reviews that have applied since the 1st of November last year.
Senator, no, there hasn't.
Okay. So according to the Services Australia website, a review should not occur within 3 months or within 4 weeks of a plan being prepared. Is exceptional circumstances clearly defined in this?
Certainly the regulations allow for a review to be done in less than 3 months. Where exceptional circumstances, I would have to check if we've got a definition of exceptional circumstances somewhere. I don't have that with me.
Okay, well, that would be helpful. Thank you. Is the department aware of an open letter that was sent by over 450 psychologists that have raised concerns regarding how the Medicare health outcome items changes, which they are referring to, which you say haven't occurred, have been implemented specifically around the minimum time periods for re-referrals?
Yes, we've been provided with a copy of that.
Okay, so what are they talking about if there is no change?
So, Senator, it would appear that some providers misunderstood when, from 1 November, I'll go back a step, from 1 November we removed the specific MBS item for a mental health treatment plan review. That item could only be claimed every 3 months. Now, to undertake a review of a mental health treatment plan, a GP will claim a general attendance item. It would appear that some providers thought that you could undertake a review with a general consultation and not use the review item that could only be claimed every 3 months. Okay. That was not the case at all.
Okay, so there was no change, that these people have just misunderstood what was said?
Yep.
Okay. All right, well...
Maybe just as a point of interest, Senator, the number of people receiving services under a mental health treatment plan that require more than 6 in less than 3 months, or actually the number that we're using, 10, so where exceptional circumstances may have applied, was 0.1% or less.
That 0.1% still represents real people.
And that's probably being applied where exceptional circumstances exist appropriately.
Okay. So on the basis of the clear miscommunication, misunderstanding that's occurred here, have you considered putting steps in to make sure that communications are better?
So we've recently updated a number of resources that are available on the website that go to this issue, and that probably prompted people to consider what they previously misunderstood.
Yeah, okay, cool. So can I just ask about the HTA review, that hoary old chestnut? Hey, you thought you were getting away with it lightly today.
Famous last words.
The HTRO review was provided to the government over 2 years ago now. So maybe, Minister, can you confirm how many of the recommendations have been fully implemented?
Just give me 1 second, Senator. I might have to get... I think the officials next to me will have that information while I just scan through the information I've been given.
Senator, we can take you through the work we are doing to implement recommendations from the HTA review.
So can we, in the first instance, just answer the question of how many of the recommendations have been fully implemented?
Ms Shakespeare can provide a more detailed argument, but answer. But a number of the HTA recommendations are... I think it's not quite as straightforward to say is something fully implemented or not, because they are sometimes quite high level.
Yes.
Some people would take the view they have been fully implemented. Others would say it hasn't gone as far as I'd like. So I think it's not one of these reports that's as clear cut to say tick, cross, it's been fully implemented.
So, for instance, HTA review final report recommendation 1. Which was to reduce health inequity for First Nations people by establishing a First Nations Advisory Committee to advise the Pharmaceutical Benefits Advisory Committee on matters for First Nations people. So there has been a meeting between the PBAC and the community controlled sector, which has been established now, and that has had meetings, and one occurred last week. So I think that there's probably more work that we'll do over the years on this, but you could say that that recommendation has now been implemented.
Or you could say it's in progress.
Senator, just as a point of clarification, the meeting Ms Shakespeare referred to last week has been slightly deferred, so it'll be next month. But it is scheduled. It was scheduled for last week, and therefore Ms Shakespeare's notes say that it. But in fact, it had to be deferred in order to accommodate the schedules of the participants. But it will be held in shortly.
Yeah, I think, with the greatest amount of respect, I don't think you could call something the convening of a meeting the full implementation of a recommendation. But I certainly, from the description that you just gave us, Ms Shakespeare, I would concede that it is in progress. So I'm just interested to understand, because there is such community anxiety out there at the moment amongst the stakeholders that this review just keeps on getting kicked into the long grass. So I'd be keen to understand if you could give me maybe, and not right now, a progress report against the recommendations of each of the recommendations, what action has been taken, what action is yet to be taken but is planned, and how many of them have had no response at all. And I suppose the question back to you, Minister, will the government commit to a formal public response to the review's findings?
So as you know, Senator, the government announced immediate steps that we were taking to bring medicines and new treatments to Australians sooner. I won't step you through those, but you are aware that there was a number of immediate actions that the government took. We are working with the Implementation Advisory Group, which is independently chaired, and the findings or recommendations of the Implementation Advisory Group about how to implement the HTA review is being considered by the Minister.
So the recommendations of the Implementation Advisory Group are being considered by the Minister.
Recommendations might be the wrong word in this context, but we're working with the Implementation Advisory Group, and that work is being considered by the Minister. I can't add to that in any way.
Yeah. You will excuse the sector's view that this is the review of a review of
Well, no, it was a really comprehensive report, and there was a lot of recommendations, I think over 50 possibly recommendations across a range of areas. That's why the Minister established the Implementation Advisory Group. We wanted to make sure that the critical reforms and findings of the recommendation of the HTA review were guided by the Implementation Advisory Group.
Okay. We seem to have a lot of guiding and advice and meetings, and we don't actually seem to have much reform. The HTA review gave the government a roadmap for fixing a system that it's, you know, I think its own commission experts identified as failing patients. Were there any meaningful measures funded in the 26-27 budget?
Senator, there was $5.9 billion worth of investments in $5.9 million worth of PBS listings funded in the budget.
No, I don't think, with the greatest amount of respect, Ms Shakespeare, that is actually even remotely relevant to what I'm saying. We're talking about the HTA review, not the funding of PBS listings. I mean, I understand the review is about the process by which those PBS listings come to pass, but that is not the issue that we're talking about here, and you know that.
Well, I think that there is a recommendation, for instance, in the review around having an approach where we might have tumour agnostic listings. One of those was funded in the budget papers. So what looks to me like in a subsidy scheme of this nature, the first listing for a medicine that can be used across different tumour types, regardless of the tumour type, regardless of the evidence that has been produced. So this was one of the recommendations. The government has responded to that in this instance by listing nivolumab and ipilimumab for people with all types of tumours.
A very long bow to suggest that funding relates to the implementation of the HTA review. So I'm just keen to understand what's holding this up. I mean, the review came down 2 years ago. There was, at the time, great fanfare, I think great relief because it had been a long time coming. It was immediately put back to a group, including Medicines Australia, about building out the program to enable the implementation of the review. So as we sit here today, over 2 years later, with much promise and not a lot of action, I'm just interested to understand, is the reason that the review implementation is going so slowly? Is it cost? Is it capacity? Is it political will? What is it that is actually holding it up? And maybe that's a question that the Minister is probably better placed to answer.
Perhaps if we take you through what some of the recommendations actually recommended and which required further work. Yeah. And we could take you through some of what the recommendations were, what the further work is, how that's being implemented.
I think
that
you took on
help.
notice. Yeah, I think you took on notice that you're going to provide me a review of where everything's at. But I'm just keen. So I suppose a question to you, Ms Shakespeare. I mean, you've been involved in this right from the get-go, so quite invested in it. Do you think that the implementation of the HTA review is going at the speed that the stakeholders were expecting?
So when, again, we look at the nature of the recommendations, things were like establish a stakeholder engagement framework. The work has been happening with the stakeholders about establishing that stakeholder engagement framework. Recommendations around establish a working party involving the PBAC and the Therapeutic Goods Administration to develop guidance on extending the use of TGA-registered therapies to paediatric populations. That work is continuing, but it involves consultation with a range of different groups.
Yeah. My
it's not things that the government can say, right, well, this is going to happen now. We need further consultation. We need to establish frameworks. So these are the nature of the recommendations from the HTA review.
Okay. So my question was actually to you, well, maybe I shouldn't be asking less of opinion. Have you had feedback from stakeholders in the sector that the HTA review is being very slow in terms of its implementation? Have you had that feedback?
I've had that feedback from medicines companies.
Just medicines companies? Mind you, they are the lion's share.
There are a range of people in the department that engage with different stakeholders around the PBS.
Okay. So you have had concerns raised. That's fine. I mean,
concerns around specific recommendations usually as well.
But what about the actual implementation of the HTA review? I mean, I gather that there will always be people making comment in relation to the process for having a drug listed, but in relation to the implementation of the HTA review, because there was much promise around this and there doesn't seem to have been much that we've seen.
There is a lot of work happening to implement recommendations of the HTA review.
I think so. The point I would make is we wouldn't accept the proposition that we're not progressing the HTA review.
I asked whether you'd had feedback.
We've had, as Ms Shakespeare said, we've certainly had feedback from medicines companies that would like to progress some of the recommendations more quickly, and particularly the way they would interpret the recommendations for a particular outcome. But we are engaging with those stakeholders very closely to make sure we work through something that is workable for the overall system, and that is happening in a pretty intensive way.
So how many medicines that received a positive PBAC recommendation in 2024 and in 2025 are not yet listed on the PBS?
Senator, we can. I'll find a precise number for you, but basically we are seeing a continued stream of positive recommendations that has been slightly increasing, but largely steady over recent years. So we have seen quite a bit of public commentary from medicine companies who assert that that is dropping, but that isn't in fact what we're seeing in terms of the statistics about both submissions that are coming to clinical committees, PBAC, as well as the medicine listings that are progressing through our negotiation and pricing processes and being listed on the PBS. We're continuing to see, as we have throughout the history of the PBS, a steady stream of listings coming onto the PBS. But if you have other questions, I'll come back to you about the precise number.
Yeah, well, I'm just keen to understand, because I mean, obviously there's a process that goes through, and once a medicine gets a positive PBAC recommendation, doesn't necessarily mean that it's going to be listed. So is there any way that you could reasonably quickly get me the numbers of how many medicines got a positive PBAC listing in 2024 and remain unresolved, or did not progress to the PBS? And I'd like to understand the reasons for each.
Senator, I think to answer that question, we'd have to do it on notice. There are a range of reasons why listings don't progress, why recommendations don't progress to listing.
Yep.
The most common reason is because the price at which the clinical committee PBAC has found the medicine to be cost effective is unacceptable to the sponsor. In other words, the sponsor would only be willing to list if they were paid more than the price that we have been advised would be the cost-effective price for the medicine.
Yeah.
If
So
we were to pay more than
happen?
that, it would mean that other kinds of care that are available to patients would be cheaper than what it would be proposed with a new medicine.
Yeah, sure. I understand the mechanism. I'm just keen to understand. So how often does a PBAC-approved medicine is unable to negotiate a price that will enable it to progress to PBS listing?
Yeah, I think we'll take that on notice. The other reason I think we should take it on notice is because I think you are reasonably asking for what other reasons might exist.
Yes.
We just have to be careful when we think about the commercial confidentiality arrangement, what we might reveal. Because obviously sometimes Mr McIntyre's right, the price negotiation is something, but for some reason some sponsors, once getting the listing, just actually choose not to engage in the process for whatever reason they might do. But we'll take that on notice.
Yeah, I mean, obviously the biggest issue is the fact that I'd be really keen to understand over the last few years, has there been an increase in the number of medicines that have gone through the process to positive recommendation by PBAC that have not then progressed to PBS listing? Has there been an increase in the number of medicines that have been caught in that last negotiation process?
So we'll take that on notice, Senator, because we have provided quite a lot of information to this committee about the numbers between PBAC recommendation and listing over the years, and that will have included particular categories of reason for not progressing. So we'll make sure that we circle back to the information that we've previously provided, use the same categories and give you that comparison over time.
So obviously there can't be terribly much of a difference, because otherwise it would probably be, you'd have been alert to it. So you're suggesting that there's not been a great deal of difference in the number of medicines that have been approved by PBAC that have not progressed to PBS listing because of the inability to reach a positive pricing negotiation?
So the number of new listings that we see has been relatively constant, and the number of applications coming forward to the PBAC has also been stable, if not up a little bit, in the last couple of years.
Okay, that's actually not the question I'm asking.
So that's what we monitor. So according to that, yes, it doesn't look like that there's been a significant change, but we will check that back with some of the previous data that we've pulled out for this committee, because we haven't necessarily been monitoring it on the same basis for the last couple of years.
It just appears as if it's become more topical. So in terms of the public commentary, so is the department monitoring the potential impact of the US government's most favoured nations pricing policy on medicines?
Yes, Senator, we are monitoring that closely, and indeed very often the commentary about listings has been tied to that policy, but in fact we're at this stage seeing that the system is continuing to operate well. Okay.
Are you developing a policy for response to that risk?
Senator, we're monitoring it's not a single risk, but there's a series of changes in the geostrategic environment, shall we say, that we are monitoring closely, and we are developing responses to be able to deal with anything should it be necessary. But at the moment, what we're seeing is a continued stream of applications for listing on the PBS and a continued stream of successful listings.
So we saw recently Eli Lilly made the announcement that they weren't going to continue to progress with their application in relation to Monjaro. Is the department aware of other medicines where the company has indicated it will not submit for PBS listing, or has withdrawn their submission in the context of international pricing policy pressures?
Senator, we are finding that an increased number of companies are citing international issues as a part of their decision making about how and when they will introduce medicines into the Australian market. What we're seeing is that there is continued demand from companies to have their medicines assessed, and then we are continuing to find that we can reach terms that are agreeable for companies and they are listing, and that's reflected in the $5.6 billion of new listings that were reported in the budget. So we are continuing to see the system operate, but it would be fair to say that companies are saying that the reasons for their decisions not to list are often related to those changes in the geostrategic environment. In terms of the decisions of particular companies like Eli Lilly's decision to not progress, that is a matter for the company, but it is certainly always been a feature of the system that there will be companies that receive a positive recommendation, as they did, and then who, for whatever reason, choose not to progress it.
Yeah, it was most specifically about the fact that Eli Lilly actually cited the international policy situation as the reason why they chose, as opposed to, I'm sure there will be and have been over the years reasons why people decided not to pursue, but I just was interested to understand if there were other companies that had expressed concern around international pricing pressure or pricing policy pressures, and you've answered that and said yes. There are.
Now, Eli Lilly did also say that the price premium that PBAC had recommended for their drug was less than the price premium that they had sought, and that was also a reason for them not progressing it. Now, we don't normally talk. We won't talk about the reasons that companies give, but they published that as the reason.
Yes, they have, and I mean, obviously, I suppose the thing that's sort of bothering me is, if we've seen a big company like Eli Lilly do this on a drug that obviously is top of the pops in terms of what a type of GLP-1, which is top of the pops at the moment, it would suggest that it is something to certainly be taking notice of. So just keen to understand, did the decision by Eli Lilly prompt any sort of acceleration of the action in terms of the government's response to the MFN challenges that are before us in terms of PBS?
So in that instance, we look at the potential impact on patients. That was for type 2 diabetes. There is an existing GLP-1RA medicine listed on the PBS for type 2 diabetes. So in this case, we don't necessarily have a significant impact on patients because they do have access to another therapy.
Sure, and I understand that, but this is the first time that a big company has made a public statement in relation to the implications of MFN. And so I was wondering, did that trigger, because up until now, and I think we've spoken about this in previous estimates, it's sort of been a threat that's been over there, but we actually hadn't up until recently seen any solid action that would suggest that it is now starting to come into play in terms of the actions and behaviours of the pharmaceutical companies that import the life-saving and life-changing drugs that I think Australians quite assume that they're going to get access to. So in a recent interview...
Sorry, Senator, can I just make one comment?
Yeah, please.
So I would characterise it... We are very vigilant about this issue and what impact will have a supply of drugs, pharmaceuticals into the company for impact on patients. I also think we would say that we are in continued negotiation with all of the pharmaceutical providers over price. And so in that negotiation, it would not be surprising that firms will make claims, the claims to have an impact on what the price negotiations will be. And so, we have to take that into account, but also take account of how we evaluate that piece of information in our overall negotiation. But we are very, very vigilant to seeing genuine signs of MFN having a significant impact on supply into Australia.
Yeah.
Senator Ruston, I know that Michelle Anandaraja had a few minutes worth of questions that she wanted to sneak in at some point. Do you feel like we're going to finish with this outcome?
I can stop on MFN after one more question, if that would be
great.
Fabulous. In a recent interview, the CEO of Medicines Australia described Australia's PBS, and the word that she used was broken in the context of Eli Lilly's decision not to pursue its listing of Mounjaro. I'm just interested in what your response as the department is to somebody of that stature in the Australian medicines community saying that she believed the PBS was broken, and whether the minister wanted to say what her response is to that, and how would you describe the current state of the PBS in Australia?
So, Senator, the HTA review 2 years ago, as you say, was published, and it found, as part of its very substantial investigation, that the PBS represented one of the most functional HTA systems in the world. And indeed, that has been backed up by a series of international benchmarking studies that have been done both before and since the publication of the HTA review. Australia continues to fare very well in international benchmarking. We are often found to be amongst the top countries in terms of assessing the value of medicines and paying on the basis of the value for those medicines. During the HTA review, the CEO of Medicines Australia was a member of the committee, and there were a number of recommendations on which she provided a dissenting opinion or recommendation. And to have a better understanding of Medicines Australia's views as opposed to those of the HTA review, you can consult those dissenting reports. But I would assert that the PBS is an absolute treasure of Australian government work on both sides of government over many, many years, and that while we continue to need to improve the system to ensure that it's fit for the future, it remains an absolutely strong and healthy system which is capable of serving Australians well into the future.
Okay, so do I take it from that? I think, it is worth mentioning that I think Australians value their PBS immensely, as they do their MBS. It is something, if you did a survey, I'm sure it would, be rating in the high 90% of favourability. There's no question about that. And I don't think anybody is suggesting that that's not the case. and that everyone wants the PBS and the MBS to remain strong and in support of Australians into the future. I think the question is you know, to have somebody like the head of Medicines Australia to suggest that the PBS is broken, and, you know, to the point around so many people making complaints about their frustration at the slowness of the rollout and implementation of the HTA review. I think it's, I suppose, whilst I'm glad you think that the PBS is in fabulous shape, I would suggest that the HTA review would suggest it could be in better shape than it is, otherwise we wouldn't have had the need to do it and the recommendations wouldn't be there. So I suppose, you know, Minister, is there any state of urgency in amongst the government itself as to making sure that the things that have made the CEO of Medicines Australia suggest the PBS is broken, that we shouldn't be acting with some urgency to make sure that it's not broken, because it is such an important aspect of Australia's health system?
Well, I can't speak for the head of Medicines Australia. All I can say is that Australians do value the PBS, and I think that while we recognise the need for reform, and we've taken you through some of the work that is being undertaken, particularly some immediate measures that the government's put in place, we've also been very clear that the PBS is not up for negotiation. We're proud of the PBS, and the Labor government, you know, the Australian government will always protect it.
Sure.
Thank you. We'll go to Senator Amanda Raja. On the topic of the PBS, interested in the new drug listings on the PBS. Could you just tell me a little bit about one of the drugs, Calquence? This is a calibrutinib drug that's used for mantle cell lymphoma and chronic lymphocytic leukemia. Keen to hear more about this drug and how it ended up on the PBS and when it was listed.
Thank you, Senator. I'll ask my colleague to give some further details, but the drug Calquence, as it's often called, or as you said, I'm sorry, I'm going to struggle with that.
Don't worry about
as
it.
Well,
the calibrutinib
was expanded to treat patients with chronic lymphomatic leukemia or small lymphocytic leukemia in 2025. Over 1,200 patients accessed a comparable treatment, and without subsidy, patients would have paid more than $7,000 per pack. We've been working on this drug for quite some time, and we're delighted to now have it listed on the PBS. I'll just ask if my colleague wants to provide any further detail. No, that's fine.
Who's the drug maker? Do you know?
I don't have that information immediately
That's all right.
at hand.
It's interesting. It's clinical. So this was born out of a clinical trial throughout Australia. I wonder if you know who ran that trial. Was it a consortium? Was it the Australasian Leukemia Lymphoma Group by any chance?
Senator, I'd have to take on notice the particular set of trials, but often there are a number of different trials that are presented to our Clinical and Economic Evaluation Committee, PBAC, that does assessments, and they do that on the basis of all of the trial information that can be provided by sponsors. Very often they have a range of different studies that they put forward, and we can get you on notice information about the particular studies that underpin that recommendation.
No, I just want to give them a shout out. I used to be a member of the ALLG. It's an outstanding consortium. The other thing is, how many new and amended drugs have been added to the PBS since July 2022?
Senator, since 2022, there are 146 drugs that have been put on the PBS for new indications or that are new medicines. And of those, further to that, there's 265 amended listings, and most of those amended listings would be increasing the access to medicines that's available. And there's also a further 33 high-cost listings. So that gives a total of 444 new listings.
Okay. Could we, on notice, get a list of those medicines, perhaps their indications, if it's been broadened or if it's new, and whether it relates to an adult or paediatric population?
Senator, yes, we'll see what we can pull together to provide
Just
that
on
information.
a table, something simple, not reams of paper, please.
We'll see if we can provide a high-level summary of those things. But I'd also point you and your constituents to the PBS website, which is a real treasure. It's got a huge amount of information about every single drug that is listed on the PBS, and it includes a detailed history of how those medicines were assessed, when they were approved, and who can have access to those medicines.
I will, thank you. And just in the last minute or two, can you just briefly tell us a little bit about the 60-day prescription program that was rolled out in September 2023? How many medicines does that now cover, and what has been the uptake? And has there been any adverse impact on pharmacies?
Yes, Senator, thank you. We answered some similar questions earlier, and I'd note that it's been a successful program. It's led to very substantial savings for patients, and it appears to have had no negative impact on pharmacy. Indeed, we continue to receive requests for new pharmacies to open at a greater rate than was the case before the scheme commenced. So we are continuing to see the business of pharmacists holding up well, but patients have improved access to medicines now. I'll just see if I can find the particular figure that you asked for there.
Sarah Norris, Assistant Secretary, Technology Assessment and Access Division. There are over 300 medicines listed now for 60-day dispensing out of over 900 other medicines on the PBS. And I can give you some data on some pharmacy approval notices to state. So as of 31st of March 2026, for the 25-26 financial year, 86 applications for new pharmacies have been submitted across Australia, with 38 approvals granted to date and 7 approvals cancelled.
That's great. Thank you. Thanks, Chair.
Thank you very much. We will now break for a slightly longer break to accommodate some of the logistics we're dealing with, and we will return at 4, but we will return with outcome 2, but it is our anticipation that it would be maybe half an hour, and then we'll move on to the following outcome. So thank you very much, and we will suspend until 4 o'clock. Welcome back, everyone, to this glorious afternoon in Canberra. We will continue with outcome 2 for a little while longer, and we'll go directly to Senator Ruston for questions.
Thank you. Hi, can I just ask some questions about newborn blood screening, please? You probably know the answers. You've had these questions before. And I do love your jacket.
We were just having that conversation.
Seriously, the only reason I come to health estimates is to just see what Liz is wearing.
It's not the same jacket every time.
It's never the same jacket every time. I can't imagine what her wardrobe must look like, your wardrobe must look like. I'm just wondering how many conditions are currently intentionally screened for as part of the newborn blood screening program?
Yes, so thank you, Senator. Prior to the election, there were 27 conditions consistently screened. There is now 37 consistently screened, or what we call target conditions. 34 of those, 34 are being consistently screened, and 3 are under implementation, which will take us to 37.
Yep. So, once again, when you say at the election, I assume you mean the 2022 election?
That's correct,
Yes.
Senator.
So when will the number of conditions screened nationally reach 80 as promised by the Prime Minister 4 years ago at the election you just referred to?
Senator, I think we have previously walked through the numbers to talk about how Australia has now considered all the conditions that were in the Californian program, which is where that number of 80 comes from. So as I said, we have 37 that are either being consistently screened or are under implementation. We have 18 conditions in addition to those which are considered non-target, and that takes us to 55. There are 15 that have been considered but will not be included in Australia's program because they didn't meet the requirements. So that's why there is a difference in number between the Australian program and that often referred to 80 conditions, which comes from the Californian program.
Minister, when is the Prime Minister intending to correct the record in relation to the promise he made to Australian mothers and mothers-to-be, or Australian families, or expecting a child, that there would be 80 conditions screened? He said there should not be a lottery in this country. He held up a baby with Pompe disease and said, in the future, this baby would be screened. And I understand, if I just check with Ms Devlin, Pompe disease still is not one of those conditions that we screen for. Is that correct?
Senator, so last time we spoke, MSAC had considered Pompe. They recommended not including it in Australia's screening program because it did not meet the requirements considered for the test to be specific enough, or that the condition identified through the test available would look at children in the young years as opposed to adult onset. So their recommendation was not to include it. That recommendation is now with health ministers for consideration.
So, Minister, back to my question. When is the Prime Minister intending to correct the record that he misled Australian parents-to-be, that there would be 80 conditions that would be screened within the newborn blood screening program? As we sit here today, we've just heard 34 in total, plus an extra 3 that are well underway, and potentially another 15. That is not 80. The Prime Minister misled Australian families in 2022. Do you think it's time for him to correct the record and admit that his promise of 80 conditions was unachievable?
Well, Senator, what I'd say is that prior to that commitment from the Prime Minister, only 27 conditions were screened in all Australian MBS programs. We have obviously increased that number substantially.
To 34?
We have increased that number, and we are working with all health ministers on the agreed national decision-making pathway. We know that there is more work to do, and there are conditions that are being considered, additional conditions that are being considered, and a pathway through for those. But, look, this is a comprehensive newborn blood spot screening program which has increased under our government.
So when will all 80 be screened for?
Well, we've taken you through the department's explained to you the process we're going through with all of the conditions screened by the Californian MPS program. We do need to make sure that we take the advice of health professionals into making a final decision about the conditions that are included.
Will 80 conditions be screened in our lifetime?
Senator, I'm happy to assist with the numbers because the Californian program does count them differently. We can add up the numbers to demonstrate that we have considered all those conditions that are screened in other programs through the Australian decision-making pathway.
Okay, and there are how many that will not be listed as a result of that process?
Senator Ariane Herman, First Assistant Secretary, Chronic Conditions and Screening Division. In a direct comparison to the Californian model, Australia is now has now included or agreed for screening 77 of the Californian conditions. In addition to that, we have 3 that are under assessment and 15 that have been considered not suitable for screening in the Australian population. We also have an additional 9 conditions that are not included in the Californian model that are included in the Australian newborn screening program.
So the advice that you have just given me, Ms Harriman, completely contradicts the advice that I've just received from Dr Devlin.
No, Senator. We were talking about the way they are differently counted in the programs. I think I gave you evidence that we have. I gave you the numbers of the conditions that are consistently screened, those that are non-target screened, and those that are under consideration. As Ms Herman has just said, there are additional conditions that has been in Australia that will be included. As we said, they do count them quite differently. Some conditions might be counted almost multiple times, if you like, variations of a subset of a condition.
So as we sit here today, let's be absolutely clear. The Prime Minister promised 80 conditions would be intentionally screened. There were 27 intentionally screened at the time he made that commitment. As we sit here today, in full delivery of that promise, there are 34 that are intentionally screened and another 3 that you have indicated are close to being in that. That makes 37. So I'm just keen to understand, we have been talking about this over and over and over again. There was an absolute categorical commitment made to new families and new parents that their children would be screened for 80 conditions, and as we sit here today, only 37 of those 80 conditions are at a stage of screening that was promised by the Prime Minister.
Senator, just to clarify, the way that the conditions are counted in California...
Why you keep going back to California? The Prime Minister made a promise to the Australian public that 80 conditions would be screened in Australia. He didn't say that he was going to do it the same way as California. He made a promise of 80 conditions in Australia. So keeping on making reference to California does not move away from the promise the Prime Minister made to Australian families. So if we could just stick to what he promised and what's been delivered on that promise, that would be great.
So, Senator, for clarity though, 77 of those conditions are screened in Australia, or agreed for screening in Australia.
Intentionally?
So of those, there are 36 that are target conditions, 32 that are non-target. In California, 33 are target and 50 are non-target.
Okay, so you keep going back to California. So in terms of the promise the Prime Minister made to Australians, there are 37 conditions that are being intentionally screened as per the Prime Minister's promise in 2022.
Senator, we're saying to you that that reference that was used was a reference to the Californian MBS program. We have taken careful steps to consider conditions. We've increased the number of conditions that are now being screened, and we are now delivering the most comprehensive newborn blood spot screening program. Well, I would argue one of the most comprehensive programs in the world.
It still doesn't move away from the fact the Prime Minister made a promise that hasn't been kept. But we go over this every estimates, and we'll continue to keep going over it at every estimates. But can I just go circling back on the PBS? So I'm just interested in relation to just a couple of drug listings, and I know that there have been others that have asked about drug listings today. So I'm sorry if I'm being repetitive. Can I ask about Keytruda?
Yes, Senator?
Yep. So my understanding that the PBAC recommendations were released in January this year have included a positive recommendation for Keytruda, that's correct?
Yes, Senator, and it was listed on the PBS on the 1st of April 2026.
Okay. So was it listed on the PBS for the full scope of its application?
Senator, there are a number of different conditions for which Keytruda was listed on the PBS. A number of specific populations as well as a pan-tumour listing for a range of... excuse me, not that...
let's be more specific. For the MSD's multi-cancer funding proposal.
So on the 1st of April it was listed for advanced cervical cancer.
Yep.
Renal cell carcinoma. And head and neck squamous cell carcinoma.
Okay, so under MSD's multi-cancer funding proposal, was it listed under that?
I'm sorry, Senator.
So I can answer that if you like. So we're still working with the sponsor on the broad listing to finalise the listing arrangements and find a mutually agreeable pathway to get that listed as soon as we can.
Yep. Okay, so it hasn't been listed?
Not the broad listing.
Okay.
But as Mr McIntyre said, the other cancer-specific listings were made on April.
Yeah, but I mean there's 700 patients or so that are waiting on the broad listing. That's of no comfort to them.
As we outlined earlier though, we have nivolumab and ipilimumab, which has been listed for broad cancer pan-tumour types.
Okay. And so back to the actual listing. So it received a positive outcome for the multi-cancer funding proposal from PBAC. Some other elements of the proposal obviously have been approved, but this one has not, despite it receiving a positive recommendation. So it has always been the convention of all persuasions of government to, if arrangements can be reached, that all listings, all positive recommendations will be listed. So I'm just interested, maybe Minister, can you confirm whether the government intends to honour that convention, that that all positive listings will be listed if financial agreement is achieved?
Senator, just on this particular listing, I'll have to get some more information from the Minister. I know I think it was made in March, if that's correct, pretty recently. I can find out some more information for you about that listing in particular. Of course, we would want to provide access to cheaper medicines for as many Australians as possible. And I think we've gone through a number of listings that we've made through the PBS system for you. But if there's a particular question about this listing, I'll take that on notice for you.
Well, there is a particular question about this listing, is whether the government's intention to honour the long convention of listing positive recommendations.
Senator, if the company reaches agreement in line with the PBAC recommendation, the government will absolutely list it. But pembrolizumab is available, as the other officials have said, for a range of existing patient indications.
That is not the question we're talking about here. We're talking about a positive recommendation from PBAC.
If MSD reaches agreement with the government, it will be listed.
Okay. Of all the treatments that received positive recommendations at the December 25 PBAC meeting, how many have been funded and how many have not?
Senator, I think in the same spirit as the previous question you asked of this sort, we can on notice give you a detailed breakdown of the recommendations that went to that meeting and those that have been listed, and an understanding as to where they're at if they haven't been listed.
That would be very helpful.
I'd note that much of this information is available on the medicines website, on the PBS website, but we will provide you everything we possibly can and consolidate that in a way that centres on that meeting.
Yeah. Okay, well, but as I said, I'm interested to understand how many medicines get through the positive recommendation process on PBAC, and then what happens to them then. Is it ricociclib, the breast cancer, early breast cancer drug? It's fully, it's reimbursed for the full early breast cancer population in the UK, in Canada, in Singapore and in most of Europe. And yet Australian women with fewer than 4 cancerous lymph nodes are either paying approximately $3,000 per month out of pocket or going without the treatment. Can somebody explain why the PBAC's assessment has placed Australia at odds with every comparable health system and what the government's doing to breach the gap?
Senator, we may need to take that on notice. My colleague is just seeking to retrieve some information about that particular medicine, but we assess those applications that are brought forward by sponsors on the basis that they bring them forward. Sponsors often don't bring forward their submissions on the same basis in different markets for a variety of commercial reasons and other reasons, and so we can give you advice about whether or not the reason why we may have made different decisions to other markets relates to changes in the way in which the sponsor has sought to bring that forward.
Okay. The current listing for this particular PBS listing includes a restriction that prevents a woman from accessing the treatment for more than once in her lifetime. And so even if her cancer returns after an initial response, so can you confirm whether this restriction reflects a clinical recommendation of PBAC?
Senator, we will have to confirm that based on the assessment for that particular medicine. What I would note, though, is that usually the restrictions are driven by PBAC's advice, and that advice in turn is based on what the sponsoring company is willing to offer. So the restriction is a combination of ensuring that the drug is made available in Australia on terms that will be acceptable to the sponsor, and any advice about its introduction into care to ensure that it's consistent with the best possible care that can be provided in the Australian system. But we will get you on notice details.
Okay, so if it's a recommendation of PBAC, PBAC would only make a recommendation that would be a clinical recommendation?
It may reflect the clinical evidence or other evidence presented to the PBAC by the sponsor. I'm sorry, Senator, we'll need to check that restriction and where it came from.
Because you'd just be interested to understand whether it's actually a cost containment measure that's being applied by the department, and if so, who has the authority to remove that? Does the authority sit with PBAC, does it sit with the department, or does it sit with the minister?
So, Senator, we'll have to get you some information about that. But, I mean, PBAC's role is to provide advice to government on the way in which a medicine should be introduced to the PBS. The department then, on the government's behalf, treats with the sponsoring pharmaceutical firm to seek to reach agreement on conditions that they will find acceptable that are consistent with that advice. And then, of course, government makes the final decision as to whether to list it, which is based on the recommendation that's made by PBAC, as well as a consideration of fiscal sustainability.
Okay, well, I look forward to receiving that information. Thanks, Chair.
You all done, Senator Ruston? Yep. Excellent. Thank you so much to everyone from Outcome 2 for spending the day with us. It's been a delight. Thank you, and we will release anyone who is only connected with Outcome 2 and not connected with Outcome 1. If you are, however, connected with Outcome 1, please settle in. We will move to Outcome 1, which is Health Policy, Access and Support and Cross-Portfolio Indigenous Matters. I'm now going to read out the agencies and the agency reps that we are expecting in the room while everybody changes up the mix in the room quietly. So we will welcome the Australian Health Practitioner Regulation Agency and Chief Executive Officer Mr Justin Steiner, We will welcome the Australian Institute of Health and Welfare and Chief Executive Officer Dr Zoran Bolovic, the Australian Radiation Protection and Nuclear Safety Agency and Chief Executive Officer Dr Gillian Hirth, Cancer Australia and Chief Executive Officer Professor Dorothy Keefe, Food Standards Australia New Zealand and Chief Executive Officer Dr Sandra Cuthbert, Hearing Australia and Chief Executive Officer Mr Kim Terrell, National Health and Medical Research Council and Chief Executive Officer Professor Steve Wesling, National Rural Health Commission and Professor Jenny May, the Office of Gene Technology Regulator and the Gene Technology Regulator Mr Raj Bahula, Organ and Tissue Authority and Chief Executive Officer Ms Lucinda Barry. Okay, so now that we have everybody on the record, the manner in which we will attempt to do this is obviously as senators seek to ask questions, they'll call whichever agency or area in the department they wish to speak with. When you come to the desk, if you do have an opening statement, please take that opportunity to provide that opening statement, but please place on the record who you are and the capacity in which you're in this hearing. So we will start with, Secretary, do you have anything to... No. Senator Ruston, we will start with you.
Thank you very much. So can I just ask some questions around the Mental Illness Fellowship of Australia Hospital in the Home program?
That's a good start.
Where was it? I think it should be health policy, I suppose. Probably preventative health and chronic disease, maybe. Richard's got some questions in relation to tobacco and health regulation around tobacco. Where would be appropriate for him?
So you could do it in this outcome.
Okay.
We've got both the TGA and we've got
yep.
Lizzie's
okay.
area.
All right. Do you need to go now, or do you want to go next?
We'll go next.
Okay, right. Okay, just wondering what the status of the Commonwealth funding for the Hospital to Health program in Western Australia is.
Hospital to Health. Might need a bit more detail about this. Is it a mental health program? Hospital to Health.
Yeah, it says so. It's the Mental Illness Fellowship of Australia has written to us regarding the imminent closure of its Hospital to Health program. And it's a program was established through the Western Australian Primary Health Alliance in 2017 and funded through the Commonwealth's Information Linkages and Capacity Building program.
Yeah, that is a program that's under the disability part of the department, so that'll be probably one for Friday.
I moved that one. Yep. As soon as I saw ILC, I thought,
they are aware of the issue, so they should be able to cover that in Friday.
No, that's fine. As soon as I saw that, yes, ILC is definitely disability. Okay, so can we just ask some questions around the National Mental Health and Suicide Prevention Agreement? Is that still you?
Yep.
Okay. I'm just interested to understand why there's only 12 months funding in the agreement, and I could find no forward estimates funding in this year. Is that correct, or have I missed it?
So, Senator, the agreement was due to expire at the end of this financial year. It was agreed by all state and territory ministers in the Commonwealth to extend the agreement, so that is why there is a one-year extension of funding.
Yep.
Any further funding will be subject to the negotiations of the agreement, which is currently in play with states and territories in the Commonwealth about the future of the agreement.
Okay, so the absence of funding indicates that the matter is still under consideration. There is no necessarily any certainty that this agreement will be funded after the end of 2027 as per normal budgetary processes.
Through normal budgetary processes, yes, Senator.
Okay. It's interesting when you're having a look at the bilateral schedules, and I was just interested to understand, when you have a look at the funding that's provided in the 2 years that it's still for this year and next year, there's like reasonably low amounts of money, which would probably relate to the pro rata populations of the states and territories, and yet for some reason, out of the $151 million that's been provided by this agreement, $82.6 million has gone to Victoria. Do you explain why Victoria is receiving over half the funding?
So, Senator, that really, so the continuation of the agreement for 12 months was basically literally a straight rollover of the existing agreement. So there hasn't been any other changes. It's sort of inside the agreement. So it reflects what was negotiated in the bilateral schedules of the original agreement. So the Victorian bilateral did contain, I think, from when the agreement was struck originally, a higher level of funding from both sides than other jurisdictions at the time, which was put into that bilateral at the time. So it largely reflects the items that were negotiated between the Commonwealth and the states, which varies quite a bit. Western Australia had less, Victoria had significantly more, and that was what was reflected in the bilateral schedules to the agreement at that point in time, and then that has been continued for another 12 months.
Okay, so it's just better negotiation skills from Victoria.
Yeah, and it sort of probably reflects that the things that are underway, the Victorian government probably put more of its own effort inside the national agreement, where other states have probably done things outside of the agreement as well. So it just reflected what they wanted to put into the bilateral schedule at that time.
So, Minister, just keen to understand what the process for negotiating the next stage or the next agreement for suicide prevention services, given that the current agreement is due to expire in 12 months' time.
What I can tell you, Senator, is that Health and Mental Health Ministers agreed in February 2026 to prioritise the development of a new national agreement over the next 12 months. So it's a priority for our minister, but also ministers around the states and territories.
So can I take from what you've just said that there will be another agreement, it's just the negotiation?
Well, we're seeking to form another agreement. I can't speak for states and territories.
Okay. All right. Well, we'll watch with interest for that. So in relation to the National Suicide Prevention Strategy, Suicide Prevention Australia stated in their budget media release that, and I'm quoting from their release, despite consistently high levels of distress, this marks the second consecutive federal budget that does not provide any clear, dedicated funding for the implementation of the National Suicide Prevention Strategy. This omission is not an oversight, it is a policy failure with real consequences. How does the government respond to that statement?
Well, in the first place, Senator, can I say that, the budget is investing $283 million in mental health over the next 4 years, and that includes $206 million for existing mental health and suicide prevention activities under the agreement.
Okay, so I'm just interested then, so is there any new funding in the budget?
In the budget, Senator, probably for directly related to suicide prevention, there is funding for 13 Yarn, which is the Aboriginal and Torres Strait Islander, it's the main crisis line used by First Nations people, which is about $18.9 million, which is to expand the capacity of that service and then put in a text-based service, which is something that they've been looking to do for some time because it provides a safer way for many First Nations people in some situations to access that service. So we've provided the funding for that and to boost the capacity because their call line was basically becoming fairly oversubscribed into that. So there's an uplift in funding for that included in the budget as well. Would be probably the main new item in this budget.
Okay, so is that part of the National Suicide Prevention Strategy?
It will fit under the strategy because, of course, the two strategies, the National Suicide Prevention Strategy and the National Aboriginal and Torres Strait Islander Suicide Prevention Strategy, both basically have a number of actions in there. So yes, I think that sense of prevention, diversion, and doing it in a way that is First Nations led is consistent with both of the agreements.
So I think the statistics are something like 3,000 Australians die by suicide every year, and a further 55,000 attempt suicide, and all that's new in the budget in relation to the National Suicide Prevention Strategy is $13 million to 13 Yarn. Is that correct?
I don't think we would. So, from the budget point of view, obviously the continuation, the extension of the national agreement for 12 months in itself continues around about $55 million worth of effort for the continuation of aftercare, which is obviously for people that have made an attempt and provides direct support to those, and also for postvention into that. So it does continue, and extend those services for a further 12 months as well. So it's sort of there are continuation of some existing effort, and then of course that builds on. Then not all suicide relates to mental health, but there are obviously that pattern, particularly through MyFO, of some fairly significant investments in mental health to continue growing investment in mental health, which is sort of growing from year to year.
So I'm just interested, how the government intends to implement the National Suicide Prevention Plan if there's no funding that is dedicated to the implementation of the plan.
I think, Senator, the part of the answer to that would probably be also that we are in the process of negotiating the new national agreement. So this is the other obvious place where, the Productivity Commission had itself sort of laid out that there should be specific focus on suicide prevention. So that is the other place to look at. We're working with our state and territory counterparts and stakeholders on that aspect. But that is the other place where we would expect to consider potential improvements for suicide prevention. So
that's work in progress for somewhere down the track. So nothing in this budget. So what discussions have you had with Suicide Prevention Australia and other peak bodies regarding funding for this strategy?
So we obviously meet with SPA quite regularly. So our team has very regular discussions with SPA. They're quite, they're fairly clear, which I think is the normal conversations we have with stakeholders around those matters of what they see as the priorities to work our way through. They're not obviously the only body we talk about. Obviously, Roses in the Ocean. We have lived experience groups. So there are sort of a range of stakeholders that we talk to really quite regularly about both the broader suicide prevention strategy and as it relates to mental health, and with not all the overlays with mental health, but that relationship there that kind of comes up in probably most conversations we would have with the broader mental health sector, as well as the stakeholders that are more specific around suicide prevention.
I specifically asked you regarding funding for the strategy. Have you had discussions specifically about funding for the strategy?
Yeah, well, SPA have obviously, we would have met with SPA regularly. They're obviously their submissions around seeking further funding we're aware of. We've discussed with them, but of course we don't discuss what is actually flowing through, the budget process with them because we can't because of the nature of budget processes. But yes, we do talk to them about their submissions and what they're seeking, as we do with a range of others.
Okay, Chair, were you giving me the nod? Chair, were you giving me the nod before?
No, I was talking to Senator Whitten.
Oh, I'm sorry. I'll keep going if that's the case.
You've got about another 3 minutes.
Yeah. Just quite frankly, if you add those two together, it doesn't look like there's a great deal of priority being put on suicide prevention. So going to men's mental health, ABS data shows that female suicide fell by 2% during the most recent year, while male suicide sadly rose by 5% during that time. So how much federal money is being spent on suicide prevention and suicide-related services each year? And has the department done any analysis as to why we're tragically seeing such a marked increase in male suicide rates in the last year?
So just in relation to funding, I think your question was sort of broader funding for suicide. So we do in 2025-26, we're spending about $130 million on suicide prevention across a range of fronts. Funding through the national agreement around aftercare and postvention we've talked about. We have funding through our PHN network, which provides a range of flexible place-based initiatives that we do. We have our National Suicide Prevention Leadership Support Program, which is just a bit under 40 million, that provides around about 36 projects. That also funds things like mates in construction and the FIFO, DIDO approaches in mates in manufacturing, which is sort of things that are then placed specifically because they're probably a little bit more male targeted. There's also a program called the Men's Table, which provides specific support for men from a suicidality mental health program funded underneath that. And then there's a range of other supports that we do as well that we fund through there. In terms of specific research of why that's gone up over the last week, it's probably not, since the data has been released, necessarily something we've done specific research into why it would have gone up into that 5% from there, but there obviously is sort of research through, as you know, through SPA and Black Dog and various organisations that are funded from a broader research point of view, but not specifically on that exact question of why it's gone up over the last 12 months.
Okay, so has the government commissioned any research into the fact that, sadly, males make up 75% of suicides in Australia?
I think there has over time been quite a bit of research into suicide patterns.
No, I was actually asking, has the government commissioned any research?
Over what period, Senator?
Well, the last 4 years.
Over the 4 years, I would have to go back because that would also include we'd need to go back and check what comes under the Medical Research Future Fund and other things as well that are beyond the part that I will have direct knowledge
just
of.
rotate. Okay.
But we've funded research through SPA, as you know, and there are some other funding through, Black Dog that sort of looks at the broader question, which will pick up elements of that. But whether I'd need to go and check the actual title of the research parts, and particularly the MHRC, to sort of see whether there's anything that's specific exactly into that wording.
Okay, sorry, Chair.
Thank you. And we'll go to Senator Steele, John.
Thank you very much, Chair. So following our Greens-led Senate inquiry into ADHD supports, it's been really exciting to see progress made across the states and territories, empowering GPs to diagnose ADHD and to prescribe ADHD medications. However, there are still some jurisdictions, such as the Northern Territory, which are lagging behind others in relation to this change. What conversations are being had with the NT on moving forward with GP diagnosis and prescribing of ADHD medications?
Hello, thanks for your question. Natalie Beekes, Acting First Assistant Secretary of the Workforce Division. Yes, we have been working on this issue. We have established a Medicines and Poisons Advisory Committee that is reporting to health ministers. The issue of GP prescribing on ADHD has also involved engagement with the RACGP and this Psychiatry College as well. You're right, there is some great work happening, particularly around training being led out of South Australia. We are trying to facilitate a broader national discussion around harmonisation around what GP ADHD prescribing should look like. As you can appreciate, states and territories do have various powers under their own drugs and poisons legislation. And so that is something that we are actively working on. We are due to report to health ministers later this year around both short, medium and long-term options to look at this issue to try to create harmonisation. But there are some that want to progress further than others, but we are hoping to facilitate a more harmonious conversation around what the future could look like, both in terms of training, but in particular around initiation of ADHD prescribing and how we bring that more formally into scope of practice for GPs.
Okay, could you...
Sorry, I was just going to make a gratuitous comment, if you don't mind. I'd just shout out to South Australia, who have done a really fantastic job in this area. We've had some excellent feedback from people. One guy who it took him a month to get the diagnosis from beginning to end, and it was under $300 for the entire process. We have around 100 GPs now in South Australia who can do this work, and it is making a fundamental difference. So just shout out to South Australia. Thank you. Sorry, Senator
Thanks,
Stillwell. Please go
Chair.
ahead.
No parochial statement would be complete without bringing everyone's attention to the fact that it was WA who first successfully managed to put a program in place for the GP prescribing and diagnosis for adults. So that's our claim to fame, and I'm very proud of it. Just back to the timeline, though, because it's interesting what you say there about a report, information to government, I think later in the year, did you say?
Yes, that's correct. Yes,
what-
we are currently consulting with the Health Workforce Task Force, which
Yep.
has representation from states and territories.
Yep.
And then we are due to report to health ministers. Did you want to add anything?
Nick Morgan, Assistant Secretary, Workforce Division. Yeah, we're aiming for mid-year, so within the next couple of months into Health Ministers with a report that's come through this new working group that's been established.
So that would be in time for the Health Ministers meeting because we're now in at the mid-year point or just past it. So
the next two health ministers' meetings are September and then I believe December. So I'm not yet clear exactly, Senator, which one we are tabled for. Right. But certainly we are progressing those more fulsome conversations, including how we get states and territories to share the good work that has been happening and try to create more consistency nationally.
Okay. Thank you. So it'll either be for the September or the December Health Ministers meeting.
It's a little difficult for the Commonwealth to predict. The agendas are set by secretariats, which are managed by state.
Yeah, okay. Now, another recommendation from the inquiry which was supported in principle by the government, was to review the Medicare benefit schedule with a view to improving access and accessibility of assessment, diagnosis and support services for people with ADHD. Where are we up to?
That doesn't sit with us.
We'll check to see whether the officers from Outcome 2 are still downstairs that can tell you more about that work.
Right, so that would have been an Outcome 2.
It's just the people who work on the Medicare benefit schedule, because it's individual health benefits, tend to be here for Outcome 2.
Okay.
They may have been released, I think.
They may have fled the building.
If they've fled...
It's a bit hard for us to tell. We can take on notice.
Senator, we can take that on notice, Senator.
The government also supported in principle the inquiry recommendation to implement neurodiversity affirming public health campaigns on ADHD. Where would that be up to?
I think we might need to take that on notice for you as well. The people who look after our campaigns are generally here for whole of portfolio, which was yesterday morning. But I'm not sure if they're here in the waiting room downstairs as well. Okay, all right. Well, I'll be here for a lot longer if they are around. That would be really... Okay.
Otherwise, we'll take it on notice for you, Senator.
Yep, otherwise take it on notice. Great. Yep. Thank you. If I could just go to the TGA with my remaining time. Fantastic. So I understand the TGA has been consulting on potential changes to the regulation of sunscreens and that public consultation periods for that have just concluded. Is that correct?
Nick Henderson, First Assistant Secretary, Medicines Regulation Division. Yes, Senator, that is correct.
And how many submissions were received as part of the consultation?
I can speak to that. Avinash Clark, Assistant Secretary, Complementary Medicines and Over-the-Counter Branch. So, Senator, we received 117 submissions. So I can give you a breakdown of those if you're interested.
Yes, please.
Yeah, so 47 of those were from industry, 39 domestic and 8 international. 36 were consumers, 7 from professional associations, 7 from academia, 4 from other authorities, 3 were not stated around a category, and 13 were unknown as well.
Okay. And how many were from? Could you give me a few categories there? But how
Sure.
many were from not-for-profit advocacy groups?
I think, can I take that on notice just because we don't have a discrete category for that? So it might take going through a bit of data to figure out what, and we'll give you an idea of what we would categorise as not-for-profit.
And if you could tell us how many not-for-profit advocacy groups made a submission out of that overall number, that would be great. What are the next steps from here?
So we are going through all of the recommendations, all of the submissions. Part of the next steps will be determined based on the feedback that we receive. There are some aspects of the recommendations that we have suggested and the directions in which we foreshadowed that we could probably do more quickly, perhaps things like testing, but others would likely take more time, such as SPF labelling. So once we go through all the submissions, we will take an appropriate approach on each individual issue.
Okay.
Excuse me, sir. I might also add, we're also looking to set up a sunscreen expert working group as well to support our consideration of the outcomes from that consultation.
All right. And when will that be set up?
So we're in the process of writing to potential members at the moment, Senator.
Okay. Would you be able to provide us on notice a copy of the terms of reference for that advisory group?
Yep, we can.
And the members of that group?
Yeah, I've got here with me now the expertise that we're looking for. So
that'd be fantastic.
Obviously, dermatology and skin cancer prevention, topical formulation and cosmetic chemistry, photobiology and skin optics, photonics and optical measurement science, lab accreditation and analytical quality systems, and sunscreen manufacturing and ingredient suppliers, and sunscreen testing. So trying to cover the broad range of issues that we've picked up in our consultation. So,
yeah, okay. Thank you. When will the TGA make the results of the consultation public?
So we anticipate to do that in the next month or two, Senator, where so that will go up on our consultation, and it'll be a summary of what was received from the consultation.
So it'll be a summary, but you don't intend to publish the actual submissions?
Well, we may publish the actual submissions as well.
Okay, but you haven't decided
we haven't made
whether you will?
on that. Yeah,
okay.
But given it's a public consultation, we generally do publish submissions.
Yes.
But there may have been some that asked for their permissions for the submissions not to be made public.
And who makes that call ultimately as to whether they are published publicly or not?
I think it'll likely be the TGA.
Yeah, so generally, Senator, if they've asked for their submission not to be published, then we wouldn't look to publish.
Yes.
And however, they would be available through mechanisms like freedom of information and requests and the like.
But in the absence of a request, you'll publish?
We generally publish for a public consultation.
Okay. Now, I'm interested to know a little bit more about the potential regulatory changes that were in the scope of the consultation. What are the possible changes that would increase the oversight of SPF testing laboratories? Would those changes have prevented the wrongly labelled sunscreens that were identified by choice?
Thank you for the question, Senator. Assistant Secretary, Medical Devices and Product Quality Division. So in the consultation paper, we've proposed a couple of different options for improving the oversight of the competency of the testing laboratories. So, for example, one of the options is to prefer laboratory results that come from a laboratory that has received ISO 17025 accreditation, which is the international standard for the competence of testing and calibration laboratories. So that's one of the options. The other one is potentially, these are all under consultation of course, is to ask for GMP certification of the laboratory that's doing the SPF testing. And to answer the second part of your question, I do believe that that would strengthen the reliability of the test results and would alleviate the problems that we saw with the choice report.
Okay, thank you, Doctor. The consultation paper also raised the possibility of changing the SPF labelling for sunscreens to a low, medium or high system. What would the benefits of this system be?
I can talk to that, Senator. I think there are two key reasons we suggested that as an option. So the first is around consumer understanding of a specific SPF number and the SPF spectrum. So as we've mentioned before, the SPF spectrum isn't linear. So an SPF 30, for example, would filter out 97% of UV radiation, while SPF 50 would filter out 98%. So we feel that a banded system could benefit the consumer through better understanding of the protection that is actually provided and the relationship between the different SPF values. The second reason is around the specificity of the test. So SPF testing does have a margin of error. And so attributing a very specific SPF number to a test that does have a margin of error may not provide a consumer with as accurate an idea of what the SPF of the product they're putting on is, and so a band would would accommodate for that margin of error in the testing as well.
Okay.
Sorry, if I may, yes. Senator Professor Anthony Law, the Deputy Secretary of Health Products Regulation, and what Mr. Clark has highlighted is very much goes to the heart of our role as a regulator, which is to ensure the standards of safety and quality, but also to ensure the level of transparency in communication to consumers so that they can make the decisions that they need to. And to do that, they need to understand the risks. We recognise, and we have had through feedback through the survey, particularly on this issue, communication that it is a well-recognised mechanism of labelling, the SPF 30, 40, 50 plus, but the challenge that we have is that we're not convinced that it is as well understood as people think it is. So the non-linearity of the rating, as Mr. Clark's highlighted, but also it enables, we think, particularly consumers and those who are looking after children, where there needs to be regular application and reapplication, that banding of the SPF rating into various bands will actually give a greater level of information to be able to make those risk-based decisions.
Now, another possible...
You've got a couple of minutes left,
yes.
And then we'll rotate.
Yep. Thanks, Chair. Another possible change floated by the consultation paper was to bring cosmetics that make SPF claims under the same TGA regulation that applies to sunscreens, that sunscreens are subject to. I'm very pleased about this possibility because I've been advocating in my role on this side of the table in the Parliament for cosmetics to be properly regulated when they make an SPF claim for years now. Many people have shared with me during the course of that work that they use SPF makeups as their primary sunscreens, and it's never made sense to me that the same consumer protections don't apply to a normal bottle of sunscreen that are applied to those products. One of the options presented, though, is for cosmetics that make that same SPF claim to simply be required to be labelled as quote, cosmetic sunscreen. Now, is that an idea that would communicate to people that the SPF label can't be trusted in that circumstance?
I think it's safe to say, Senator, that one of the reasons that we've framed the consultation in the way that we have is to gain an understanding of that perception.
Yeah.
There are significant, both, I guess, regulatory and environmental differences between primary and cosmetic sunscreens. We recognise that presents a challenge for consumers, and they go to issues such as how frequently it needs to be reapplied and the requirements under regulation. We're obviously in the process of analysing the feedback we've received on that question, as we are on other questions. In terms of what that would mean, we would be looking to do to undertake an appropriate analysis of what the various regulatory reform options might mean. We didn't put these options out with one particularly in mind that we'd already committed to.
No, I do understand. I think my concern continues to be that while the regulatory environment for sunscreens and cosmetics are different, the community's perception of the trust that they can place in an SPF claim, if it is on a sunscreen at a chemist or whether it be on a makeup product that they've bought online, is the same. And my concern with this language of cosmetic sunscreen is that it actually still enables the consumer to believe they're putting on a sunscreen with an SPF factor, and doesn't really draw to their attention the fact that the claim has not been substantiated in the same way that it may have been for a sunscreen, notwithstanding the fact that we are living in an environment where that framework and that testing process is demonstrated to have some flaws in it. But I'll kind of pause there, I think, and pass back to the chair. But I'll keep going with this a bit when I come back.
Fantastic. Thank you. We'll go to Senator Roberts.
Thank you, Chair. Thank you for appearing again. Good to see you, Professor Lawler. Psilocybin was made available for treatment-resistant depression on the 1st of July 2023, provided it was prescribed by a doctor registered for the purpose as part of psychotherapy. You received an application to extend that same system, medical reviewed prescription and psychotherapy, to patients in existential distress towards end of life. You refused. On any humanitarian level, refusing palliative care patients the right to access medication of their choice, medication you use for other purposes, under medical supervision to ease their suffering, is very difficult to understand. What's your justification for this inhuman decision?
Thank you very much for the question, Senator. I do disagree with your characterisation of this as an inhuman decision. We undertake extensive work in the scheduling of medicines and poisons. In fact, it's one of our key responsibilities. As you highlight, there was a scheduling change to psilocybin and MDMA in 2023 that enables its use under certain circumstances. It remains an unapproved good, that is, that it's not entered on the Australian Register of Therapeutic Goods, and so there are certain mechanisms to the ability to access it. There was an application to extend its indications to include end-of-life care. There were a number of issues, as outlined in the interim decision that was published last week. There are some concerns, and I'm more than happy to provide the link to the benefit to the rationale for that interim decision, which is there for all to read. It includes such issues as the fact that the term itself that was intended for inclusion as an indication, is not a well-defined or recognised diagnostic modality. The challenges around timeframes. And also the lack of robust evidence. So I take the comment that you make around compassion and humanity. That is one of the inputs that we have to our decision-making process, but so is the robust evidence that must be brought in support of a change to indication.
So you approve it for one use but not another. And the real answer, isn't it, that pharmaceutical companies can't patent a mushroom, they can't make money out of it. Your decision is based on protecting pharmaceutical companies, company profits. Is that it?
No.
So you picked the application apart on technical grounds?
We are a regulatory agency that is risk-based and evidence driven by the management of risk and informed by evidence. We analysed the application for the change in indication on the basis of the available evidence and the rationale for a change. If you choose to characterise that as on a technical basis, we involve significant technical expertise in making those determinations.
Did you do that for the COVID vaccines and the 20 drugs you rubber-stamped under emergency use, including remdesivir, or as it's better known, run, death is near? Dying people getting a psychotropic drug to ease their distress gets the magnifying glass treatment, Big Pharma gets off with a rubber stamp. Who do you work for, Australians or the pharmaceutical establishment?
Senator Roberts, a little respect for the witnesses here. They've come here to answer your questions, so I'd be really grateful if you could form your questions in a respectful manner.
Well, Chair,
with all due respect
Chair,
for your views.
I acknowledge that.
Thank you. Please go ahead.
I'm trying to treat my constituents with enormous respect. And
I'm not sure that your constituents have asked you to come and be rude to some witnesses.
I'm not being rude, I'm being factual.
It's different perspectives. Your characterisation is not mine. Please go ahead with your questions, but I'm asking you to please respect the fact that the witnesses at the table have come here to answer your questions, and if you could ask the questions in a respectful manner, I'd be very grateful. Thank you.
Sure.
Sorry, I might need you to repeat the specific question there, Senator.
You picked the application for psilocybin apart on technical grounds. Did you do that for the COVID vaccines and the 20 drugs you rubber stamped under emergency use, including remdesivir, better known as run, death is near? Dying people getting a psychotropic drug to ease their distress gets a magnifying glass treatment. Big Pharma gets off with the rubber stamp. Who do you work for?
So the TGA is actually functionally a part of the Department of Health, Disability and Ageing. So it obviously works as a part of the Australian Public Service. Our role is to provide appropriate regulatory oversight for therapeutic goods for the Australian people, for the benefit of the Australian people. We do that by balancing the risks of access, safety and quality. We work with other parts of the department, obviously, in terms of providing ready access for Australians to emerging and established therapeutic goods. In terms of do we apply the same level of evidentiary and scientific rigour to the decisions we've taken around the medicine that we choose to refer to as remdesivir, the COVID vaccines and psilocybin, I think it's challenging because the processes that were followed, the questions that were asked of us were different. So, as you've highlighted, the request and the application for a change in indication for psilocybin was just that. It was a change in the approved indication for use, and so there is a requirement. We have done the evidentiary work on enabling the prescribing under certain constraints as an unapproved therapeutic good, and that's been proceeding. And we've been working with health professionals, with advocacy groups to ensure that there are mechanisms in place to enable the prescription of those medicines for treatment-resistant depression and PTSD as appropriate. So we've actually received significant positive feedback from patient groups and from advocates around the decision that was taken to enable access to the medicines. In terms of the process that was followed, we didn't provide emergency use authorisation for the vaccines. We registered them through a process that we've discussed many times in this place, Senator, called the provisional approval pathway.
My apologies, that's correct.
No, that's fine. I just want to be really clear. And the process that was followed there was on the basis of the need for ready access to a vaccine in the face of a once in 100 years pandemic that was evolving as we knew it, was that there was a process of approval with the implementation of appropriate risk management plan and the requirement on those sponsors to provide corroborative scientific evidence with a transition to full approval and authorisation. So the short answer to your first question is: did we apply the same level of evidentiary rigour to the vaccines and the treatments? No, it was order of magnitudes higher than we did for the discussion around the indication approval. And in answer to your second question, I think we very clearly work for the Australian public.
Senator Roberts, if I may, not to lead your questioning, but there is opportunities for drugs or medicines to be reconsidered if other evidence comes forward. I think you're talking about the use of a medicine which is emerging in the way that it's being used, and we've seen over many years the way that we approach the treatment of trauma or PTSD and things like that changing. And I wonder if Mr. Lawler, if it might be helpful for you, could give you some information or advice for your constituents who have raised this with you about what the process might be in the future if more evidence comes forward or the sponsor provides more information.
Thank you, Minister. We'll get to that.
Yeah.
Minister, are you aware that during the early days of the COVID response in this country, the predecessor Chief Medical Officer, not the current Chief Medical Officer, advised me that the severity of COVID was low to moderate, which then, if you think about the people who are under extreme threat, elderly, immune compromised, it means the average or the typical person in their 30s, 40s, 50s is under very limited threat. It's also, he showed me, the Chief Medical Officer showed me in a graph that the severity was less than previous past serious flus. So I just wanted to, but come back to Professor Lawler. The inquiry had 590 submissions in favour of relaxing the rules and 5 in favour of not doing so. You relied heavily, apparently, on 1 out of those 5, Palliative Care Australia, to give legitimacy to your objection. That organisation is federally funded by your department, and here we have another of your department's agencies agreeing with them. Minister, was this whole process a predetermined outcome, nothing but theatre to satisfy Part 6, Bracket 3 of the Therapeutic Goods Act requiring a structured process of consultation and inquiry?
No.
Let's move on to serotonin reuptake inhibitors.
We've got about 3 minutes left, Senator Roberts.
Let's move on to benzene, then we'll come back to SSRIs. The US FDA recalled a group of products which they found to contain high levels of benzene, a known carcinogen. In response, the TGA put out an advice which read in part, quote, TGA is aware of the US FDA's 2025 voluntary recalls of a small number of benzoyl peroxide. How was that?
That was pretty good, Senator.
Acne treatment due to elevated benzene levels. As of March 2025, the matter was, quote, currently considering what regulatory action, if any, should be taken in Australia. Have you pulled some samples of acne products to test for benzene levels yourselves?
So, Senator, thanks for that question. I just highlight, as I've highlighted previously, that we incorporate safety signals from a number of sources, and one of those is the decisions of international regulators. On the specific issue of benzoyl peroxide products, I'd probably have to take that on notice because that's quite a specific question. I don't want to be in the position of answering that accurately.
Thank you. We value accuracy. What does currently considering mean? What does it look like? Or is that code for doing nothing while pretending to be concerned?
Okay, so that's. I'll answer your second question first. It's not. Currently considering means that, as I mentioned previously, we undertake continuous post-market monitoring on therapeutic goods. So that's through pharmacovigilance, the monitoring of safety signals as and when they emerge, working specifically with states, territories and other stakeholders, and having an understanding, as I say, of international safety signals. In terms of currently considering, with respect to the way in which it interfaces with our routine post-market pharmacovigilance, I think, again, I would have to have some more detail of that item in front of me, so it might be better if I were to take that on notice.
Thank you. Those acne products are registered with the TGA. How much does it cost to licence an acne product through the TGA, please? Application fee and annual fee, if any.
Sorry, Senator, I'll just find that information.
Thank you. Move on to the next question while we're waiting. What percentage, Professor Lawler, of the TGA's revenue comes from these licensing fees and related payments by product sponsors?
Sure. So I have. I'm not sure whether Mr. Bedford might be in a position to respond to that. We've had this conversation before, and I know that we've had the discussion around the 96% figure, and I think that is a few years old. Our funding sources come from a number of different sources. We have, in essence, firstly, the cost recovered figures that we've discussed previously, which are fees and charges. I'm just trying to get the figures up myself. Then we have our public good appropriation, which is those amounts that are given to us through appropriation through budget that are used for used for activities that are not appropriate to be cost recovered. We also have a small amount that's given to us by the Department of Foreign Affairs and Trade, which we use to provide regulatory capability uplift in the region. No, Mr. Bedford.
Could you give them to us on notice?
Oh, we have the numbers. We have the numbers right now.
Good afternoon, Senator. Chris Bedford, First Assistant Secretary, Regulatory Practice and Support Division. So in answer to your question, for the current financial year, the budget is 75% of our funding comes through fees and charges, and 25% is through appropriation from government.
Thank you. Two more questions, Chair.
Senator, I've got those fees and charges available now.
Okay.
So the annual charge would be $5,362. And we have different categories of a submission. So if it was a brand new submission, a new chemical entity, the application fee is $58,663, and then the evaluation fee is $235,115. If it's an extension of an indication, so if it's already on the register and it's a new indication,
The application fee is $34,988 and the evaluation fee is $139,483. If it is a new generic product, the application fee is $22,625 and the evaluation fee is $89,801.
Thank you. A lot of money. Do you have
Senator
a bias?
Roberts, is this your last question?
I've got two. They're both pretty short. Do you have a bias, Professor Lawler, conscious or unconscious, normal human, towards protecting your revenue stream by being slow to recall products?
Thanks, Senator. I can't...
Conscious or unconscious?
No, I can't tell you whether I have an unconscious bias. I certainly don't have a conscious bias.
Is there any tendency towards that in the department?
No. We have a process whereby we have cost recovery. We undertake work on behalf of the Australian public, which includes evaluation and ongoing monitoring of therapeutic goods. We recover the cost from sponsors to cover that. We do not work towards the development of healthy cash reserves. We do not build up a war chest. We do not seek to over-recover, and I would posit fairly strongly that there is no perception from the industry stakeholders with whom we interact that we are either undercharging or giving them an easy ride. The role that we have in regulation is to apply the appropriate risk and risk treatment and evidentiary basis to ensure that products that are supplied to Australians strike the right balance of access and safety and quality. We certainly do not have any strategic, tactical or other intention to protect our revenue stream. If we have more work to do, we charge for more work. If we have less work to do, we charge for less work.
Thank you.
And we use those resources in protection of the Australian public.
Last question in this bracket. In the last 5 years, when was the last time the TGA detected an issue with a drug or a problem with a drug or medical device and issued a recall on your initiative rather than relying on foreign regulators finding issues?
A recall, and so I'm not being tricky, Senator Roberts. But when you say recall, we have a recalls procedure that covers product corrections, cancellations, voluntary and non-voluntary recalls, and quarantines. Are you talking about all of those things?
Yes.
Okay. I'm happy to be corrected,
if you want, take it on
notice.
No,
I'm happy to be corrected, but we're sending out recall notices and notices on that nature every week. So I'm happy to provide you with information around some of the recall actions we've taken in the last 12 months, if that would be helpful.
Under your initiative, not as a
They
result
are all under our initiative. We're the only ones that can institute recall actions within Australia.
I accept that, but sometimes you rely upon foreign agencies to advise you there's a problem with the goods before you work it out.
And I am
so
going to rotate the calls.
I can provide... Sorry, Chair.
We can come back to you, Senator Roberts, but I am going to have to...
What do you initiate?
All of them.
Yes, please.
No, we initiate all of them.
What do you detect yourself? Not.
We detect all of them through various signals that we receive, including over the actions of international regulators.
Excluding where you've been advised from external.
So not all of the recall actions that we're taking.
Correct.
I'm happy to take the question on notice, Chair.
Just the ones you've identified yourself.
We've identified all of them ourselves, Senator.
I think you know what I mean.
Yeah, I do, but I'm not sure you know what I mean. So I'm not trying to be difficult. What I'm saying is that we have a multi-partite process of post-market vigilance on all of our therapeutic goods, and it is one of our significant inputs. Every regulator works that way.
It might be valuable to pop that on notice for Senator Roberts, just for that point of clarity. That would be great. Thank you.
Thank you, Chair. Thanks, Senator.
We will go to Senator Colbeck.
Thank you, Chair. Thank you. I just want to go very quickly to the annual report, which might be a rare thing for a senator to do, but I'm going to, in relation to one of the planned performances for 24-25, which was progressive decrease of daily smoking prevalence towards less than 10%. It's been actually trending up over the last few years. 22-23 was 10.1. 23-24, 10.6, 24-5, 10.7%. And in the budget, the same objective is there in relation to achieving that, but it says that it's on track. I'm just concerned as to how you could claim that that objective might be on track, given the recent nicotine monitoring from around the country that shows an increase of about 4%. But more problematically, the information released by the ABS today that indicates that the quantity of nicotine consumed in Australia increased by almost 40% from 2017 to 2025, with most of that increase occurring since 2021, and population growth of that over that period was 14%. So, I mean, how on earth are we suggesting that we're on track to meet that objective, which I think everyone would support? We've done great work over recent decades in changing the community attitudes towards smoking and the prevalence of smoking, but this data released today is very, very concerning.
Thank you for the question, Senator Colbeck. Trish Clancy, First Assistant Secretary of Population Health. So the data released today is in relation to nicotine consumption,
yes,
which includes tobacco, but it
yes.
also includes nicotine through vapes, nicotine through pouches, but also therapeutic nicotine products like patches and gums, etc. So it is not a measure of tobacco consumption.
No, it's not. It's a measure of nicotine consumption, including all of those things, and I acknowledge that. That's what the report clearly says. But it also talks about there having been a progressive reduction in the consumption of nicotine, and that the increased number is a startling number.
The increase, our consumption of vapes or use of vapes in this country increased quite significantly since 2017, particularly 2019 onwards.
Yes, I'll come to vapes in a minute.
Which are part of this.
Yes,
so we're
I
not
understand
entirely surprised by this quantity of increase for overall nicotine, given the usage of vapes. And it is hard to unpick what's vape versus tobacco in this.
Look, I understand that, but if you're looking at the vape consumption, I think the report talks about something like 96% of vapes coming from the illicit market. So effectively, it's an illegal market. And the next statistic in the report, and this is the second finding basically of this piece of information, is that the increase was underpinned by a large rise in illicit cigarettes, as well as increases in e-cigarettes and other nicotine products. Consumption from illicit sources as a share of the total tobacco consumed rose from 12% in 2017 to 80% in 2025. I mean, we are saying that 80% of the nicotine market in this country is now run by organised crime. Surely that sets off alarm bells.
Senator, I think you're referring to the illicit tobacco market rather than the nicotine market. And yes, there are a number of estimates from a range of government sources. I think the ITEC Commissioner has a slightly lower one. This particular ABS report, which is a very interesting and experimental study, has put another figure on the size of the illicit tobacco market. Government is well aware of the rise in the illicit tobacco market. There has been extensive investment in trying to combat it, both in the health side of it, which is trying to decrease demand for all types of tobacco.
But it's not working. I mean, it's clearly going the other way, and I think it's a bit rough to try and pass it off as being experimental, because when you get into the report, it talks about that these estimates were peer-reviewed by the ITEC Commissioner, the Department of Home Affairs and the Australian Tax Office. I mean, so it's not as if the ABS is out there on their own on this. This work, the methodology, has been peer-reviewed by the ITEC Commissioner, and I'm aware of the estimates from the ITEC Commissioner. I've had some conversations with Home Affairs and talked to Tax Office tomorrow, but if you look at just on tax data, from 2019's tax data to what's in the budget for this year, we're talking about a 74% reduction in excise, which would indicate roughly the size of the market because the two have lined up. Surely there's some concern about where this is going with this data that's landed today.
Senator, the government agrees and is highly concerned about the rise in the illicit tobacco market. We have seen significant investment across government to combat it, both in the law enforcement agencies in terms of Border Force and police. We have also increased our investment through the states and territories, through the Federation funding agreements, because as you would appreciate, a lot of the compliance and enforcement efforts are on the ground.
Yeah, but that number's $14 million
laws.
in this year's budget. It's $14 million in this year's budget.
That figure, Senator, is in addition to the already existing Federation funding agreements in place with the states and territories to boost their compliance and enforcement efforts.
So if you look at the figures out of the budget so far, we're talking in this agency 737 over 4 years from the 23-24 budget for managing illicit tobacco, and there are other numbers from others in the other agencies. Border Force has got 188 and ITEX, the Commissioner's got just under 20 in their budget from 25-26. There's an increased funding there. But surely all of this starts to add up to the fact that what we're currently doing isn't working, because the numbers keep on going in the opposite direction. I mean, I'm mortified at the impact that those who've worked so hard, particularly in the public health arena, of the effort they've put in over the last 20 years to change, as I said, community attitudes and reduce the impact on smoking. But what the government's doing isn't working, and if we're going to just pass this off as experimental data, it shows, I don't think, any serious reflection of what's actually happening out there. And this is actually verifying what people are telling me on the ground with what's happening in their businesses.
Senator, can I just say that the government is very concerned about this data as well. We share those concerns. We are taking this incredibly seriously. We are up against big tobacco and organised crime, and that is why you have seen... I mean, sorry, can you just let me finish my...
Trying to blame this on big tobacco is ridiculous.
Well,
this is organised crime that's taking control of the market.
I'm very clear about those two elements that we are working against, and that is why we have made the investments that you listed off yourself in what I would refer to as a multi-pronged approach. Funding for illicit tobacco through Home Affairs, cracking down on those organised crime syndicates, and we can take you through the amount that has been seized by police agencies. We are increasing the penalties, we are improving regulation, we are stamping out these activities, and we are also at the same time delivering investments in our health portfolio, which we can talk to you about in this portfolio, to raise public awareness and to help people stop smoking. We recognise that this is one of the biggest public health issues, and that's why we are taking it so seriously. But as I say, we're up against big tobacco and organised crime, and we're taking them on.
Senator, Minister, the driver of this is organised crime. They have 96%.
Well, you can defend big tobacco if you like, but I'm going to group them together.
I'm not defending big tobacco. I'm not a smoker, never been a smoker, and so don't try and put words into my mouth.
Exactly.
This is exactly the attitude. This is exactly the attitude from the government that we've had all the way through this, where ministers come out and try and ridicule people who are concerned about.
I don't understand. You're trying to draw a distinction.
Go personal, which is exactly the
I would suggest
go personal. That's exactly the.
I don't think
we're actually trying
Senator
to kill
Colbeck,
off.
if you could just hold on one moment, I don't think we're going to get anywhere if we're going to start talking over each other.
Well,
let's just, Senator Colbeck, please don't let me finish my sentence, if you don't mind. Ask your question, then the minister does get to answer it. You get to counter that. but I think it's very unhelpful if we're talking over each other.
Thank you, Chair.
So
But
Senator
can I say
Colbeck,
to
over to you.
I get very, very tired of this government who, when they're in a corner, go personal and start making personal reflections about people. It's not within the standing orders, and so.
I'm not
so it's
sure
a
that
deflection.
that was a
It's a deflection
by
that the
any
government
stretch.
uses. I get all that. That's the politics.
And you're having a political hit out now, Senator Colbeck.
And
good on you.
I am expressing a concern that I've been on the public record for a long time with respect to this. I think the government policy is wrong, and I'm quite entitled to say that.
You are.
I'm not talking about anyone particularly here, but this is very, very concerning data, and I find it troubling that there's attempts to pass it off as experimental when it's been verified and the methodologies have been verified by the agencies that are being employed to manage this. So the Commissioner, the Department of Home Affairs and the Tax Office have all been part of pulling this process together, and the government just wants to try and deflect this as though there isn't a problem here that a lot of other people see.
And you're very entitled to your opinion, Senator Colbeck. The
And I'm
Minister is also
entitled to express it.
The Minister is also entitled
Without
to
reflection.
We just have to.
If you could stop speaking over people, Senator Colbeck, that would be really helpful.
There's just a clarification.
The Minister has a right to respond now, and I'm telling you that you're coming up on your 15 minutes. Senator.
I'm actually going to let the official just make a clarification. No, it's a helpful
No,
to
it's fine.
clear up what you've
I just
suggested.
would like to reiterate a comment I think we've all made, that we think this is a really serious issue. If you look at the success Australia has had in smoking reduction over a very long period of time, it's one of the major contributors to us having one of the longest life expectancy in the world.
Agree.
We're not as good on alcohol consumption, we're not as good on obesity, we've got move to do, but this is a very significant contributor. When Ms Devlin was and Ms Clancy were talking about this, they used the terms experimental because that's actually in the preface of the ABS report. We are not using that words in any way to distance ourselves from the severity of this data. It's very important and potentially groundbreaking work using wastewater data, so we take that very seriously. So we just like to reiterate, we take this ABS data very seriously. It's got to be correlated with other data. I think there is no question that illicit trade is increasing. The question of exactly the increase of smoking rates is harder to estimate, but clearly we've got a real public health challenge, and it's not just the illicit market that we need to look at in this area to get us back on track. To your original observation about the performance measures, I think those points are well made. We actually do say in the annual report we're off track on those measures that were put in there, which were annual measures. The budget papers, I think you make a good point. They have a longer term target that's a little bit vaguer. I think we should look in future about whether we've got the right target in the budget papers and the performance measures. And I think we should also look at the data sources that we're going to use to assess that target in the future. But I just wanted to give you the assurance that we very much take this seriously. I think there's a lot of work to do between a number of agencies and the community on how we address this issue.
Thank you. And can I say I lament the likelihood of an increase in smoking rates, like everybody else does here. I want to acknowledge the work that public health officials in particular and public health advocates have done over a long period of time to change the culture here in Australia with respect to smoking. It's a huge achievement for us all. I just don't want to see it be lost through the activities of particularly organised crime, which is driving the consumption levels in this country. And I suppose the question that comes out of that, and this is, I think, particularly from a government perspective where the difference is, if 60 to 75% of those consuming tobacco aren't paying the excise, how do we claim that it's an effective measure when it's not being paid? I acknowledge that price is one of the key indicators to people stopping smoking, but when such a huge proportion of the market isn't paying the excise, on what basis is the measure still effective?
I'm just is that a statement or a question? Well, I think that this is the thing that we are taking seriously, because you are right in the sense that it's the effective price paid that is the thing that drives what people's behaviour is. It's certainly the case that, if not now, until very recently, price has been a significant contributor, not just onto whether people take up smoking or cease smoking, but also the volume of smoking they do when they're actually smoking. So I think that the objective that we would have from a policy perspective is to ensure that that effective price continues high, and that is being undermined for a proportion of the market at the moment. We also think about other measures that we continue, which we have for a long period of time. Obviously, the whole anti-smoking movement has got a whole range of things, including no one's smoking in this building, and there are also a lot of campaigns on the public health side.
So, Senator
One last question.
I am going to have to rotate the call.
Yeah, just one question. I just want to ask, the Treasury said to us in February that they'd done some elasticity modelling with respect to the excise and its impact on pricing. Can I ask whether any of that information has been shared with you, or whether you were consulted as a part of that process?
There has been lots of consultation across government in a range of forums around tobacco excise, the government's response to illicit tobacco. So we are in routine conversations at an officials level with colleagues from Treasury, Border Force and Police.
So does that elasticity modelling say anything?
And we'll go to Senator Whitten. Thank you.
Thanks, Chair. I've got some questions on mental health and suicide prevention. And just at the outset, I just want to say I'll be asking questions about male suicide in particular. I'm not taking away from other cohorts. I'm not saying that they are not worthy also of funding and help. I just want to specifically talk about men's suicide prevention. So 3 in 4 people who die by suicide in Australia are male. The National Mental Health and Suicide Prevention Agreement lists 15 priority populations. Men are not among them. There are specific strategies for other specific cohorts of people, yet no equivalent strategy for men. Can you explain why the group accounting for 75% of suicide deaths have been deemed less worthy of a targeted national strategy than those other groups?
Thank you, Senator. Look, I think probably the broad answer to the question is that obviously the government probably takes all suicides very seriously. Obviously, it's a terrible thing for individuals and families and.
Sorry, I'm really quite deaf.
So I think the government takes all suicides extremely seriously. So so that's probably an overarching point of view. I mean, obviously the numbers remain fairly intransigent over a long period of time. So governments do take that very, very seriously, and we covered that a little bit earlier today, which I'm happy to go through again. So there is a range of effort for suicide. I mean, it does also sit under, released in February last year, there is a National Suicide Prevention Strategy that was released, developed by the National Suicide Prevention Office, that I think are here today, that may want to provide evidence on this as well. And that, of course, covers all suicides, and that is, I think, quite acknowledged that that men form a disproportionate part of that cohort. So they are acknowledged in that broader strategy because of the data that sits around that, and so probably embedded in everything we do is this concept of breaking that number down and looking at that cohort. There are specific things we do for men for suicide that we cover. We do have some programs for specific industries that sort of are disproportionately affected by suicide. So some of the construction industries, etc., have a higher rate. More men work in them, their suicide rates are higher. So we have funding for programs for things like the mates in construction, mates in manufacturing, fly in, fly out and dry out services. We have a funding for a thing called Men's Tables, which is specifically targeted at men. So there are actually a range of programs that are targeted at men. There's also a broader men's health strategy and work that's also put in there from a broader point of view that's not specifically suicide related, but of course suicide relates to the broader well-being of people. So there is broader effort from a broader men's health point of view as well.
So are you saying in the National Mental Health and Suicide Prevention Agreement men are mentioned in there?
I would say that sort of not a specific cohort, but they are, you know,
do you think they should be, given that there's 3/4 of actual suicides?
Look, I think as I said, all suicides are very significant things.
I'm not taking away from any other thing. I just want to know about men.
Look, I think it's whether they are identified as a separate cohort. It's probably less an issue of whether we have the right actions in place, you know, to do things, which is really where there is a range of work with the jurisdictions and stakeholders now looking at that broader question and the national strategy.
You've listed 15 priority populations and men aren't one of them. It doesn't make sense to me. It wouldn't make sense to a lot of people.
Look, that's fine. I'm not questioning. I mean, obviously they are disproportionately affected, which has been a known thing for a long time. So I think in the actions and the strategies, it is something that is taken and embedded into the broader strategy. And so, for example, the National Suicide Prevention Strategy, there's not a national men's suicide prevention strategy and one for others. It is all part of the same strategy. So probably reflecting the broader, strategy document, we don't tend to separate. It's not to say that there's any reason why we sort of couldn't or that could be considered in the future, but it isn't, really, it's not where it is now in the current agreement. You're correct, but there is a lot of focus on men because of that data.
Australia's suicide policies seem to be failing. From 2000 to 2021, Australia's suicide rate fell by 1%, while the global average declined by 36%. Can you explain why Australia is doing so badly compared to the rest of the world?
Look, I'm not aware of the broader global statistic, and this might be one for if we do have our National Suicide Prevention Office, maybe more across the broader international trends. It may reflect that in other countries that they're, starting from a higher position than Australia was. That's perhaps something that we can look at from that point of view, but I'm not sure that the international comparison is something I can provide you with.
There seems to be a very big difference between us and the rest of the world by the looks of it. So.
Well, I think it would probably come down to, I think you would need to look at the prevalence rates per 100,000 as opposed to that and where they are relative to Australia as opposed to the percentage drops.
Senator Whitten, I just wonder whether we've got Dr. Howard Haynes, who's the head of the National Suicide Prevention Office, may be able to provide more information for you.
Yeah, thank you, Secretary. So, Alex Haynes, the head of the National Suicide Prevention Office. We haven't got any information for you with regards to the statistic comparing Australia to international, but I did want to come back to your earlier question with regards to men's suicide prevention. So in the National Suicide Prevention Strategy, which was launched just over a year ago in February last year, we do overtly call out men and boys as a population that is disproportionately impacted by suicide and list a number of recommended actions in order to address that.
Just to be a bit forward-looking about that, the Productivity Commission has obviously referred to that strategy in its report on the existing national agreement that it provided towards the end of last year, sort of saying that strategy really should form something that governments consider as part of developing the next national agreement, which is probably why I'm sort of not trying to kind of dismiss what you're saying, but to sort of say that it is actually embedded in the broader strategy, and that is something that governments will consider as part of the development of the new agreement.
Yeah,
and whilst acknowledging that, I think that everybody acknowledges that whilst the rate is above zero, we still have a lot more work to do.
So, according to analysis by the Australian Men's Health Forum, 4 in 5 beneficiaries of government-funded suicide prevention services are female, despite men accounting for 3 in 4 suicide deaths. Do you agree with these figures?
I haven't specifically looked at that. I don't think I've got those figures in front of me, so we'll take them at face value.
Can you provide on notice the figures that you do have?
We have lots of figures, obviously, from... there are quite extensive statistics, particularly through from the suicide self-harm monitoring system, that is probably where we draw most of our data on from there. But yeah.
Once again, I'm not taking away from money being put towards prevention of women's suicide, but I'm specifically talking about men, and it seems they're not getting the same level of funding as women. So if you could provide on notice a breakdown between that.
Senator, I'm not sure that we would agree with the assertion that there is a different level of funding between men and women for suicide prevention in Australia. So I don't believe we have data that would suggest that to you. I just do wonder if the data you are referring to might refer to broader mental health supports, and it is not unusual for women to sometimes look after their health or proactively seek help, sometimes more often.
If that's the case and I've got the numbers wrong, then I'm wrong. But would you mind providing on notice the numbers that I've been asking for?
Very happy to look at that and see where this is, because I mean we do know Dr. Devlin is right. So from many of our broader mental health services, probably usually it's above 50%, more than 50% is female. And we have things like Medicare mental health centres and things where, and some of our youth services where quite often it can be 60-odd% or more, of female clients as opposed to male. So, but there would be other services that would be different to that, as I talked about at the men's table and the mates in construction and those sorts of programs where they would be disproportionately male, not female. So it would depend on the service as well.
The New South Wales Government's 2024 report on men's suicide found that 15.6% of men who died by suicide were experiencing family disruption or divorce, and 13.6% were having serious problems with their spouse or partner. And the ABS coroner's data confirms relationship and family breakdown as a major suicide trigger for men aged 25 to 44. Why do none of the federally funded suicide prevention programs address these situational drivers?
So I think it's probably, I don't know that we would accept that proposition either as, as such. I think, when you think about mental health services, we have obviously, there are multiple places that people with mental health concerns and other issues will be, whether they're caused by domestic violence or other things, will, and it can be, vice versa, will sort of present. So, for example, people may go to a GP, they may go to a specific mental health service, and most of those services are generally, they are, as part of their sort of training, and others are aware of domestic violence as a driver of those concerns, and then will, be able to respond at some level to those drivers. I know services like Relationships Australia have counsellors embedded in there that, partly because they recognise for some of those services that they have people that the relationship breakdown causes other stresses, including mental health services, so they have counsellors that are there to deal with that as part of their service design. So there does tend to be a range of services that are able to respond to that, to those dimensions, depending on where they present. But that's of course acknowledging that it is absolutely genuinely a driver for distress for people. I don't know whether
that wasn't a proposition.
Last question, Senator Whitten.
I've got two, if that's okay.
Last question, Senator Whitten. You can put them on notice or you can rotate. Nobody's paying any attention to me trying to round them up, so I'm just going to be harsher from here on in.
All right, well, that wasn't a proposition, that was a report, so it'd be good to see some research into that. But the coroner's data consistently shows a large proportion of male suicides are precipitated by situational distress. That's not a proposition. Financial crisis, family breakdown, loss of children, and not simply by mental illness. Can you explain why suicide prevention sits entirely within the Health Department, and is the department structurally capable of addressing causes that are social, legal and financial rather than medical?
Senator, I think the government's release of the suicide prevention strategy made it very clear that this was a whole of government issue, and the activities described in that strategy refer to broad portfolios outside of health for the activities that are required, recognising the drivers of suicide.
Thank you.
There's a lot of men watching this, so I'd like to see something change.
Senator Whitten, you're welcome to put your name back on the list for another rotation or to put further questions on notice.
Senator
Thank you for dropping in.
Before we move to the next, can I just make mention, of course, of the work that the Special Envoy for Men's Health, Dan Repicoli, is doing in this space, not only highlighting men's health but also encouraging conversations about mental health, and I'm sure he would encourage you to join him in that quest.
Well done, Dan.
Thank you.
Yes, thank you. We'll go to Senator Bragg, and then for 10, and then we'll go to Senator Steele-John for 10, then 5 for Senator Brown, and then we will break. So we're going to be a bit late. Senator Bragg.
I have some questions for APRA. Thank you, Chair. Mr. Understeiner, last time you were here, which was in February, I asked you whether or not you had adopted the definition of anti-Semitism as recommended by the Special Envoy, which the government has adopted. Have you now adopted that definition?
Sure. Good evening, Senator Justin Untersteiner, CEO of APRA. I'll answer that question very quickly, just to start by saying again, we have no tolerance for discrimination or racism in our system whatsoever, and all Australians should be able to access health services in this country without concerns of fear and discrimination.
Of course.
Last time I was here, I mentioned to you that we had been working with the Special Envoy combating anti-Semitism, that they were about to release a report which talks about how to operationalise the IRA definition. We were waiting for that report. That report has now been released. We attended the launch. In fact, my colleague next to me, Nicole Brady, attended the launch. We have met with the Special Envoy and applauded them for the release of that additional information. On the basis of that, we will be adopting the IRA definition.
You will be?
Yes.
Well, that's a very good step forward. So a lot of people will be pleased to hear that, Mr. Understeiner. Can I ask you about, do you have a vexatious notifications framework?
Yes, Senator, we do. So we, at the moment, we have a framework that supports the identification and the management of vexatious complaints that come to our service. We understand that vexatious complaints can cause a great deal of harm to practitioners that they target. We have, though, through our engagement with different communities, including the Jewish community, have heard stories about how concerns of vexatious complaints targeting Jewish practitioners. And so through all of our engagement across many groups, we've heard that.
Yeah.
We also, just to share, recently undertook some research, which I'll allow my colleague to sort of talk to in a moment, which further validated concerns we have around vexatious complaints, particularly in remote and rural areas. As a result, we will be undertaking a further review of the vexatious complaint framework, and part of that is we're inviting people with lived experience to come and help us with that. We've been working at the moment with the Executive Council of Australian Jewry to support us on that work as well, to make sure we have appropriate representation. But I might ask my colleague...
Can I ask before you, who's working on that for you? Who's leading that?
That's been led within our organisation.
Right.
Yep.
By
members of my team.
Right.
I can give you specific areas, but I'm not sure it'll... Sure. So we... actually, I might pass on to my colleague.
Thank you. Nicole Brady. I'm an Executive Director at APRA. So I have a team within my directorate that has a lot of experience in working with people with lived experience of our notification system, not necessarily always positive experience of the notification system. They did some extensive work over a number of years relating to practitioner distress. They worked with families of practitioners, and they also worked with practitioners, and they've made recommendations and changes to the way we handle practitioners. That same group of people is now embarking upon a review to work with people with lived experience of racism and discrimination notifications, potentially vexatious notifications, to make sure that we're responding appropriately and taking into account their concerns as we seek to improve that experience.
It's a committee, is it?
No.
How many people are working on it?
Oh, the team is about 6 people who sit in that team, and then we're establishing very carefully a panel of lived experience practitioners. In my conversations, very preliminary conversations with the Executive Council of Australian Jewry, for example, they express concern about the trauma that some of their practitioners have experienced in relation to anti-Semitism. So they are going to give us advice about how we go forth and embark on this work. So it's a team of people doing the work guided by a panel of people with lived experience.
So was Associate Professor Marie Bismarck involved with this?
No.
No. And what about Dr. Meg Mundell?
No.
Not involved with it?
No.
Okay. Can I ask you about some of the cases we discussed last time? You may recall we discussed a case where a woman had her name anglicised in a Sydney hospital. You said you would come back and provide more information about that.
Yeah, so Senator, I don't know that that is a question for APRA. As the regulator of health practitioners, that was an action that was taken in a New South Wales hospital. And so that would be...
Department?
Yeah, again, I think it's actually the New South Wales Health Department, as opposed to Commonwealth, that could support that. I don't know.
I believe that's the case. My understanding is that incident was in a New South Wales public hospital.
Yeah, I'm just going through the Hansard. You helpfully said that you would come back and provide some information, but maybe the information is that I should be asking the New South Wales government about that.
Yeah, I do apologise, Senator, if I gave you the wrong sense last time. I think when you asked me that question, that was something that we had just learnt about in the media. You know, I understand probably what you understand at the moment, which is that there was a Jewish person who was taken to a New South Wales hospital at the time of the terrible and horrific events in Bondi, was given a pseudonym, and my understanding was the general reason for doing that is to protect the individual from media, understanding that that they're there. But again, because I'm not part of the New South Wales system, I'm unable to obtain any further information, and I'm not the right person to be able to answer that question. So again, I apologise if I gave you the wrong impression at the time, but it would certainly be New South Wales Health that would be able to assist.
Okay. Do you have a definition for Islamophobia?
We don't at the moment, no, Senator.
Okay, so who do you consult with on Islamophobia?
So we, at the moment, we have been working with the Special Envoy combating Islamophobia. I meet with the Special Envoy on a regular basis. We also have been working with the Islamophobia Register, which again is a reputable organisation in Australia that captures information and events of Islamophobia, but also provides training and information as well. And so we partner with both of those organisations.
So I noticed you've put a statement on your website, a joint statement with the Special Envoy to combat Islamophobia.
Yeah, correct.
Yeah. Will you have one on the Envoy to combat anti-Semitism?
Yeah, look, we've got a very strong relationship with the Special Envoy combating anti-Semitism. We've been in active discussions about...
No reason why you haven't published the same thing on your website?
Well, to have a joint statement, we require both parties to develop that joint statement. We've been working with the Special Envoy to do that. It's a positive discussion. I'm having further discussions with the Envoy tomorrow.
Right. Well, was one of the sticking points the adoption of the international definition of anti-Semitism?
No, I don't believe so. No. Again, we have I mean, I can't talk for the Special Envoy, of course, but I can give you my sense. I meet with the Special Envoy on a regular basis. They seem pleased with the actions that we've been taking. We've been taking a lot of work, and I'm happy to share more of that work. We've got a significant amount of work underway. And again, they seem, our recent discussions seem very positive about putting out a joint statement to talk about that work as well. So I don't think it's a sticking point.
Strange. I'll need to wind you up, Senator Bragg, if you want to finalise.
Well, this was a bit odd that you, thank you, Chair, that you didn't have any statements post the Bondi incident.
Well, it's not true, actually, Senator. We did put out information immediately after the Bondi incident. It just wasn't a joint statement with the Special Envoy. And again, I've been pretty open about this. We take anti-Semitism extremely seriously. We've got a very good relationship with the Special Envoy. We work very closely with the Monash University Centre of Jewish Civilisation. We're doing incredible work with them. We're now also working with the Executive Council of Australian Jewry as well. But we also work with other groups to deal with other forms of discrimination that we see in the system. And unfortunately, we're seeing also high levels of discrimination relating to Islamophobia at the moment too. We're also seeing discrimination against Aboriginal and Torres Strait Islander people, and we're seeing discrimination against others for other reasons too. And so we work with a range of different organisations to make sure that we can, number one, understand the experiences of those in the community, but also to send messages out to the community that so they understand that we're listening and we're taking them seriously.
Well, I think I'm being wound up by the Chair, so can I just ask one final then? So, sure. Have you had any, sorry, I just wanted to get your latest numbers of complaints about anti-Semitism. What's the number?
Yeah, sure, Senator. So the total, I'll give you two figures, I think it's most helpful. Yep. The total for this financial year, the total number of complaints that relate to racism and discrimination is 126, and of those, 34 related to anti-Semitism.
Yeah, and just so, have you had any in relation to St Vincent's Hospital in Sydney?
I would have to take that on notice, Senator, and also I would have to note, based on confidentiality, I have to be careful what we can share if there's live investigations, but I'm happy to take that on notice and come back to you.
Well, with the Chair's goodwill, can I request that maybe we could arrange a private briefing then, if the Chair's willing to arrange that?
Sure. I mean,
if you don't want to air these things in public.
Just to be clear, I don't have an issue with airing things in public. I need to follow the law that we have to apply, and that includes confidentiality. But I'm happy to either provide it notice, and if that's not sufficient, certainly happy to do a private hearing.
Senator Bragg will follow that one up offline in terms of the notion of a private briefing with these guys.
Thanks, Chair.
Absolutely. We'll go to Senator Steele, John.
Thanks very much, Chair. So we'll go back to the TGA and sunscreen.
Chair, can I just ask the question? Are there other senators who are seeking a call from APRA, or could they be excused?
At this point in time, I'm not in a position to release anyone. We are trying to ascertain that to enable us to ease our way through the evening.
Just checking.
Absolutely. On it.
So just continuing where we left off on the topic of cosmetic sunscreen within the consultation, have you undertaken any research on people's response to the label cosmetic sunscreen? As in, have you checked that people understand that this means, you know, not properly regulated? Because my guess would be, as I discussed with you earlier, that the label cosmetic sunscreen, including the word sunscreen as it does, would communicate that it is actually treated like sunscreen and therefore regulated properly.
So just perhaps before I ask Mr. Anderson or Mr. Clark to comment, Professor Anthony Lawler, I should say, Deputy Secretary Health Products Regulation, there are a couple of things that we've taken from the experience in our examination of sunscreen regulation and our move towards reform. Some of those are specific issues around testing and so forth, but one of the really clear messages that we've taken is around the role of a number of players in this space, which includes ourselves as the regulators, other regulators of products in this space, including the ACCC and ACUS and so forth, but also sponsors, health professionals and advocacy groups in obtaining a better understanding within the Australian community around such things as sun-safe behaviours, SPF labelling, and again, that's one of the reasons that's prompted why we've incorporated that into our consultation, but one of those that has in fact particularly prompted its incorporation into the consultation is around the cosmetic sunscreen issue and what people understand from that. So in addition to our looking at the regulatory parameters around it, it is a matter of us understanding more clearly what is understood by the community and how we can work to improve that. Mr. Clark, if you'd like to perhaps...
And to add to that, primarily putting this in the consultation paper was that concern from our end that consumers do not understand that cosmetic sunscreens are regulated as cosmetics. So if they see a 50+, the differentiation between a primary sunscreen or a secondary sunscreen isn't known. So we haven't done any specific research on this, consumer research. However, that is, in our view, the point of this consultation. It is a key issue. We've laid out what we think are various permutations, and we want to see what feedback the public has. If in examining that we feel we need to go out to do further work to gain consumer understanding, we will. But a primary objective with this issue is to ensure that when consumers do choose a sunscreen, they understand how it's regulated. I
understand, and I'm incredibly... I think it was the right course of action to do this consultation. I was very happy with the inclusion of the question of cosmetic regulation, or the demarcation of regulation was included in the consultation. It fantastic. I would say that while it's great to hear that we've had this many submissions, as you pointed out, there's a material difference between the type of feedback you'll get through one of these consultation processes and a piece of a quantitative market research to understand consumer perception of a certain thing. And I would put it to you that because in many ways Australia has done such a good job at the high structural level of regulating sunscreen as an essential medical product rather than a cosmetic substance that it is in other countries, notwithstanding the issues that have brought us to this conversation, the word sunscreen is loaded in the public mind as being something that you can trust to be sun safe, and therefore cosmetic sunscreen equals sunscreen which protects your skin from the sun but has a cosmetic quality. And what we know, because of the differentiated way they're regulated, you can't actually guarantee that a cosmetic sunscreen product has any SPF benefit whatsoever because we don't test for it. So that it's more a comment than anything, but it has a massive red flag for me, that word, for that reason. Thank you for your evidence.
Senator, sorry, I'll just say that we will take that as feedback.
Thank you.
And particularly that concern around the term cosmetic sunscreen.
Thank you very much. I do appreciate it. Now, I've got some questions that follow up on a question on notice in relation to myalgic encephalomyelitis and chronic fatigue syndrome. I've got the question on notice number for you. We did
for the TGA, sorry?
I don't necessarily think it will be for the TGA. I'll give you the reference number. It follows on a list of questions that we asked in the previous outcome that also now need to be asked in this outcome. So the number is SQ26 001295. That's the reference number for the question. And the department advised in the answer to this question on notice that Australia currently has no clinical guidelines for ME/CFS, no formal interim guidance, and no assessment framework of workforce capability. So my question is, given that we have GPs as the main gateway for diagnosis, for treatment, for disability supports, what assurance does the department have that clinicians are receiving appropriate training and using evidence-based reference materials while the national guidelines are under development?
Does the CMO want to start off here, or are there others
Professor
in the room?
Kidd, maybe you want to give us...
Happy to start.
Yeah.
And as we mentioned this morning, Senator, the National Health and Medical Research Council are developing the national guidelines, which you know about very well. These will be clinical guidelines which will assist all clinicians, but including, of course, general practitioners in the diagnosis and management and ongoing care of people who've been diagnosed with ME/CFS, people with long COVID and people with other related conditions. As I mentioned this morning, one of the really essential elements of the development of this work is the close consultation with the peak bodies and with people with lived experience, ensuring that their voices are central in shaping care. As a GP who's worked for almost 40 years and has worked with many people who've been affected by this condition, I look forward to these guidelines coming through and getting some consistency. Having said that already, the Royal Australian College of General Practitioners has a number of specific interest groups which are bringing together doctors who have a strong interest either through the patients they're seeing or through personal interest in looking at developing further standards for care and also for the ongoing education of the workforce.
Yep. Thank you, Professor. And Professor, do you have more to add to that?
Hi, Steve Westling, CEO of NHMRC. I think most of it has just been said, but yeah, we are in the process of developing the guidelines, and the evidence that we have gathered for those guidelines is currently out for external assessment. And once that external assessment has been done and the guideline committee develops further the guidelines, they'll go out for public consultation next year. So it is a bit of a process, but we do want to get it right, and we want to get all the evidence we possibly can.
No, I understand that. I think my concern, I guess, is that we've now acknowledged we need new guidelines, which is great. We're doing the work to make them, which is far past time that we do that. There are some materials that can be drawn on, but the concern is around currently, as we are, what the department can draw on to assure itself of the basic qualifications or competencies of the gateway practitioner, if you like, in many of these spaces. Has the department sought advice from the AMC, the AMA, the RACGP, the RACP regarding the extent of MECFS training provided to clinicians, the resource material recommended to clinicians, and whether those materials align with evidence that is being considered through the guidelines creation process? And if not, how does the department then assess whether the workforce is adequately equipped currently to manage MECFS?
Well, certainly, I'll let the Chief Health Officer answer some of that, but certainly in terms of the work that we're doing, we have consulted all of those organisations and sought and stakeholder input into the process and into our committee. And in fact, our committee contains members of a number of the organisations that you mentioned.
Yes, I do understand that. My question goes to in the interim. So we're in the interim between where we are now and actually having the new guidelines that are urgently needed. So in the interim, what the department has, whether the department sought advice from groups like the RACGP or the RACP regarding basically what they provide to clinicians to make sure that it aligns with the evidence that is being considered by the NHMRC as you work through the guidelines.
Senator, we provide funding for GP training, and the mandatory endpoint of that is registration as a specialist general practitioner with the Medical Board of Australia, which does delegate the accreditation of education programs that lead to registration as a specialist general practitioner to the Australian Medical Council. We're happy to check to see whether or not we've raised this issue with either of the two general practice accredited training bodies, so it's RACGP but also the Australian College of Rural and Remote Medicine, to see what content they have about this particular issue at the moment, and happy to raise with them whether or not there needs to be any changes while the guidelines are under development.
Excellent. And I've just got the wrap-up look from the chair, so I'll just sneak in one last brief question, which is whether I can confirm that clinical guidelines for MECFS they're still currently not expected until March of 2028, is that right? The updated guidelines?
That is correct, yes.
That's the date? Okay. Yep. All right, well then I won't push my luck any further. I'll leave it there.
Thank you very much, Senator Steele-John. We will now break for dinner. Over that period of time, we'll see if there aren't anyone we can maybe give an early mark to, but I make no promises. Thank you very much for your attendance this afternoon, and we will see you at 7:10.